এই ল্যাপটপের এটা অন করা আছে ইপিটা? হ্যাঁ, ওই জন্য আওয়াজ হচ্ছে। বন্ধ করো। অফ করা, আমি খুলছি। হচ্ছে।
It is good morning, persons. My pleasure. C'est lié à la rythmie.
Sir, I can see your
Good morning, good morning, good morning, good morning, friends and colleagues. Chairperson, good morning.
Hello. Hello, check. Hello. Hello, check. Mic test. Hello, check. Hello, check. 1, 2. Hello, check. Hello. Hello. Hello, check. Hello. Hello. Hello, check. Hello.
she's Aloka. Good morning, everybody. Welcome to the second day of the 16th annual conference of the Indian Heart Rhythm Society. We'll be starting the first session at the Dr. Mohan Nair Hall. That is a debate session, and we have Dr. Haigriv Rao and Dr. Vikash Kataria will be joining us in a few minutes. Thank you.
Good morning. Welcome you to the day 2 of the IHRS Con 2024. The first session, we have a debate, Dr. Daljit and Dr. Arun Gopi on cryoablation of AF versus RFA. The way is, we have 12 minutes for the initial presentation for each of the speakers and 3 minutes each for rebuttals. There will be no questions because it's a debate. I request them to keep to the time and also make it sufficiently spicy so that people are all fully awake in the morning.
Spicy.
Dr. Daljit.
Morning. Thank you, IHRS, for the opportunity and having me here. So we are going to talk about cryoablation versus radiofrequency ablation for atrial fibrillation. I'm going to talk in favor of radiofrequency ablation. Do we have a pointer? So we all are actually, at least there is no debate here. We should be thankful to Dr. Hesagre for making us realize that the cause of the paroxysmal atrial fibrillation or triggers are commonest are from the pulmonary veins. We know that particularly if it's a paroxysmal AFib, all the triggers are in the pulmonary vein, and the answer to this is durable PVI. There is no debate. Like if you create a durable pulmonary vein isolation with whatever technology we use, the outcome is good, right? And when you go to persistent also, even in persistent, the first thing we should be doing is durable pulmonary vein isolation, followed by, there is a debate on that what kind of, whether you should do substrate modification, you should do reinduction, all those things. That's a huge debate. There is no clear answer how to go about if it's a chronic persistent atrial fibrillation and you have done PVI, and then how to go, whether to go for rotors or create a lines or do a substrate modification, we don't know. So whatever it is, one important point is here is a durable pulmonary vein isolation. I'll start with the case. This is a 70-year-old male, paroxysmal AFib since last 7 years, persistent since 3 months with lot of comorbidities and the long drug list. We did a cryo on this patient, and you can, best thing to see is persistent atrial fibrillation terminating while doing the cryoablation, and cryo showed that also. Whatever data, all the trials showed that if you use cryo versus RF, termination during PVI with the cryo chances is little bit more with cryo as compared to RF. Later outcome may be the same, but this is what it's beautiful to see. And then you create a map and you demonstrate that it has created a nice pulmonary vein isolation. Mind you, we have recreated the map. We can debate here that recreation of map may not be required, but it has shown that you have nicely isolated the pulmonary veins, and this patient is really doing great. And why the patient is doing very good? Because we are able to create a good pulmonary vein isolation. While searching the data for the debate, I got a very good paper. This is an MRI study in the patients who underwent cryoablation versus conventional radiofrequency ablation. And this ablation was performed with the smart touch catheter, with the touch technology. And this is a cryo group and this is a RFA group. This study showed that with the cryoablation, the lesion width was wider with cryo, the gaps were less with cryoablation, and degree of myocardial injury was more with cryo. That means cryo is better in creating a confluent, a good lesions as compared to a point-by-point technology which is used by the RF. So I think I should put my things down and say that yes, cryo, because it can create a durable PVI, it's far better than the RFA, because here you are using point-by-point technology. I'll show case examples from our lab. This is a paroxysmal AFib who had this patient had a frequent episodes of paroxysmal AFib, 2015 case. This is a lady, persistent AFib, obese, high NT-proBNP, large LA, persistent AFib going on, 1.5 years. This is February 2024 case, and this is 75-year male, paroxysmal AFib, short runs of AFib terminate. And then this is July 2024. I'll come back to these cases. So the first randomized trial, single center, data was collected from 2009 to 12, which showed that they used combined cryo and RF also. And RF, they showed that cryo is faster, obviously, because it's a single shot technology. It is faster, and results are higher single procedure success rate than conventional RFA. This is first trial. Then we all know about fire and the ice, where the data was collected from 2012 to 2015, which showed non-inferiority of the cryo with as compared to the RFA in terms of efficacy and the safety. So this data we are aware, and only thing is after the procedure, atrial arrhythmias were little bit more common, 2.57 with RF as compared to that with the cryo. This is because point-by-point ablation, there may be some leaks, and they were attributed to the incomplete pulmonary vein isolation. Obviously, procedure time is shorter, LA dwell time is shorter with the cryo, whereas the total fluoroscopy time is shorter with the RFA, because it is using 3D here, in the cryo using 2D, and even in cryo many people are using eyes. Maybe combining the 3D, the fluoroscopy time can also come down with the cryo. Phrenic nerve injury is more with cryo across all these studies as compared with the RFA. Some groin complications, not much bothered, as little bit more on the RF side. Secondary analysis, although primary efficacy and safety are same, but secondary analysis showed that with the cryo, there were fewer all-cause hospitalization, fewer rehospitalization, fewer repeat ablation, and cardioversions after the index procedure were less. What are the loopholes here? So we need to go to the loopholes of this trial. So when the trial was going on from 2012 to 15, the cryo balloon changed, like from first generation to second generation. So two-thirds, more than 75% or 75%, they did cryoablation with second generation balloon. Whereas RFA, the newer technology that is Smart Touch, was used in only one-third, 24% of the patient. I think the loophole is here. So next came the Circa dose trial, which is again 8 centers in one country, the data collected from 2014 to 17. Here, they have compared contact force technology, a better technology, with your second generation cryo balloon. And here, RFA stands along with the cryo, saying that there are no progression to persistent AFib in the RF group as compared to some in both the cryo groups, and otherwise the data is comparable in terms of recurrence of any atrial arrhythmias and burden of atrial fibrillation. You can see the data is comparable. So as soon as you improve the technology of your radiofrequency ablation for durable PVI, now your RF is coming along and standing along with the cryo. So now these were all paroxysmal. Coming to persistent, because persistent there is no big long randomized trial. This is a meta-analysis which was published in 2019 of 7 trials, 7 best trials they chose across the world, and they said there is no difference between cryo and RF in the procedural success rate as well as complication. Cryoablation might yield a lower incidence of repeat ablations because again there are some leaks, so repeat ablations are less with cryo as compared to RF. And the sub-analysis showed similar efficacy. But if you go to the limitations, again the same thing. This meta-analysis did not reflect new technology used in the RF. So you're weakening the reliability of these results. So whether they have used the new technology, and when they went to sub-analysis, where the contact force technology was used, there was no difference in the repeat ablations compared to cryo and the radiofrequency ablation. Going back to the MRI study, in the MRI study, it was published in 2019, they used contact force, but if you go to their methodology, they have not spoken how much was the interlesion distance was not defined. What is the blob size? I can make my blob size of 6 millimeter and not bothered and completely, immediately finish the lesion. FTI was not mentioned, force time integral was not used. And force, how much force should be there? Like it was not defined. In Circa they defined like 20 to 40 or average minimum 10 should be there. But in the MRI study they were not bothered whether force, whether the contact, whether the stability, whether the FTI index or the blob size was used or not. This is a very nice, it's an editorial, and these are all the study. It's a nice from the Dheeraj Gupta group, which he said that may the force be with you. So the difference in the RF ablation when we were doing previously than now, like if you have your blob size of not more than 3 millimeter, interlesion size of less than 6 millimeter, if you have given a very good anesthesia, GA, even if not GA, your patient should not be moving. And you can use the different energies. Cryo, you cannot use different energies. It's the same energy across everywhere. In the RFA, you can change the energy on specifically if you go on the vein of Marshall site. When you go on the ridge site, you can change, you can give higher energies, whereas, and the posteriorly when you go, you can decrease your energies. You can give apnea to the patient when GA is given, so that especially when you go near the RIPV, you can give apnea and see the catheter stability. So now this is one of the recent study, PRAISE study, where they use all the ablation indexed technology, and they showed that here the durable PVI was achieved with this new technology in 93% of the patients' PVs as compared to the cryo where 91 is used. And mind you, in all the randomized trial, if you pick up the data, at least 1/3 of the patient you have used backup RFA. Why? Either to touch up or patient has induced another arrhythmia. So I don't know about Western world, but for us here, we are using cryo and then here we are opening RFA also. So you're using both the technologies ultimately. So we need a research to compare the efficacy and safety between ablation guided by index and new RF technologies and your new cryoablation technology. Coming back to our case, this is from our lab, 2015, persistent, this atrial fibrillation was going on. You can see the type of lesion. It's terminated, it's nice output. But you can see we have not defined the type of lesions or interlesion distance and all. This is 2024 February case, lady persistent AFib. You have created a map with the pentaray and 0.1 to 0.3 is the voltage bipolar. You have defined that looks like complete scar. And you can see now the type of lesions you are creating with a better technology. You can see your blob size is smaller, you have defined interlesion distance, and you are very clear that we have not left any gaps anywhere. And the post-ablation you have again created with the same 0.1 to 0.3 volt. You have created the same map and defined that now there is no scar which was looking a huge scar, maybe because that is during the atrial fibrillation. This is the second case, July 2024. You can see it's a nice pulmonary vein isolation performed in this case. And this is the ridge area, which was very thick in this case, lesions. It was not going away, your amplitudes were not, and you can give we have created 2 lines only in the ridge area to make it sure that we have created a proper isolation. And after that, flutter is induced, which was very easily inducible in this patient. If this patient was a cryo, you had to open the RF also to take care of this flutter, although we were lucky this was a CTI flutter and the ablated, but many times we have an LA flutter as well. So what is the limitations of the cryo, which I have already spoken about, is because it's a similar kind of energy you are giving across all these sites. You cannot change the energy in the different walls. So advantages of one-shot technique is whatever energy you use either IEs or a cryo, RF, short duration of procedure, less LA dwell time, lesser risk of leaving gaps in the lines of ablation because it's point by point and that is a single lesion you are giving. Relatively a simple procedure, and I agree it's a shorter learning curve as compared to doing a point by point ablation. So we all are aware, this is my last slide, it's not about cryo or it's not about RF, it's about creating a durable pulmonary vein isolation with whatever technology. Now we are moving towards single shot technology. You talk about PFA, you talk about laser, we have now cryo, we have RF balloons also to create lesions, and now technology is coming to change to flip between the PFA and the RF where we want to change the degree of the depth of the lesions. I'll stop here. Thank you very much.
Thank you, Daljit. Now, invite Dr. Arun Gopi to present his view on the cryo versus RFA.
Respected Chair, friends, at the outset, I thank organizers for the opportunity and this debate between fire and ice. I think Daljit has already given me a heads up saying that cryo is already equivalent to RF, so I just need to show that how it is superior to RF. So, in this therapy for AFib, when your primary intention is primum non nocere, improve function and symptoms of your patient, reduce stroke morbidity and mortality of your patients, I would rather prefer to do this with hypothermia, ice formation, extracellular, intracellular, with apoptosis and necrosis, rather than having a lot of heat and direct cellular injury. Now, let's start on with where Daljit said. Let's start on with evidence. Head-to-head trial, largest multi-center head-to-head trial between fire and ice. The primary efficacy endpoint, almost non-inferior. So cryo was said to be non-inferior to RF. You see the graphs, cryo is slightly more superior, but it's again statistically non-significant. But okay, efficacy, we agree with what Daljit said, they are equivalent. Now, what is more important to the patient? You look at the advantages that cryo gives, what probably Daljit didn't want to say, that was 34% fewer cardiovascular hospitalization, 33% requirement for lesser repeat ablations. That's what made the authors say. The extent of reduction in re-interventions and re-hospitalizations is not only statistically significant, but also clinically relevant. So this is one thing that your patients really are looking at. Patient's perspective, this is the most important aspect. Re-interventions, re-hospitalizations, which is definitely lesser with cryo, and that is statistically significant. The second aspect is about safety. You look at the complications. All complications are numerically higher with RFs, be it groin complications, be it post-op tachycardias, be it perforations or cardiac tamponade. All are numerically higher with RF. Only thing that is higher is phrenic nerve injury. Daljit definitely said that 2.7% is the phrenic nerve injury, but what she didn't say is how much resolves. So almost at the end of 3 months, only 0.5% was unresolved. At the end of 1 year, it's only 0.3% who is unresolved. That is 1 out of 374 patients who underwent the therapy, which is almost minuscule kind of a complication. So you have a complication which you are talking about cryo, which is fully reversible. So the key takeaway with fire and ice was cryo was non-inferior, but the most important takeaway was it has a favorable safety profile. It has lesser procedure times, which Daljit also agreed. It has lesser LA dwell times, which is a very important factor when you're doing with AFib ablations, and lesser requirement for repeat ablations and re-interventions. Now, if you feel that that was not done with Smart Touch, as she said on, there was circa dose trial. Again, Smart Touch versus cryo 2 minute and 4 minute cryo. Again, there is no difference, equivalent efficacy. But if you see the graphs are slightly favoring cryo 2 minute protocol. But again, they are not statistically significant. But always, if you see by numbers, there's always the circa dose also says that it's although non-inferior, but there is a better reduction with the short cryo protocol. Now, if you think that all these trials are not sufficient, you want to see what happens really in our real life scenario. Obviously, these are trials done in the best Western centers. We don't have that much expertise. What cryo to your patients mean in India would be a safer procedure, a procedure which is more effective, versatile, more consistent and more reproducible. So with RF, you know that myocardial temperatures greater than 50 are required for irreversible myocardial damage, and lesion size is proportional to the temperature that you achieve at the electrode tissue interface. There's a lot of things variable in this actually. If you look at So if you look at atria, this is the autopsy of the atria. Atria are really thin-walled structure. So there's a lot of complications you have with RF because of its unpredictability. As she said, there are numerous variables which you need to be dealing up with. You need to give GA. You need to put them on apnea. You need to get a good contact. All of them you'll have still a lot of thrombus formation, you have a lot of collateral injuries, there's a significant amount of difficulty in the stability that you need to get the catheter in contact with the left atrium. And although a mapper would give you a beautiful set of lesions, in life you know that inside the heart, that's not the set of lesions that develop. On the other hand, you have cryo, which is reversible. If you're not in the right site and you feel that you're not done properly, you can always reverse the loss of electrical function by temporarily stopping the cryo and warming up the tissue. So you have a therapy which is fully reversible, although it's one form of therapy. So reversibility is a major advantage that cryo gives you. And the other hand, if you look at the LA lesions that RF and cryo does, if you see cryo, it actually preserves the extracellular matrix, maintains the endothelial integrity, less chance of actually thrombus formation. So you see the lesions formed by RF and cryo, you want your patients LA to have these kind of lesions with endocardial damage, thrombus formation, or you want a well-demarcated lesion with minimal thrombus, endocardium not altered. And the beauty of cryo is the balloon adheres. So it's not your experience that is going to give you stability. The cryo adherence is going to give you excellent stability and good contact. So the major things that I said, safer procedure, all trials, cryo first, stop AF, early AF, all say that cryo is safer. And the major, when you say about safety, all complications are unfortunately higher with RF. That's why it's said to be safer, because you have groin site issues, post-op tachycardias, cardiac tamponade, and a complication, only thing numerically higher with cryo is phrenic nerve injury, which is majority of time reversible if you have done it properly. Now, the second aspect of cryo for your patients is it is effective and versatile. So when we say effective, you see the single procedural freedom from AFib or atrial tachycardia is 80 to 90% in across centers. And if you look at 2 years, the durability of these lesions is almost 75%. This is from the STOP AF past results. And if you look at the PVI lesion durability, you know that durable transmural lesion is the most important target when you're doing PVI. And if you look at the durability of lesions with cryo, you have a 78% durability, and with RF, the durability is dismally low. And this has been shown consistently across trials. You name the trial, Fire and Ice, Stop AF, you say Stop Persistent AF, you say Cryo First, all early AF, all these trials show consistently that the efficacy is consistent with cryo across large clinical trials. So efficacy-wise, there is no doubt. Now, when she said that it is only limited to PVA, no, they have gone a step forward. You can use cryo now for substrate modification, the LA. You can use it for posterior wall isolation. This has all been well described. So cryo is not to the pulmonary vein alone. You can go definitely beyond pulmonary veins with cryo. Now, the other important thing is consistency of the therapy and the reproducibility. Now, let's be true to ourselves. We are talking about the Western data. What would you quote your RF ablation success rates? It might be between 14 to 91%. What would your complication rates be? 2 to 12%. So there's definitely an RF learning curve. If Haigrip sir would have done an RF, would he be comfortable handing over the RF catheter to his fellow and ask him to do an AF RF ablation? On the other hand, with cryo, he would do that. Our AF, our radiofrequency ablation, has a higher learning curve, and the outcomes are definitely operator experience dependent. But on the other hand, cryo ablation is very efficient, very predictable, does not depend upon the operator's experience. And if you are in the hands of my mentor, like Dr. Narasimhan, I would say that he would be a gifted hands who could take away with the variables of AFib RF ablation, like the catheter motion. You can see the pictures actually, the catheter, the effect of the heart motion on the catheter, the reliability of the energy delivery, the lesion formation, the potential complications that can happen with RF. All of these things would be really mattered by the operator's experience. On the other hand, you see the French AF study. So seeing this, you can see the operator experience between RF as well as cryo. So in 6 centers, even an experienced operator and a non-experienced operator can give equivalent results because there's a shorter learning curve, higher reproducibility, and less operator dependence. So me and Daljit can equally smile to our patients and say that we can give you equivalent results if you're doing cryo. And the most important aspect is patient and staff satisfaction, because all the analysis have shown that cryo definitely improves quality of life. The most important aspect, as I said, it leads to lesser re-interventions. 33% fewer repeat ablations, 53% requirement for fewer cardioversions, 53% requirement for rehospitalization. And that is what cryo offers: predictable patient outcomes, better quality of life for the patient. This is what patient really is looking forward to. And if you look at the lab workflows, with cryo, it's a very predictable procedure. You know exactly how much time you're going to take it. There are not much variables. You're not going to fool around. You have definite things to do. And so with the cryo, you can really plan your time. And if you're in a busy lab, you can clearly schedule your time, and that will make the workflow more efficient. You can do it with moderate sedation. You can actually ensure a same-day discharge. All of these things actually are going to improve patient satisfaction and improve the workflow of the system. And if you have a triad of cryo, ice, and electroanatomic mapping, probably you are going to do all of these AFib ablations, zero fluoro, and probably going to step into your lamps without lead aprons, which would be the dream for us. And technology is actually advancing in a faster pace. You have newer innovations, and these things are, as I said, are going to become better as newer and newer innovations are going to come in this arena. So I'll just end up with some of the case scenarios. So this was a story of a 55-year-old doctor. He is a doctor known to many of our cardiology colleagues as well. So he had repeated hospitalization, paroxysmal AF, treated with amiodarone, took amiodarone for a long time, developed all sorts of side effects of amiodarone, took off amiodarone, put on flecainide and metoprolol, maximum tolerated doses. LA is 39. LA is not dilated, but repeated episodes. He, in fact, had to leave his job because every time he does a surgery, he gets paroxysms of AF, had to actually leave his profession. He underwent twice radiofrequency ablation for AFib, one from senior experienced operators in our country, across our country, but unfortunately still continue to have episodes of AFib. This is the true story of radiofrequency ablation for AFib. There's a significant steady learning curve for AFib, and that's why we're not able to give the predictable results that are being demonstrated in the Western trials that say about AFib RF ablation. So this unfortunate doctor continued to have symptoms despite 2 radiofrequency ablations, had very impaired quality of life, had to leave his job. And that's when he came to us. What we did is, that's when we got in the RF console. So we got in the cryo console. So we did the procedure under conscious sedation. You can see the esophageal temperature probe placed in. From the right femoral, single groin axis. So we have 3 axes. We take a transeptal puncture under full heparinization with ICE guidance. You can see the ICE guidance on the other side. So you don't need any arterial stick, no aortic reference required. With an SLO BRK needle, with an electrocautery 40 cut, there is no mechanical pressure to puncture the septum. We get across the intrathecal septum. Since it's all intracardiac echo guidance, we actually give full heparinization prior to the puncture and maintain the ACT between 350 to 400. And we get into each of the veins, define the anatomy. We've not done a CT in this case, so we define the anatomy with an angio, and then go on freezing each of the veins. So you can see the cryo console freezing, and on the lower part you can see the electrograms. You can see the sharp pulmonary vein potentials dissociating and actually disappearing as early as about 20 seconds. So 20 seconds of freezing is sufficient for the pulmonary vein potentials to go off, but we would still go on to give about 3 to 4 minutes of freeze in each of the veins. So in this doctor, we were able to freeze all the 4 veins. Each of the veins were freezed by about 3 to 4 minutes. The fluoro time was about 15 minutes. The whole procedure time was 50 minutes, which would have been a dream for a radiofrequency ablation for us. The LA dwell time was 28 minutes, which is an important predictor of future risk of stroke. This doctor was discharged on day 2, absolutely asymptomatic after that. We're on minimal drugs, just on anticoagulants, and is back to work. So this is the improvement in quality of life that cryo does for failed RF ablation. And this is what our experience has been at our center, Metro. We have, since the inception of cryo, since October 2021, we have done about 60 cases of cryo ablation. 49 were for paroxysmal, 11 were for persistent. Even for persistent, we end up doing a cryo PVI. The median age was 54. The procedure, acute. During the procedure, we are almost able to get pulmonary vein isolation, 100% of cases. We had clinical recurrence in 3 out of 60 until the follow-up that we know about, which is about 5%. No major complications by God's grace, only a transic phrenic palsy, which happened in one person had hemoptysis. You look at the fluoro time, average fluoro time is only 25 minutes. Procedure time is close to an hour. We use intracardiac echo in all of our cases, ultrasound for vascular access, and 3D mapping in about 80% of cases. And average LA diameter is about 39 in these cases. So since we have got cryo, we have fully shifted to cryo, and that's what the whole world is also doing. You can see I'll almost conclude now. The whole world is actually shifted towards cryo, and if me and Daljit were together in our fellowship period, so when our third colleague Mandar asked me to describe Daljit, I would say that Daljit is fast, she's consistent, she's very efficient, she's a very safe operator. That's what I would say to my patients when he asks about cryo. Cryo is a safe procedure with less collateral damage, more effective, more versatile, more consistent efficacy, very reproducible results, excellent overall procedural success, very fast, shorter procedure time, lesser post-procedural complications, better patient satisfaction, lesser recurrence, and you will probably be able to do it even with zero fluoro. That makes it our first line of therapy for paroxysmal and persistent AFib. But leaving science apart, when two friends debate, I would say that this would be a concluding statement. AFib ablation can be performed with cryo balloon or irrigated radiofrequency ablation according to the operator's preference, skill, with similar anticipated outcomes and similar favorable safety profiles, provided you are getting more and more experience with RF. Thank you.
Thank you, Gopi. I think you have put a cryo at a very striking situation. Now, Dr. Daljit would like to give a rebuttal why RF is now. I feel that you should not be so considerate and give a very balanced picture like you did in your initial thing.
No, it's not about debate. It's about the real world, because if someone wants to take a message from here, what message they should take, I think that's more important. Coming to the learning curve of RF versus cryo. See, you see the Indian, everyone, this company guys comes and say that how much AFib ablations we are doing in our country. It's very meager as compared to the Western world. Their only work in the Western world in electrophysiology is AFib ablations. So for them, if you call any Western world who are doing AFib ablations, I think they'll do in the same time we are doing cryo. They finish the case in 1 hour and also. So I think learning curve is because we are not doing so much of AFib ablation. That is one. Secondly, Arun spoke about zero fluoro. He showed Devi Chechi, and she's the same lady who does even RF with zero fluoro. So it depends upon this. So she does all her 3D cases with zero fluoro. So I don't think zero fluoro, it's rather fluoro time is in our, we who are not doing with zero fluoro, fluoro time is more with the cryo as compared to RF, because RF we are using 3D. But if you want to, second thing is, he didn't speak about all the trials. I agree with the trials. Again, I'm saying all the trials are done with the previous technology of RF. Now the new technology of RF, where you're using a touch technology, I've shown all the things. If you use all the technology and now you compare the RF, the only answer is a durable PVI. RF is not able to give durable PVI. If RF is able to give durable PVI, your results will be better or maybe same, whatever it is. So next he said about cost. I think we should be talking in our country, because cost differences, we know it is there. It may not be there in the government institute, but for us. And secondly, 1/3 of the patient in all the trials also, despite of using cryo, they have opened RF. I don't know how much for us it is feasible to use both cryo and the RF. If your patient is well affording, yes, go do PVI quickly with the single touch technology, and then you open RF for your other modalities. Last but not the least, technologies, it's not about cryo RF, it's more about single shot technology. If your RF comes with the single shot technology, I think we will be able to answer better. Thank you.
Yeah. Dr. Arun Gopi, now it's your time for rebuttal.
So okay, let's all start off from now. Let's all start radio frequency ablation RF learning curve, and let's take another 10 years, learn this technology. By that time, I'll tell you, PFA is going to come in, and PFA is going to change the world. And probably we are going to have hybrid catheters. So let's probably start learning the hybrid catheters and start how we can do these procedures in shorter developed times. And rather than opening two technologies, cost, as Daljit said, yeah, at the moment, any newer technology coming in cryo, unfortunately, our part of the world, everybody ignores. Medtronic ignored us for 10 years. They came after 2010, they launched cryo worldwide. 2020, they came with cryo to India. So that's unfortunate thing that happens with all of the EP technologies. Rhythmia, again, has not come in. Many of the newer higher-end RF technologies have not come in. So this is all things that I would say that is beyond us. But let's be true to our patients, actually. Let's tell them really what we can offer to them. What with our expertise we want to give them is a durable transmural lesions for during a PVI, which would give him good long-term outcomes. And at this point of time, with the technology that we have, I still feel cryo is a much safer and effective therapy for our patients to ensure that there is a durable lesion. And regarding the cost, again, as I said, if you, most of our settings, we would have a 3D patch opened up because we have cases clubbed together. We use a patch. We don't follow the US economics. Our patch would be shared between different patients. So anyway, the patch is opened up for another patient, and that's the same patch that is used for even for the cryo. And the catheter, again, we are not opening up a new catheter. You're again opening up your flexibility, which is already there in your card. So none of the additional cost comes with RF if you're combining RF with cryo. But all said and done, we need to really improve our therapy for AFib. The key message, as I would say, is that let's not ignore AFib. Let's not say that it is PVI is not that what is need to be given. Let's not ignore patients with heart failure and AFib, saying that AFib has to be managed medically. We are actually ignored and neglected AFib for almost decades. That's where the West went ahead of us. We should really target AFib. We should really get and ensure that we are doing PVIs regularly so that our next generation actually have the equivalent expertise in doing PVI, whether it's RF, cryo or PFA, equivalent to the West.
It's a very lively debate. Thank you very much, both speakers. Generally, there's no question, but Dr. Ashish, you want to ask one question? Just to give an exception and make one question. Can you take the mic? Come forward.
Thanks, Dr. Haigreve. To both Arun and Daljit, I want to ask this. I like the conclusion of Dr. Arun about how we still got in RF and showed its role. So, if you were to have a randomized trial, would you like that trial between PFA and RF or PFA and cryo? Or would you like a 1-to-1 randomization with all three included to give you the answer?
I would like to have a trial of single shot technology to single shot technology. So you have RF also with single shot technology. So you are trying to combine point by point ablation technology with the single shot technology. If it's a real trial, the trial should be single shot technology comparing the, if you are really comparing energy. So single shot technology of RFA, PFA and the cryo.
So my thoughts are, let's just have the hybrid catheter, learn that catheter well, learn how to use it well, and do the same thing repeatedly rather than shifting from one technology to other. And if you're doing the same thing repeatedly, your learning curve is going, your expertise is going to be better, and you're going to definitely give durable PVIs for our patients, which is what ultimately matters. It's not the energy that matters, it's not what you're using that matters, it's a durable PVI that matters. So let's use one technology. Probably it's not a long time before Afera or something comes up with a hybrid technology of PFA and RFA or PFA and cryo. So once let's have this hybrid technology and use it and learn it and repeatedly reuse it, ensure that our learning curves come down.
Any other questions? So there are no questions. These are two different technologies, and both have their own advantages and disadvantages. Ultimately, it comes to operators' preference, patient safety, and the procedural outcomes. So with this, I would like to conclude the session and move to the next one.
Thank you so much, Chairperson. And to our speakers also, we'll move on to the next session. As Chairperson, I would like to invite on the dais Dr. Avinash Verma, Dr. Kartikeya Vargav, and Dr. Praveen Srikumar on the dais, please. Thank you so much. Welcome, sir.
I think the first talk is an optimal management of AF symptom base by Zhong Tu Choi.
Okay, thank you, Mr. Chairman. And I'm Jong-il Choi from South Korea and the Scientific Committee Chair of Korea Heart Rhythm Society. My topic is optimal management for better symptom control in atrial fibrillation. As you know, the atrial fibrillation, most common cardiac arrhythmia, has a huge impact on the patient symptom and adverse outcome. And also, the burden in healthcare system is very important more and more. The expected healthcare burden is 1 or 2% in overall nationwide healthcare expenditure like this. The guideline recommended symptom management, the rhythm control and the rate control is most important beside the anticoagulation and ACC/AH and ESG guideline. I am focused on the reduced symptom by rate and the rhythm control in like this, and this is including the antiarrhythmic drug and the catheter ablation and the surgical ablation like this. First, I would touch on the rate control. This is a case in the male 67 patient and the dyspnea in the Nair class functional 3 and 1 month ago. Echocardiography showed the LV ejection fraction in the 30% like this, and the EKG showed the atrial fibrillation with the left ventricular response like this. What is your choice in terms of rate control in the decoction and diltiazem, adenosine, the antiarrhythmic drug? As you know, this is the latest 2 clinical trial, most important landmark clinical trial in the lenient rate control, less than 110 beat per minute resting heart rate is equivalent to the strict control like this. And so lenient control is acceptable in current practice and guideline. And so, however, as the ESG and AH guideline recommend the LV ejection fraction based guided in the rate control strategy, and the LV ejection fraction less than 40% in the beta blocker or decoction is the first choice, and the higher the 40% is we can use in the diltiazem or verapamil. What is your the opinion? And so, although the evaluation of LV ejection fraction is crucial for deciding the rate control strategy in patients with atrial fibrillation, however, the real-time assessment of LV ejection fraction is limited in the outpatient or primary care setting. In addition, there is no RCT data about supporting the use of beta blocker for heart rate control in atrial fibrillation. I would like to introduce our data, the recent publication. This is first in the deep learning algorithm like this in the AITI LV dysfunction, and this is LV systolic dysfunction prediction using AI, and showed the AUC 0.777, and the negative predictive value is 0.882. This is superior, the better, compared to anti-pro-BNP, the predicting LV systolic dysfunction in this data. And so use of AI-based algorithm may facilitate the prediction of LV systolic dysfunction, and earlier choice of drug, the rate control, enable better symptom control in atrial fibrillation with the left ventricular response. I would like to order my data in the rate control, and this is a multi-center randomized clinical trial participating in 20 institutions in South Korea, and the beta blocker and the carvedilol showed a significant reduction in heart rate compared to the after six weeks, and however, placebo showed no effect in the heart rate reduction. And also, this is a Holter-based data, and daytime showed it is heart rate reduction is effectively reduced, but nighttime is there is no bradycardia and any other side effect. And so we conclude that the beta blocker is very effective and safe in control the heart rate control. And so in this case, so let's back to the case, and the carvedilol and the digoxin showed good rate control the result like this. Next topic is rhythm control. This is a case, male 67 patient, the LV ejection fraction is 45%, half the reduced heart failure, mildly reduced ejection fraction. And so fast history showed that proximal LA did 80% stenosis, and he underwent in the PCI 2 years ago. And EKG showed the atrial fibrillation rhythm status, and after cardioversion in the sinus rhythm like this. And as you know, East AF4 trial is a very landmark clinical trial. Is early rhythm control showed very beneficial to reducing in the composite cardiovascular outcome compared to usual care. And what is your choice in the antiarrhythmic drug before the catheter ablation? Like this. And this is the ESC guideline. And as you know, in case of coronary artery disease and the heart failure, preserve the ejection fraction and the significant valvular disease, and we can choose the amiodarone and dronedarone first in the case of this patient. And how in other hospital, in the doctor prescribe in the dronedarone the first choice, and the rivaroxaban 20 milligram standard dose after cardioversion. However, he experienced in the ocular hemorrhage and the GI bleeding, hematuria, and also recurrent significant hemorrhage like this. And so, as you know, the dronedarone is the drug-drug interaction, especially in the rivaroxaban and the edoxaban and NOAA. And so the bleeding risk is higher. And so we he transferred to our hospital. We stopped the dronedarone and we changed the amiodarone. And however, the sinus rhythm maintained well, but the 1 year later, and we followed the pulmonary function test within DLCO. DLCO showed in the dramatically reduced in the over 100 and to the 64. So as you know, this DLCO is the reduction of DLCO is one of the critical signs for the potential risk of idiopathic pulmonary fibrosis. And so we cut amiodarone and we try to catheter ablation in this patient. And this is our data, and the amiodarone is very showed in the very many kind of side effects, and so amiodarone is associated with increased mortality compared with the other antiarrhythmic drug, 1C or dronedarone, in new onset atrial fibrillation patient like this. And so this effect is especially in the higher in the female patient compared to men patient. And also, the 1C drug is also showed the other side effect. This is our published data. And the antiarrhythmic drug is also associated with the syncope and pacemaker implantation in patients with atrial fibrillation. In the hazard ratio is 3.6-fold increased risk of pacemaker or syncope. So, and in this patient we can try in the catheter ablation like this. Catheter ablation is widely used especially in drug-resistant patient. And so guideline also recommend in the catheter ablation class of recommendation 1 in patient with drug-failed patient and heart failure patient. However, atrial fibrillation, the cause of atrial fibrillation very multifactorial cause, and alcohol and diabetes and hypertension. And so this the many multifactorial factors affecting the substrate remodeling. And so the genetic predisposition is one of the cause of recently published. And so conceptual framework is genetic predisposition is like this, and involved in the atrial fibrillation genesis, and especially in lone atrial fibrillation and persistent proximal atrial fibrillation rather than persistent atrial fibrillation. And so our question is that whether genetics and genomic data can predict the clinical outcome in terms of catheter ablation. This is our data, and previously published in the single nucleotide polymorphism combining the biomarker and the TIMP1, and this is significantly associated predict recurrence of atrial fibrillation, especially in proximal atrial fibrillation. And however, there are many data related to the genetic variant in like this in globally, and including Korean data. And most data included in the patient with average age of about 60 age, is a little bit elder patient. And so we investigated this effect of SMP in a patient with very early onset atrial fibrillation before the age of 40 years after catheter ablation like this. And we analyzed in the 16 single nuclear polymorphism in the young Korean population, early onset atrial fibrillation like this. And we discovered in the 3 SMP were significantly associated with the recurrence of atrial fibrillation like this in the SOX5 and the ZFHX3 and the TBX5. And especially interestingly, when we combining this number of risk allele, there is significantly incremental progressive value regarding the freedom from recurrence rate. In summary, and to reduce symptom by rate control and rhythm control is a mainstay in treatment of atrial fibrillation. However, there are still concerns in real-world practice. And based on our data, and the deep learning algorithm may facilitate prediction of LV systole dysfunction, earlier choice of drug enabling better symptom control. Listen to our data, confirm the beta blocker is effective in reducing heart rate, and antiarrhythmic drug therapy is associated with the syncope and the pacemaker as a various side effects in atrial fibrillation. Among them, amiodarone is the most important drug, and this is associated with increased mortality compared to the other antiarrhythmic drug. Emerging evidence in genomics help inform decision regarding genetic testing in patients presenting with early onset atrial fibrillation like this. And finally, I would like to introduce in the Korea Heart Rhythm Society next year, similar will be held in the June 2025 in Seoul, and I'll see you in the later. Thank you.
Thank you, Dr. Choi. Wonderful overview of symptom management of atrial fibrillation. A couple of comments before we open it for the audience. One is what is your threshold of doing cardioversion as a means of symptom control in patients with atrial fibrillation and fast ventricular rate? And maybe you can answer this, then we can have the second.
Cardioversion?
Yeah.
Electrical cardioversion. And we try to cut electrical cardioversion in persistent atrial fibrillation, especially in the patient with a long duration of atrial fibrillation. Patient cannot, it is difficult to feel their symptom, and so the cardioversion is at the patient in the most beneficial in patient with persistent atrial fibrillation. However, the cardioversion is not just in the palliative and not curative in the rhythm control strategy. And so in this patient, failed patient, we consider in the catheter ablation patient with failed cardioversion.
Okay. Any questions from the audience?
Yeah. See, 2 questions. One is that do you do gene testing for all your patients for AF? Do you do genetic testing for all your patients or AF or selected patients?
Genetics.
Yeah.
Okay. Yeah. And that's a very important question to our clinical practice. In the 2011, in the ESC and the EHRA guideline recommend in the genetic testing, not recommended usually in clinical practice. And 2022, and genetic testing can be recommended in the patient with the less than 60 years old patient, considering in the clinical symptom and echocardiogram data. And so less than 60 years old, we can consider in the genetic testing, and gene-associated atrial fibrillation is the most common cause is TTN, and KCNQ1 loss of function. That's the current guideline recommendation.
So another question is that in long persistent AF, long persistent means more than 1 year of atrial fibrillation. So what are the factors which you take into consideration for deciding that you want to have a rhythm control in these patients versus the rate control?
Yeah, I think it's there in the guideline there is no definite the recommendation about the management of permanent atrial fibrillation. In the permanent atrial fibrillation definition is that the negotiation and some consensus between the patient and the physician. So, however, is now in the ongoing studies the investigating in the how can the rhythm control strategy in the effective in the permanent atrial fibrillation, and when you try to the cardioversion and
no, I'm not asking permanent AF. I'm asking long persistent.
Long persistent.
Yeah.
I think it's a similar. The definition is one longer than 1 year. The permanent atrial fibrillation. The permanent atrial fibrillation, long-lasting, long-standing atrial fibrillation. I think there are some overlapping the zone. So the long-lasting, yeah.
Do you consider the age? Do you consider the left atrial size? Do you consider comorbidities in that patient? Do you consider what are those points where you want to convert them to normal rhythm versus you will accept it as a permanent AF?
Okay, yeah, that I think that I agreed with your comment, and still there are some gradation between the long-standing persistent AF and the permanent AF. However, is the most important factor to decide the rhythm control strategy is the patient symptom, this topic of main topic. And so after cardioversion in patient with long-standing atrial fibrillation, patient to feel it improve of symptom after cardioversion, I think this patient is a very good candidate to the rhythm control, including catheter ablation.
I think we'll move on to the next session. I think it's a E session. It is Jonathan Coleman, and it's on PVI ensuring durability and efficacy index.
Good morning. Can you hear me clearly?
Yes, you are well heard.
And you can see my slides. So firstly, what a pleasure it is to be speaking at IHRS again, 2024 in Kolkata, even if I am speaking from home in Melbourne, Australia. And I'd just like to very much thank the organisers for inviting me to speak on this subject, which is obviously of critical importance. Now, I'd like to take us back a little bit to begin with and just recall that landmark paper that we all know so well. 1998 now, hard to believe that it is 26 years ago, over a quarter of a century, when Michel Hassaguer and the Bordeaux group described the triggers in these muscle sleeves originating in the pulmonary veins. In those early years, we tried not to isolate veins, but to target these foci individually, and that obviously did not prove to be particularly successful. This is the pathology study that we all went back to. This first study describing these sleeves of muscle onto the pulmonary veins, Nathan et al., circulation 1966. In the 30 years plus between this paper and this paper, the pathology paper garnered precisely 3 citations, and in the quarter of a century since, over 600. So you never know when your work may well be recognised, when its importance may be recognised. I'd also like to just talk a little bit about the evolution of our approach to PV isolation, because we started out, again, the landmark work of the Bordeaux group, doing segmental isolation of individual muscle fibres using the lasso catheter map, but well inside the ostium of the pulmonary vein many times. We progressed to antral with the work of Carl Cook and others, and to antral with the CT anatomy overlaid, the work of Andrea Natali and others. And starting to look something like what we do nowadays. And of course, the goal is this. Everybody needs this slide in their slide set. The atrium in sinus rhythm, the pulmonary vein still fibrillating with a cycle length here of 110 milliseconds, something we used to think was unphysiological. I'd like to take you to this paper. This is a paper that we published now back in 2010. And we looked at AF outcomes in patients undergoing lung surgery, and we compared those undergoing thoracic surgery, those with double and single lung. And what we observed that in very long-term follow-up, over 10 years, there was almost a zero incidence of AF following double lung transplantation. And all of the patients who had AF to begin with no longer had the atrial fibrillation, whereas there was significant incidence of AF in the other two categories. Now, don't misunderstand me. I'm not suggesting we move to double lung transplantation, the management of AF, but I think it really emphasises how well we can do when we achieve wide antral, durable wide antral isolation. Let's look at what the guidelines in 2017 told us. They said to us, you have to isolate the veins, you have to demonstrate entrance block. 20 minutes of monitoring, maybe, 2A, probably ought to do that. Adenosine, pace capture, demonstration of exit block, all 2B may be considered. Let's fast forward now to the 2024 document. And all that remains still, electrically isolate the veins and demonstrate entrance block. Everything else is an area of uncertainty. Should we wait or not? Adenosine, many of us no longer have used that. Pace capture along the line similarly. So we're really just left with electrical isolation and demonstration of entrance block. But if we look at trends over time, and this is a lovely meta-analysis that looked over more than 2 decades at improvements in published outcomes and showed, this is persistent AF, you can say the same of paroxysmal, every 1 year increase in publication year, there was a 1.8% improvement in outcome, and it had nothing to do with additional lesion sets. Indeed, there was a non-significant trend to worse outcomes with addition of further lesion sets. What is this telling us? It's telling us something about the evolution of technology, and together with that, the evolution of our understanding. And with that, we saw reductions in procedure time and reductions in fluoroscopy time. Now for RF, the point by point, I think the major leap forward came driven by technology and the excellent work of Matthias Deutschhaber with the closed protocol, using interlesion distance to ensure overlapping lesions, using ablation index, contact force, stability, duration, power to achieve irreversible pulmonary vein isolation, or durable, if you will, pulmonary vein isolation. And with that, first pass isolation went up to close to 100%, adenosine-proof isolation went up in this early work, and also freedom from atrial arrhythmias in this observational study, not a randomized study, but really a very important advance. Now, I was listening to the debate. I was very impressed by the speakers, but I'll put my 2 cents worth in whichever data you look at that's prospective and randomized. In terms of outcomes, there is no difference between RF and cryo. We saw that in FIRE and ICE. We saw it in Circadose. Circadose was really interesting and important, and there's no trend. They're overlapping curves, but they're disappointing, right? Paroxysmal AF in the low 50s for outcome at 12 months, but then we look over here at the post-ablation burden, median 0, 0, 0. Using the 30-second outcome, we have significantly undersold our ability to improve outcomes in patients with atrial fibrillation. Now, these outcome studies oftentimes are the best we can do in terms of understanding durability of pulmonary vein isolation, because we don't have a huge number of studies that have brought patients back. This is one. 26 patients that came back for a mandated redo procedure at 6 months. 58% of patients had all 4 veins isolated If we looked per vein, it was in the 75 to 80% range, approximately, persistently isolated 76, 81. The right middle is just 3 veins, so really not very accurate data. And this is really what we can do in the era of the closed protocol. This randomised study from Jim Hansen's group in Copenhagen also mandated restudy and showed something very similar, but also compared cryo in blue with RF in red and showed no difference in per vein persistent durable isolation and no difference at maybe a disappointing 47% in per patient durable isolation. If you add 3 veins isolated, that jumps up significantly, but it's still a little sobering that that's what we can do with modern technology. And the data looks a little worse if you look at studies that have brought back patients with myocardial scar. This is one where the myocardial shell had close to 50% low voltage areas, and they looked at 17 cryo and 21 RF patients coming back for a 2-month mandated repeat study and showed a high incidence, almost 60% in the cryo group, 40% in the RF group. No significant difference, maybe a trend to those patients with scar doing better with RF, but a trend only. And as I said, all of the outcome data really can't separate the outcomes in those 2 technologies. What about high power? So everybody has a different definition of high power. Let's start with 45 watts compared with control of 35 watts using the closed guided PVI. This is from the group of Matthias Deutschaber. No difference in first pass isolation, no difference in adenosine reconnection, 6-month recurrences, also not different between high power and standard power. Procedure times shorter with high power, RF times shorter with a higher power, but maybe just this sobering finding. 1 case only, but it's a small study, 48 patients. This is with the high power. This is a deep ulcer that actually required esophageal stenting and maybe just gives us a little cause for pause using high power on the back wall. Here's another similar study, prospective multi-center study, 50 watts versus 40 watts for paroxysmal atrial fibrillation. Again, no difference in complications. Certainly we see again procedure times shorter, total RF time shorter, first pass PVI a little bit higher with high power in this study, but the overall AF symptoms and outcomes at 12 months, no difference between those 2 groups. So if high power can't improve our outcomes, perhaps we turn to different technologies. And this is an early study with the lattice catheter, the Sphere 9. This is an RF study though. This is not a PF study. This is RF looking at PV durability in patients who came back for restudy, I think at around 3 months. Striking PVI durability, approaching 100%. Linear block, roof lines, isthmus lines, when have we ever seen that 100%? Even very high numbers for the mitral isthmus line. Provocative data, small early study. This is the Sphere with RF. The Sphere now can deliver RF or PF. And here is the recurrence rate, 94% freedom from AF in a small study, 65 patients at a year. So maybe this is where we start to see some benefit, new technologies. And as we talk about new technologies in this era, of course, we have to think a lot about pulsed field ablation. And you've all seen this slide from the work of Vivek Reddy, these short pulses which rapidly isolate the veins and produce these lovely voltage maps, even at 3 months. And this is an early study. The procedure duration is much longer than it actually is. The complication rate's very low. But it's this that I want to bring your attention to. Yes, safer for the phrenic, safer for the esophagus. But if we look back at all of the studies that brought RF patients back, brought cryo patients back, we never saw anything like what this study demonstrated with PFA, with approaching 100% persistent PV isolation. Again, this is the early data. This study showed the evolution of the waveform from monophasic to biphasic to optimized biphasic with increasing PVI durability. This is 96% per PV, 84% per patient, translating in the red with the optimized waveform into these very excellent freedom results of freedom from AF. Again, observational data, impressive, but still early. Here's some real-world data. This is from the Euphoria Registry, recently published 2024 study. 1,184 patients, and these are restudies in patients with recurrence. So it's a selected group. 23% recurrence rate, of whom only 12% actually was sufficiently symptomatic at that point to require a procedure. And in that 12%, 71% of PVs were durably isolated and 38% of patients, fairly consistent numbers across the PVs. So a little more concerning, but of course, this is the selected group with recurrence. Now that early promising data about outstanding PV durability in randomized studies has not as yet translated. Here's the ADVENT study. Again, we've all seen this, published in the New England Journal. Absolutely no difference in time to AF recurrence between pulse field and standard thermal. No significant signal for difference in serious adverse events. And similarly, the dual and energy lattice tip ablation randomized trial, the investigational sphere using either PF or RF, PF dominated, versus standard point-by-point RF in the grey here, the control group. And you can see there's a clear trend which did not quite reach statistical significance. So I think we need to watch this space a little more closely. Energy application time shorter, as we've seen, transpired ablation time, skin-to-skin procedural time, all significantly shorter with a newer device. What about comparisons between PF and high power short duration? Here's one using 45 watts compared to PFA. Again, no difference in outcome. This is an observational study, shorter procedural times, shorter LA dwell times, longer fluoroscopy, and no difference really in complications. And here's one using the Q-dot micro with the 90 watt 4-second lesions, still no difference, overlapping curves in terms of outcomes, comparing very high power with pulse field ablation. To date, we have not been able to demonstrate a benefit of pulse field ablation. So to finish, here's a meta-analysis and systematic review of durability, looking at studies that have brought patients back. And you can see this trend, RF and cryo, the difference was not statistically significant. Up the top here, PF, but we're yet to translate that in randomized studies to improved outcomes. I will say, and I'm very interested in everyone else's experience, our own experience with it over 18 months is that we're starting to see better results than we've ever observed with either RF or cryo. Early observations from a single centre, but I think as this technology evolves, we are going to see greater PVI durability. And I'm going to stop there and thank you all very much for your attention.
Thank you, Dr. Coleman, for this wonderful and very insightful talk on PVI durability. Any questions?
Dr. Coleman, I just want to ask you that we know that the pulmonary vein isolation is the cornerstone of AF ablation. So when these patients get recurrence, so how many patients are because of the incomplete pulmonary vein isolation or reconnections versus another triggers into the atrium, anywhere in the left atrium or in the right atrium?
So, great question, and I was wondering whether I would have time to start and touch on what to do with those patients who, who have recurrence and you go back and they have durable PV isolation. Different numbers in different studies, maybe around the 20% mark. I'm sure it'll vary with PF. Maybe it'll be a higher percentage with PF, a higher percentage of patients coming back because of a higher durability, but that remains to be seen. Here are the adjunctive ablation targets beyond pulmonary vein isolation. If you can still see my slides there, I'm not sure. But, you know, beyond the obvious triggers, we're left with areas of uncertainty, and very little has changed since the 2017 document. Voltage mapping, perhaps, signal mapping, you know, we're seeing that now with the dispersion of electrical activation, the Volta study, but we're yet to really examine the publication. Vein of Marshall ethanol infusion, maybe a single study. Non-PV triggers, if they're not firing at the time, very soft data that you can actually reproduce these and target them. We've seen the posterior wall data. You know, it's disappointed all of us. You know, maybe that data will be better with PF than it was with RF, but it still hasn't been particularly compelling. So I think we've got a way to go, you know, and we need those patients with durable PV isolation. We really need to enter them into prospective randomized studies.
Thank you, Dr. Kalman. It was wonderful you having here, and it would have been a pleasure if you were here with us, but it was very exciting talk. Thank you so much for participating.
Thank you so much for inviting me.
Yeah. So with that, we'll close this session.
This is actually a continuous session, so requesting you to please stay back in the chair, and I would like to request Dr. Mondar Shah to please join in the chair. Big round of applause, please.
Next talk is by Dr. Dipen Shah, again an online talk, and he will be talking about how to maintain checklists to avoid complications of AF ablation. Dr. Dipen Shah.
Good morning, friends and colleagues, chairpersons. It is my pleasure to have this opportunity to talk to you during this AFib symposium at the IHRS meeting in Calcutta, to talk to you, in fact, about checklists and other measures to avoid complications of atrial fibrillation ablation. Major complications are usually defined as complications that result in permanent injury or death, require re-intervention or intervention for treatment, prolong or require hospitalization. And here is a recent consensus statement that summarizes the main complications of catheter ablation of atrial fibrillation. Periprocedural death fortunately occurs rarely, with a professed incidence of 0.05 to 0.1%. Atrioesophageal fistula also very rare. Periprocedural thromboembolic events are less prevalent now than they used to be some years ago. Cardiac tamponade remains a significant problem. Severe pulmonary vein stenosis has all but disappeared, but should not necessarily be ignored. Permanent phrenic nerve palsy is rare, although temporary palsy is not uncommon with balloon devices such as cryoablation. And vascular complications are probably among the most frequent of them. However, with the current modern techniques, these are on the downswing. Asymptomatic acute cerebral lesions are considered complications, but they have few, if any, practical consequences. Of course, mortality is the most feared complication, and it ranges from 0.05 to 0.1%, depending on the series and publications. But the most important conclusion that one can make from any review of the literature or from discussing with experienced operators is that high operator volume correlates with a lower early mortality. It's important to state here and emphasize that no other technological or procedural aspect, apart from high operator volume, has been reported to be associated with such a decisive reduction of complications. So high operator volume, a large experience equals lower early mortality. This is an example of a patient who was undergoing catheter ablation of atrial fibrillation. You see a selective angiography of the right inferior pulmonary vein. Note the prominent movement of the cardiac silhouette. About 1 hour later, you see a still from a fluoroscopy taken for the same patient. And if you look carefully, you can see a radiolucent area of epicardial fat and an enlarged cardiac silhouette. But there is no movement of the exterior part of the cardiac silhouette. You can see the heart is surrounded by a radiodense structure and such that the border of this shadow does not contract. And this is actually diagnostic of an acute tamponade and is normally a life-threatening emergency. Of course, this was promptly noticed. Subxiphoid puncture was performed and followed by the appropriate placement of an intrapericardial drain. The hemorrhagic collection was drained, and to confirm the drain position, a small contrast injection was performed. As you can see, now the silhouette contracts well. This residual contrast that was injected just for the confirmation purposes was then re-aspirated. So cardiac tamponade is the most frequent, potentially life-threatening complication, and the commonest causes are a misdirected transeptal puncture or direct left atrial mechanical trauma during catheter manipulation and ablation, or overheating during energy delivery with or without development of a steam pop, and in this case, excessive power, temperature, and force are likely to be operative. With relation to avoiding this complication, there is no real data to suggest that this is more common with uninterrupted anticoagulation, but in our experience, we do omit the dose for the ablation day. Tamponade is thought to be less frequent with cryoablation and has been shown to be so in one randomized control trial, but unfortunately that in more real life databases such as observational studies, this has not been the case. Additionally, the availability of real-time contact force sensing has not reduced the incidence, but overall it is a sufficiently frequent problem that every operator, every person involved in a catheter ablation procedure should be aware of the possibility that the development of hypotension during an AFib ablation procedure must be assumed to indicate tamponade until proven otherwise. And as you saw in the example earlier, the fluoroscopy to an attentive observer can provide a crucial early warning sign. Also, do not forget that delayed cardiac tamponade can occur in the setting after a catheter ablation within hours to up to weeks later, and it's been well documented to have an incidence of about 0.2%, so it's actually not negligible and can be a catastrophic problem. Atrioesophageal fistula is, of course, well known as a very lethal complication, although fortunately rare. The median time from ablation to symptom onset and diagnosis is actually 18 and 21 days in most reviews, as a median number. Thus, it's a delayed complication. The impact of the commonly considered effective preventive measures, such as visualization of the course of the esophagus by CT, by cardiac MRI, or intracardiac echo images during the procedure, has not been shown, as has not been shown the fact that reduced contact force and reduced ablation power in the vicinity of the esophagus or the left atrial posterior wall can be helpful. And neither has it been shown that employing esophageal temperature monitoring, esophageal cooling, or esophageal deviation can be helpful. All of these have been used in different observational studies, but are not considered routinely acceptable and effective treatment, effective measures to avoid the occurrence of atrioesophageal fistula. Note also that the use of appropriate ablation indices, such as ablation index, does not guarantee the absence of occurrence of a complication such as the AE fistula. The routine use of proton pump inhibitors also has not been shown to have any substantial benefit from this. Of course, atrioesophageal fistula is all about awareness, about prompt diagnosis, and of course, surgical treatment is typically needed. What we do in our lab is that we avoid consecutive RF lesions at the posterior wall sites adjacent to the esophagus. We do not use esophageal cooling, esophageal deviation, or esophageal temperature monitoring. We do not use IC-guided ablation. We do not routinely use proton pump inhibitors, but we do reduce contact force on the posterior wall. Thromboembolic complications are another issue, and these are often associated with the presence or the development of intracavitary thrombi, development of thrombi on or within the sheaths, and ablation catheters introduced into the left atrium. On this slide, you can see monitoring intracardiac echo monitoring of a moving echo in the left atrium attached to a catheter in the left atrium. Char formation can occur at the tip of the ablation catheter. Mobilization of a pre-existing left atrial thrombus can occur. Electrical cardioversion during the procedure can also either lead to with stunning or mobilize a pre-existing thrombus. Here below, you can see debris that was extracted from the case above. On the upper right-hand side, you see contrast-stained thrombus coming out from a sheath. And bottom right, you see another example of contrast-stained thrombus coming out from a sheath, indicating stagnation inside the sheath. This needs to be avoided with a continuous ongoing perfusion. So in order to prevent thromboembolic complications, the ACT target should be more than 300 seconds, and we use a continuous heparinized flush 100 to 150 cc per hour with 2000 international units and 500 ml for all left-sided sheaths. And appropriate sheath hygiene is important, pre-rinsing, never rinsing without aspiration, and throwing away 5 to 10 cc. Passive purging to avoid bubbles. Look for bubbles and make sure that you shake and dislodge trapped bubbles and extract them. And of course, take extra care for multi-element, multi-spline catheters, particularly in large bore sheaths. As I alluded to earlier, anticoagulation is important in the context of hemostasis and bleeding complications. Truly uninterrupted anticoagulation is currently only for vitamin K antagonists. For DOACs and NOACs, the dose on the day of the intervention is routinely skipped. We monitor ACTs periodically during the procedure, typically at 45-minute intervals with a formal target of more than 300 seconds. We resume anticoagulation 4 to 6 hours after the procedure. And you must remember that bleeding risk is highest in the first 12 to 24 hours, and you must have appropriate strategies in place in case of bleeding, such as the use of protamine, cryoconcentrates, vitamin K administration, and/or specific antidotes. Vascular complications, as I pointed out earlier, at the access site are among the most common and quite troublesome, can be quite troublesome, including hematomas, arterial lacerations, AV fistulas, retroperitoneal hemorrhages, and others. These have become much less common now with the routine use of ultrasound-guided punctures. And here you see the physiology or the underlying mechanism of an AV fistula. If a venous vessel is punctured by going through an artery which is in close proximity, typically superior to or superficial to this venous structure. And of course, instead of being side by side, if you have this superior-inferior relationship, it's very likely that the needle that goes straight in without knowing about this artery will then transfix the artery and create an artificial passage and lead to the formation of an AV fistula. As is obvious, and most labs now routinely use ultrasound-guided punctures the ultrasound can allow you to clearly target the venous structure without damaging or traversing the arterial vessel. Hemostasis after the procedure is, of course, an important measure to perform well in order to avoid local bleeding complications. As I pointed out earlier, the key is a high-quality ultrasound-guided puncture. In case of small bore sheets, we rely on manual compression, and for larger diameter sheets, a figure-of-8 stitch and perhaps vascular closure devices can be useful, although we have no experience with the latter. We do ask our patients to avoid rapid mobilization and respect a 48-hour period of rest or very limited activity after the procedure in order to avoid bleeding created by movement in the context of full therapeutic oral anticoagulation. Of course, phrenic nerve palsy is well known now in this era of balloon cryoablation. The right phrenic nerve is most commonly affected because it descends in close proximity to sites of ablation, also in the SVC, as well as the right-sided pulmonary veins. It is most common after cryoballoon ablation because of the wedging of force exerted by directing the inflated balloon, which distorts the anatomy and decreases the distance between the RSPV, or the right superior pulmonary vein endocardium, and the right phrenic nerve. It's rarely seen with radiofrequency current, and a cardinal sign is a newly elevated hemidiaphragm. And what is routine during the procedure is to monitor during the ablation right phrenic nerve pacing, whether manually or fluoroscopically or both. As I pointed out towards the beginning of my presentation, pulmonary vein stenosis has become all but extinct, but it should not be ignored. Here is an example of a left inferior pulmonary vein stenosis after RF ablation in this vessel. You can see there's a somewhat distal stenosis, and quite logically speaking, this form of fibrotic scarred narrowing has become clearly much less common, or has even practically disappeared because of ostial and antral wide area circumferential ablation. You can see here how a stent has been placed, and the contrast injection shows the stent is patent, and CT 3 months later shows you that now the right inferior pulmonary vein has a restored flow and appropriate diameter. So how does the lab setup in practice work? As you can see in this image, there are multiple parameters and features that the operator has to monitor. And much like an airline pilot, I emphasize the fact to trainees that you must make a circuit of visual observations controlling, for example, the defibrillator here, the fluoroscopy screen here, the radiation exposure here, the non-invasive or invasive blood pressure monitoring, the overall surface ECG here, the intracardiac tracings, the irrigation pump, and the impedance tracing on the ablation generator, all in sequence and in a never-ending sort of continuous surveillance circuit. That's what allows for picking up of early warning signs. And these are the few points that I consider important to remember in trying to prevent complications. Airway management for these long procedures under sedation is very important, and it is imperative that the airway be surveyed by dedicated personnel and not by the ablation operator. An ultrasound-guided puncture goes a long way towards avoiding vascular access complications. Intracardiac echocardiography, if available, can be useful to monitor the early occurrence of tamponade, although fluoroscopy can be extremely useful for the experienced observer. Intracardiac echocardiography and a designated experienced mentor are very useful in avoiding complications related to transseptal punctures. I alluded to the value of fluoroscopy. Fluoroscopy gives you a real-time, although albeit two-dimensional imaging, and can tell you a lot looking at the cardiac silhouette, contractility, catheter movement, and catheter positioning. And finally, real-time contact force sensing, temperature and impedance monitoring for radiofrequency current ablation are imperative and will allow you to, in nearly all cases, avoid situations of excessive heating and probably even audible or inaudible pop formation, and thus reduce the likelihood of a tamponade during the procedure. Thank you for your attention, and it's been a pleasure to present in front of you. Hello.
Yes, sir.
Yes, I can
Yes.
hear you. Yes, of
Yes.
course.
In the checklist, one thing which is not there routinely, but we use is esophageal temperature monitoring. So you don't routinely use that?
We have not used it in 28 years.
Dr. Dipan, you said that the most important point is the experience of the operator. So is there any statistically minimum number that a operator should have been doing per month or per year to be called competent electrophysiologist to prevent complications?
Operator experience has been documented in, I think, in a number of publications, including observational surveys as well as consensus documents as being important and well correlated with a lower complication rate. The exact number is a matter of debate. I know that one document refers to at least 50 procedures per year. But just like age is a continuous parameter that correlates with increasing risk of atrial fibrillation and thromboembolic events, increasing experience is also a continuous parameter. And the greater the experience, the lower the risk of intra-procedural and early peri-procedural complications. This is where actually the availability of an experienced mentor, whether in-house or at the other end of a telephone, can be actually quite useful, at least in a limited sort of way.
Dr. Dipen, am I audible, sir?
Yes, of course.
Yes. Sir, that was very lucid presentation, and back to the basics. I think all operators should listen to your talk. I just wish my fellows were here to listen to you. Sir, one small question. You mentioned about intracardiac echo. So do you do that routinely for all patients?
No, I'm actually quite old school. We use intracardiac echo in selective cases, for example, papillary muscle ectopics, or in patients with complex congenital heart disease to guide a baffle puncture, situations such as these. I think what is in general, at least even in experienced labs, what is often ignored is the incremental value of fluoroscopy. As I showed you in the example, an experienced observer can pick up early warning signs of pericardial collections. You can infer a lot from catheter positions. Biplane fluoroscopy has advantages over single plane fluoroscopy. And when in doubt, a small hand injection of contrast injection can also give you a good idea of where you are positioned with respect to the pulmonary veins and within the atria. So I think my message to your audience and to trainees is that in this era of the widespread use of 3D mapping and 3D imaging, which is virtual, please do not forget how useful and how effective and how real-time fluoroscopy is, and therefore, despite the small amount of radiation that modern systems emit, it is an invaluable resource.
Thank you, sir.
Thank you, sir. I think we will move on to the next topic.
Thank you.
Next is managing AF in the setting of heart failure. And speaker is Dr. Aftab Khan.
Hi, good morning. So I'll be talking about the management of patients with atrial fibrillation and heart failure. I think we are all aware that atrial fibrillation and heart failure commonly coexist. As much as 30% of patients with atrial fibrillation will go on to have heart failure. And the number of heart failure patients who have atrial fibrillation can go up to almost 50% in those who have HFpEF. And these two diseases also end up causing a difference in outcomes. And I think we are all aware, and these changes are often related to both the neurohormonal changes as well as the anatomical changes that happen because of the disease. We all have agreed and understood that there is a continuum of disease, and similar to the heart failure, where we have a staging process, it's been proposed that you have a staging for atrial fibrillation too, with stage 1, which is the patients at risk for atrial fibrillation, to stage 4, which is permanent atrial fibrillation. And I think we all have known that there is an overlap of disease processes, and therefore the interventions can also be sometimes similar. Now, what is important to also understand is whether the atrial fibrillation came first or the heart failure came first, something like the chicken or the egg story. And why this is important, we sometimes would want to do this just by a careful history taking or analyzing the previous ECGs, because there's a difference in the outcome. If AF came first and the patient had a heart failure that develops later on, we know that this sometimes means that you have to be more aggressive in restoration of sinus rhythm, because this may sometimes be a tachycardia-induced cardiomyopathy, and therefore a restoration of sinus rhythm or treatment of atrial fibrillation may help your LV function to improve. Vice versa, a heart failure which comes first and with an AF that develops later portends a worse outcome. And the studies have also shown that for patients who have AF, which then degenerates into an associated LV dysfunction, the outcomes are much better when an AF is treated versus patients who have heart failure first and an AF later. The management of atrial fibrillation in heart failure, we all know that it is first the optimization of heart failure therapy. And with the 4 pillars of heart failure, as we say, RNAs, beta blockers, MRAs, and SGLT2 inhibitors, these become the primary treatment for us whenever we are treating patients with atrial fibrillation. But also understanding that there's a 5th pillar, that is the anticoagulants. So anticoagulants are there in the consensus. And with the CHA2DS2-VASc score, heart failure gets you 1 point. So every patient of heart failure with atrial fibrillation should be on anticoagulants, whether you want to consider it a class 2A indication when you have a CHA2DS2-VASc score of 1, or a class 1 indication when you have a CHA2DS2-VASc score of 2 or more. So this is important for us to understand that every patient of heart failure with an atrial fibrillation has to be on anticoagulants. And in this era, it is always the NOACs rather than the VKAs, with the exception, of course, the mechanical prosthetic valves or severe and moderate mitral stenosis. What is also important to understand is that the Garfield, which is a real-world registry, has also shown us that we underdose our patients to almost 1/4, and this is a little worrying. So when we have an underdosing with all the NOACs in our clinical practice, this translates into a worse outcome of all-cause mortality. So patients who are underdosed, a non-recommended dosing, will have a worse outcome, and therefore this just makes it more important for us to make sure that we percolate this message to our physician crowd also, so that we do not underdose our patients with a NOAC. Again, the rate versus rhythm control management strategy has been something that we've debated since long. There has been a change in a lot of protocols, and this is just a busy slide that talks about the atrial fibrillation as a modality of rhythm control that has now grown in popularity over the last few years. This is important because there has been data to suggest, for example, the East AFNET 4 trial, which talks about early restoration of rhythm in patients with heart failure, whether it be by medicines or by means of ablation. And what this has defined the heart failure as patients with an ejection fraction of less than 50% or with class 2 and class 3 symptoms. And it was found that if you'd made an aggressive attempt to restore sinus rhythm in this group of patients, within the first 1 year, you would translate into a better outcome in terms of cardiovascular death or stroke and heart failure hospitalization. The Castle-AF trial was another landmark trial, which was one of the very few trials which looked at all-cause mortality, and it showed a 50% reduction as compared to medical therapy with ablation when you looked at death from all cause. And it also showed a significant reduction in hospitalization with heart failure and death as a composite endpoint. But the caveat here is that many of these trials, you have to be careful because these are often selected patients. So these are not for all comers, and one has to be careful to extrapolate this data to all patients with atrial fibrillation. The Castle-AF trial, for example, had paroxysmal and persistent AF only, and one has to be careful one is looking at this data. The Cabana trial, again, was one of the large trials, which was negative in terms of superiority of ablation over medications. But when you did a subgroup analysis of 778 patients with heart failure who were enrolled in this trial, there was a significant, almost a 46% relative risk reduction in the primary composite endpoint and a 53% reduction in the all-cause mortality. Another interesting finding was this benefit in the Cabana trial was driven by a reduction in the total AF burden. And this was monitored every 3 monthly or every 6 monthly by a 72 hours monitoring. So you did not necessarily need to eliminate AF, and therefore we need to change our perspective in assessing the treatment efficacy. So I think we have to move on from binary, either there is an AF or no AF, to understanding whether we've caused a reduction in the AF. So if we can reduce the AF burden, we know that this may translate into an improved efficacy or a survival for our patients. So in a clinical scenario, which are the patients who would be taken up for an AF ablation in HFpEF? Well, these would be patients who are not so sick, patients in class 1 or class 2, preferably non-HF etiology, a persistent AF, a narrow QRS, not a very large LA, LABI of less than 50, an absence of severe CMR-derived fibrosis of the atria or ventricle, a patient who's had a good response to electrical cardioversion and then has relapsed back again, but in this period of sinus rhythm has had an improvement in the ejection fraction. Well, this is a patient who probably has an AF-induced tachycardiomyopathy. So these are the patients that you'd be probably taking off. But this may look simple, but then it does not work out for all patients. And there have been certain models that have been sort of prediction models that have been attempted to be derived. And this is one of them, the Antwerp score, which tried to look at clinical parameters, known etiology, a wide QRS, severe LA dilatation, or a paroxysmal atrial fibrillation to try and identify if you can qualify for which patients would have a response. And you can see that a score of up to 2 gives you a percentage or a responder rate of almost 82%. But as your score goes to 3, you drop to almost 50%. And therefore, these prediction models are still being taken up. A lot of interest has been now brought on into AF or AV nodal ablation and pacing in the era of conduction system pacing. And these papers have basically tried to understand whether AV node ablation and AF ablation and pacing may be one of the modalities of treatment. Well, this is the Sukra plot, and when you look at this, except for the AF recurrence, which of course you're not going to achieve by an AV node ablation, the all-cause mortality, cardiovascular mortality, and hospitalization rates could in fact be reduced by an AV node ablation and pacing. You could put your leads in many places, well, into the His bundle, into the left bundle branch area, into the apical RV, or a biventricular pacing. And some of the criteria or patient selection factors where you would look for a pace and ablate strategy is pretty clear. So if you have a patient with a wide QRS and an LV dysfunction, this is a patient with an atrial fibrillation where you would want to probably pace and ablate. Someone who is very frail, someone who's had a severe conduction system disease, less sort of expected success at AF ablation. So it's all simple here. But what do you do with patients who have a recurrence after the first ablation? Would you want to pace and ablate them? Patients who already have a pacemaker in situ, elderly patients, well, these are less clear indications. The 2021 ESC guidelines with the pacing and ablation strategy have talked about RV apical pacing, irrespective of the QRS duration and the LV function, or a patient with a preserved LV would get a 2A indication. A biventricular pacemaker, irrespective of the QRS duration and a preserved LV, would get a class 2B. And as your LV dips, your class of indication would move up. CSP are not still in the guidelines. But again, with a lot of trials which are coming up, BIV versus HBV versus a left bundle branch area pacing, I think it's a lot of data to say that rather than in patients with any LV function, we would reserve a biventricular pacemaker for patients with a wide bundle, left bundle branch block, and a HFrEF to get the best benefits. And a CSP, we know, has certain limitations, especially in patients with an additional distal conduction tissue disturbance or a septal myocardial spar, or areas where we are not able to achieve a narrowing of the QRS. You may have to supplement with another lead there in the CS, something that's known as a LOT CRT or a hot CRT. So gentlemen, there are a lot of questions which are still unanswered in the management and treatment of patients with HFrEF. We really don't know what is the optimal rhythm control strategy. We don't know whether CSP would be better off as compared to a biventricular pacing. We still don't know what do we do with our anticoagulation strategy in patients with high device-detected atrial high rate episodes. We don't know what is the optimal strategy for stroke reduction in this group. So what we know for sure is that AF and heart failure coexist. Optimization of the heart failure is the cornerstone of therapy. Anticoagulation with recommended doses of DOACs is essential. Rhythm control is something which is, if feasible, is something that should be aimed for. And the key aim is to not eliminate AF, but to reduce the AF burden to get a better outcome for our patients. Thank you.
Thank you, Dr. Apta, for a wonderful overview of management of atrial fibrillation in heart failure. Now, in your clinical practice, what is your threshold of taking these patients for rhythm control strategy? And does this differ in patients with HFrEF versus those in HFpEF?
Yeah, I think that's a practical question. I think for patients with HFrEF, I think it's a no-brainer that we would definitely want to attempt to get them to a sinus rhythm, because I know that translates into better outcomes. So all these patients would have an attempt at a chemical cardioversion or an electrical cardioversion if there's no response. When it comes to HFpEF, I mean, we don't have much data, and there is still a concern whether we would want to attempt too much of a rhythm strategy control in this group of patients by means of an invasive procedure. So we would probably cardiovert them with clinical or a pharmacological cardioversion, but probably will stay away from radiofrequency ablation in this group of patients, especially when if it's a permanent AF. So if it's a paroxysmal AF or a persistent AF, we may still think if it is going to improve the patient's quality of life. So it's a shared decision in that group of patients. Yeah.
Very good talk. At least I enjoyed it. So one is the comment that in heart failure, whether it's a reduced ejection fraction or preserved ejection fraction, I think it's not a rocket science to understand that keeping them in a normal rhythm is always useful. This is at least my concept. The second thing is that one should try to keep them in a normal rhythm, and frequent use of cardioversion plus antiarrhythmic drugs. I think cardioversion is less used in our country to keep them in normal rhythm. So not only one should not jump into RF ablation, if you can maintain them in normal rhythm for at least a couple of months, and the patient has recurrence again, at least there will be some positive remodeling and the chances of AF ablation result will be better rather than jumping right away. So that's our strategy. Number two is, and if we are not able to do successful ablation, we are very aggressive in AV nodal ablation and left bundle pacing. I think that's no doubt about that.
Sure.
The question which I want to ask you that you must have reviewed is that AF burden thinking is a great thinking. So two things, what do you mean by, what is the burden which is, we say, okay, this is good enough for heart failure improvement, and similarly, what is good enough burden so that we don't need anticoagulation? So where do you start anticoagulation, what burden, and what burden is good for heart failure control?
So again, there's no data there. I mean, this is a data-free zone, and really we don't have answers there to say what is a good...
We talk qualitatively, but we don't know actually, ultimately.
No, that's right.
So that doesn't help in the management of it.
Sure.
I think if no more session, we'll go to the next one. 3D case presentations.
Thank you so much, chairpersons, and to all our speakers. Can we have a louder applause for all our chairpersons? And we move on to the next session, 3D case presentation. As chairperson, I would like to invite on the dais Dr. Kartikeya Bhargava, Dr. Neeraj Yadav, Dr. Ajit Thachil, and Dr. Praveen Srikumar. Also, a small announcement that the checkout will be within 12 o'clock. So whoever have to check out, please do the needful. And the quiz contest will be starting from 3:15 with the prelims and 4:15 the main round at the Santosh Parela Hall. So whoever want to register yourself, kindly can go forward. Thank you. We'll be starting the session 3D case presentation. Chairpersons Dr. Kartikeya Bhargava, Dr. Neeraj Yadav, Dr. Ajit Thachil, Dr. Praveen Srikumar.
Cases, we have the first case by Dr. Arun Gopi, parahesian ventricular tachycardia, decoding a SVT mimic.
Respected Chair, teachers, friends. So we'll be just starting off with an SVT mimic. So the stories of a 38-year-old new onset, incessant, drug refractory, near narrow QRS tachycardia, no response to adenosine, amiodarone or diltiazem, normal LV function, referred to us. So this is the 12-lead EKG. So you can see a near narrow QRS duration of 120 milliseconds, tachycardia running at a rate of 190 beats per minute, right bundle branch block, left axis deviation. You have evidence of VA dissociation seen. The arrows point towards sites where VA dissociation are very evident in lead 2. So when you have white QRS tachycardia, QRS duration of 120 milliseconds with a VA dissociation, the differentials are a conduction system VT. AVNRT with RBB aberrancy with an upper common pathway block. Orthomic AVRT with our right bundle branch aberrancy mediated by a nodoventricular, nodovesicular axillary pathway, and junction ectopic tachycardia with rate-dependent aberrancy. So this is the ongoing tachycardia when the patient was brought to the lab, just as what the ECG showed. So put in the CS again confirms AV dissociation. So you have a VA dissociation seen, again confirming what we saw on the ECG. Again, the differentials remain same after we have put in the catheters, intracardiac catheters and electrograms. So we give adenosine. With adenosine, there's worsening of VA block. Tachy doesn't terminate. Essentially, maybe ruling out AVNRT and orthomic AVRT via nodoventricular, nodovesicular pathway. We try to entrain the tachycardia from atrium. We are unable to entrain the tachycardia from atrium. This is the HV interval during the tachycardia. It's a white QRS tachycardia with still a positive HV, 19 milliseconds during the tachycardia. And the tech in between terminates where we are able to get a sinus rhythm HV interval also. The sinus rhythm HV is 35 milliseconds. So you have HV, so you have seemingly borderline white QRS tachycardia with evidence of VA dissociation, ECG and intracardiac wise, with no termination of tachycardia with adenosine, there is VA dissociation and atrium not able to entrain. Within the most important key factor is HV during the tachycardia being less than HV during sinus rhythm, confirming a conduction system VT. So what is the mechanism of the VT? We quickly do an activation map actually. So we find the earliest activation in the basal LV upper septum. We have find some signals about 42 milliseconds earlier. It could be a focal tachycardia versus a micro re-entry. We start entraining the tachycardia from the right ventricle. Here you can see actually we are able to entrain the tachycardia, so suggesting that it's a re-entrant mechanism, a focal re-entry. Sorry, a micro re-entry. Now we are going on to find where the VT circuit is. I think the response to entrainment has been probably well discussed in the earlier talks. So this is the landmark paper which describes what the response to entrainment in a VT is. So we start entraining from different sources. So entrainment from right-sided His, you find manifest entrainment with a PPM minus TCL of 15 milliseconds, which means you're pacing inside the VT circuit. You are in the outer loop. We entrain from the high basal LV septum, where you have concealed entrainment and a PPM minus TCL of 58 milliseconds. The stim to QRS is greater than EGM to QRS. So we are pacing inside the VT circuit, but outside the isthmus. That means you have the high basal septum is an adjacent bystander. Then we entrain from the LV mid septum, where you have a PPM minus TCL of 45 milliseconds with concealed entrainment, with the stim to QRS being more than the EGM to QRS. Again, so we are pacing inside the VT circuit here, but outside the isthmus, which means it's an adjacent bystander. So we do an entrainment mapping from different sites. Again, the lower LV septum and LV apex shows manifest entrainment with 64 and 58 milliseconds, saying that it is remote from the circuit. From the high basal septum and mid septum, we find concealed entrainment with PPM minus TCL 45 and 60 milliseconds, indicating the adjacent bystander. And the right-sided His was having manifest with PPM minus TCL 15 milliseconds, suggesting it's an outer loop. So we get in between these two, probable indicating that this might be the site between the high septal and the mid septal location. And the moment we get the catheter there, there's a bump termination of tachycardia. And the moment the tachycardia terminates, you can see His bundle and left bundle signal there, actually. And we understand that it's a very high, it's like an upper septal VT, conduct system VT. So we quickly map the native conduct system when the patient is in sinus rhythm. So this is a bump termination site, which is the yellow spot. And this is where it's tagged on the 3D. And you map the conduct system. You map where the His bundle is, the left bundle is. So this is the 12-lead ECG. Once he got sinus rhythm, we compare the 12-lead sinus rhythm ECG with the VT. It's almost like you have an RBB and almost similar axis. The HV was 19 milliseconds. And if you look at this circuit, it's almost like an type 2 upper septal VT with a slightly lower turnaround point. It's almost identical. You have an incomplete RBB configuration with an HV which is almost 19 milliseconds. So it confers to the classification by Nogami a type 2 upper septal VT. And so we start mapping and we find prominent conduct system potentials there. Signal in the ablation catheter at the termination site. So this is the site where we had a bump termination. And quickly we were able to reinduce a tachycardia. We find this potential, beautiful potential. It's about 42 milliseconds preceding the local EGM. And the moment we start ablating at this site, within 6 seconds the tachycardia terminates. We have sinus rhythm, and this is the ablation site fluoroscopic location. And this is the so-called P1 and P2 potential in the upper septal VT in this site. And after termination, we monitor, we view the consolidation lesion, and we monitor the PR interval, HV interval, QRS during further RFA, and everything remains stable. So this was a successful RF ablation site. The His bundle on the 3D was located about 6 mm away from the site, and the left bundle was about 5 mm away. So 3D was used primarily because we wanted to remain stable and wanted to consolidate that site, stay away from the conduct system. So this is our ablation site, and if you go by the circuits that Professor Nogami has described, this corresponds to the upper septal VT, the upper turnaround point of the type 2 upper septal VT which we ablated. The red side marked site is where we ablated. And this is the left bundle potential, just the proximal ablation catheter showing the left bundle potential signal. So after ablation, no tachycardia was inducible with even aggressive induction with isoprenaline. And this is the post-RFA ECG. So take-home messages is upper septal VT is a rarely encountered arrhythmia among all ventricular arrhythmias. Most of the time it presents as incessant tachycardia. Sometimes it is seen after ablation of prior left posterior vesicular VT. It is in need a mimic for SVT for all junior colleagues, because the QRS duration will almost be borderline between narrow and broad QRS. And if you look at the type 1 variant, you will have exactly the same narrow QRS as the sinus rhythm, and the axis also mimicking like sinus rhythm because it's a very high upper turnaround point. The entrainment mapping is very reliable. It accurately defines the isthmus and the circuit, particularly in upper septal VT, where you have very prominent conduct system signals and you want to stay away from the native conduct system and try to get at the upper turnaround point or the slowly conducting zone. And ablation upper septal VT processes a very high risk of AV block. Consequently, RFA should be delivered by closely monitoring the AV conduction, and you should ensure that you are ensuring that after the termination you are monitoring and staying away from the conduct system, and ensure while RFA you are not damaging the native conduct system. So that's all from my side. I'll be happy to take on questions. So I thank Amira and Shabri for making this, helping me with the case and the presentation. So thank you.
So, Arun, it was a good case. So, how did you, how would you tell that this entrainment really helped you in finding out the circuit or potential site of ablation?
Yeah, so entrainment mapping, we really want to get to that slowly conducting upper turnaround point, because this is an area where you are dealing in the in the upper septal area near the native conduction system. So you want to ensure that you are at the critical site and you are away from the native system. This is the turnaround point from the, if you see, it conducts down the anterior fascicle and posterior fascicle and goes up the slowly conducting zone. So you want to be exactly there, and that's how an entrainment mapping will roughly give you an idea. It is not that you are going to exactly go and ablate at that site. In this site, actually, we have not entrained from the site of the exact site where we ablated. We were just trying to figure out which is going to be the near zone. And while we are going, we found where we have the shortest ppm anesthesial. While we were getting in between that, that's when you have bump termination, and we found the possible site, and then we ablated. So we didn't actually entrain from the site of ablation. No, yeah, actually, see, in these scenarios, you don't take away any information that you get, because these are not scenarios where you keep looking for more and more evidence. You clearly know when, once it terminates, we were able to reinduce there. It just comes back again, and you have a clear potential 42 milliseconds ahead, and you know that this is going to be the site. So, and you know how close the conduct system is. So you have to get rid of the site.
So you got a minus 42 milliseconds.
Yeah, minus 42
at the time where you have, at the place where you have.
Yes, exactly.
And you got the P1, P2 you showed.
Yes.
You got the dissociation, P1, P2 dissociation.
Yeah, at the end of ablation, you can see P2 goes after.
It's probably mapping of all the potential that really help you decipher the re-entrant circuit in fascicular VT.
Next. Thank you. Thank you, Doctor. Next, Dr. Jeevan will be talking about ablation of VT arising from posterior process of left ventricle. I would request all the presenters to stick to time of 5 to 6 minutes and be precise.
Good morning, everyone. This is an VT arising from the posterior process of the LV. And the case history, 62-year-old male complains of palpitation since 1 year, and ECG was suggestive of NSVT arising from the LV origin, and his Holter showed high PVC burden, that is about 45% with the NSVT runs, and his echo was mild LV dysfunction with 50% EF, and he had an history of inferior wall MI in 2022, and his coronary angiogram revealed RCA total occlusion. So, so indication for 3D EP study, and we decided to plan to do it under echocardiographic guidance. So this is an ECG of the patient, and this is showing complete R-wave with no any precordial transition, complete R-wave in all the precordial leads, and the axis is superior axis with the, and lead 1 in AVL showing the positive. So this is more of a coming from the left ventricular side and arising from the more basal and septal origin. So we had a differential diagnosis of these VTs. This can be arising from the posteromedial papillary muscle VT, or the crux VT, septal parahesian, or the VT from the posterior process of the LV. So keeping in this keeping this in mind, we wanted to do this under echo guidance, intracardiac echo guidance. So under and also with the 3D. So first we have mapped it from the right atrial sides. So right atrium under ICE guidance. So through the AV septum, we have mapped the R through the RA, but we did not get any earlier points of activation, and the earliest point was only 20 milliseconds. And similarly, we have mapped from the CS coronary sinus ostium also. So it also did not reveal any earlier point of activation. Eventually, we went into the transaortic retrograde approach into the LV, and we have dense mapped it. And here we can see the activation map revealing that earliest point, earliest point of activation beating the onset of QRS by 47 milliseconds. So this is the HD signals showing the 100% pace map with the ECG matching with the ECG morphology. So we've gone to the retrograde aortic approach. We've gone to ablate the VT, but we did not with the reverse loop from the aorta, but we couldn't reach the point, reach the site of VT. So we went through the transseptal, and then we had a junctionals during radio frequency during RFA, and eventually tachycardia terminated during the RFA with acceleration and then termination. This is the LAO and RFO picture showing this is corresponding to the left-sided AV ablation. So through the transeptal approach. So this anatomy of the posterior superior process. This PSP LV is the most inferior and posterior aspect of the basal LV that extends posteriorly to the plane of tricuspid valve. The PSP LV is anatomically adjacent to the inferior and middle aspect of the right atrium. Mapping can be done. There are different approaches. Most commonly is done from the right atrial approach, but it can be done from the CS and LV septum also. So the conclusion is that the most common used approach from the PSP LV mapping and ablation is the right atrial approach under ICE guidance, with the small A and V on the EGMs. Monitor the cardiac conduction system while ablation by atrial overdepressing. Monitor for the AH intervals for AV block. Monitor for any faster AV junctional beats while ablation. So there are a few case reports of previously with prior inferior wall MI presentations, and they similarly had a PSP LV VT. So that's it. Thank you.
Thanks, Jeevan. The initial ablation was during sinus rhythm. You showed those junctionals during ablation.
Yes, sir. VPCs NSVT runs were coming in mixed with the sinus rhythm. It was not just sinus rhythm. So junctionals were coming. Oh yeah, yes, sir. Please.
Okay. So you tried retroaortic approach. You could not reach there. So
with the reverse loop.
Yeah. So then you approached it from the right.
Transeptal.
Right. Transeptal. Okay.
Transeptal approach.
So did you create a right atrial map as well in this case?
Yes, sir. We created the RA map. You can see that
Yeah.
the CS map, RA map, they are all
right
overlapped together. Sir? The earliest was only from the LV side, LV septum, from the LV septal side.
Why do you label this as posterior superior process?
So anatomically, this is the most inferior and posterior aspect of the LV, the septum. Actually, I did not put the eyes pictures because it did not help us much.
Because almost RA and this LV activation were equidistant.
Yeah.
PSP was
Yeah.
That's right. Yeah. Okay. Any question?
So this is on behalf of Dr. Kapil sir. So thank you, sir. Yes.
For third case, Anirudh Mandal, recurrent ICD shocks.
Good morning. Thank you, Indian Heart Rhythm Society, for allowing us to present this case. And also appreciate Dr. Rakesh Sarkar, who is the electrophysiologist, doing some formidable case like this. This is straightforward. go this patient. He is a 16-year-old boy presented with syncope and seeks medical attention, and he was diagnosed to having VT. And after further evaluation, they found they have ARVC. For that, they were put an ICD to this patient. But what happens after ICD? There was a recurrent VT and recurrent shock, and after there is a insufficient ventricular tachycardia, which caused the fall in the EF and all these things, and he seeks and further medical opinion, and where they opine for they give him the opinion for cardiac transplant. Now at that point, we found this patient. They came to us, and what we can offer this patient in that point, apart from the cardiac transplant, we asked them for an VT ablation, 3D mapping. Now this is the ECG, the sinus ECG. There is a manicured small QRS indicating some fibrosis, significant fibrosis most probably, and this is one of the VT ECG. Though in already there was a MRI was done in outside hospital, and the MRI shows significant epicardial fibrosis. But that VT ECG, that was something in form of epicardial origin or some or endocardial origin. We are not sure about that. We know that in ARVC, that is a different ball game. That VT arises mainly from the peritricuspid region, lateral wall, but apex normally does not involve in the VT mechanisms. And most of the time, there is a significant amount of VT component that is in epicardial or mid-myocardial region. Though endocardial VT is also possible, but there is significant amount of substrate in epicardial and mid-myocardium. So keeping all these things in mind, but the ECG, first we are some hopeful that there are something, some endocardial component may well. This is the ECG that found in our, in our lab, cath lab, but it shows that VT that correlates to the clinical VT, and this is the mapping, the endocardial LAT mapping. But in the endocardial LAT mapping, the vast area of the red zone indicating a vast area of early deposition, and that does not correlate with the VT pathway. Again, that is the voltage mapping from the endocardial point. We shows there is a purple zone, large area of purple zone, that is the healthy purple zone with some scar area in the peritricuspid region and otherwise. But there is a significant amount of endocardial healthy area. So what we found, most probably the VT substrate may be epicardial in origin. So we shifted to the epicardial approach. We use the Chivas needle 16G with the valve and tried to pierce the epicardial region in the posterior aspect. We all know that the crux is the main area where mostly the VT arises in the ARVC. Now, after entering the pericardial space, we advance the Agilis sheath, and through Agilis sheath with SD grid, we map the epicardium. Mainly the posteriorly and crux region and RV lateral wall also in the different aspect. And during sinus rhythm, during mapping with the SD grid, we found in SD1, 2, 2, 3, 3, 4, that region there is significant late potential that indicate the inhomogeneous slow conducting path area. And this is the cardiogram during the VT. And at that point, we found some mid-diastolic potential also in some part of the SD grid. And this is the voltage map. And in the voltage map, there is significant amount of fibrosis, the gray zone, and in between some unhealthy inhomogeneous red and yellow zone. This is the LAT map for the VT, and that LAT map shows there is a crowding of isochromes in some area, which correlate with the mainly the slowly conducting area or isthmus or something in the reentrant circuit. So this is our area of interest. It is the VT propagation, VT propagation image, and that also collaborate with the ILAM map during the sinus rhythm. The VT propagation map during the VT and the ILAM map taken during the sinus rhythm, that collaborate with the same the VT the reentrant pathway. Now this is the area of our interest where we have to ablate. In that inhomogeneous region, we certainly try to entrain, but due to some extent fibrosis or other contact issue, we cannot successfully entrain that part of the area. So we have to, there is a large scar burden and we have to large area to ablate. So we carry forward with ablation. But they are successfully ablated, and but after that the VT morphology is changed to the different type of morphology. Previous VT cycle length was near about 460 millisecond, and now it is transferred to a 380 something 390 millisecond cycle length, different morphology, whereas V6 was positive in the previous, now it is V6 is negative. So again we start to map the second VT. And again, same thing, we found mid-diastolic potential, and in the first VT1 that was in the area of the peritricuspid region in the lateral RV wall. Now second VT we found it near about the crux. So it is the voltage map, and there was a significant scar amount is there. So what we do, there is a lower threshold. Previously that lower threshold was the 0.2 millivolt. We manipulate the lower threshold to the 0.09. So in between the scar we found some lacunae, and we start to ablate in that part. It is the near about the posterior and crux area. We ablated it successfully. Now that is during VT ablation, that is a spontaneous termination of the VT without any PVCs. So the two VT was successfully ablated, but there was some other non-clinical VT. We keep them for the medical management. There is one interesting thing happened to manage the other. If there is a possibility of other VT or anything, so we give them some flecainide. But the next day, what happens? The patient was kept in monitor in the CCU, and we found an VF that is correlated with the QT prolongation, and we stopped the flecainide. But after that, till now, patient is well, and the EF is more or less same, and she is asymptomatic. So take-home message is VT in structural heart disease can sometimes jeopardize hemodynamics even if EF is not deranged. So in ARVC, there is a significant chance of the VT maybe arising from the epicardium, but not. It is always true. There may be it may be endocardial, but there is predominant chance of the it is epicardial. And epicardial mapping and RFA is a safe and feasible alternative before planning of cardiac transplant. Thank you.
We'll go to the next one because we are pressed for time. We don't have time for questions. So presenters, please note, try to finish just ahead of time so that we can have some time for discussion for each case.
Good morning, respected chairpersons, faculty, and my dear colleagues. So this is an interesting case of AF ablation that we had done this year. So a 73-year-old male with rheumatic heart disease, moderate MR, moderate AR, an EF of 45% and a dilated LA had presented to us with persistent symptomatic atrial fibrillation. We cardioverted him to sinus rhythm after ruling out LA appendage clot. And there was improvement in valvular regurgitation and in symptoms following conversion to sinus rhythm. So we decided to go ahead and do AF ablation in order to maintain sinus rhythm. Comorbidities were minor CAD, that is non-obstructive CAD on a CT CAG, COPD that was well under control with inhalers, and reduced kidney function. eGFR was 42 ml per minute. He was also a chronic smoker and history of chronic alcohol use, but he had stopped for the past 1 month. The ECG shows his atrial fibrillation at the time when he had presented with a well-controlled rate. So we took him up for a standard AF ablation procedure under general anesthesia, single transeptal puncture, and mapping was done with a contact force ablation catheter only. This image shows a left lateral view with the ablation catheter in the LA across the septum, and this is our decapolar CS catheter through the jugular route. Heparin was given to maintain the ACT more than 300 seconds throughout the procedure. Esophageal temperature probe was also used. And we did a conventional VACA, that is posterior pulmonary vein isolation. Impedance drop of more than 10 ohms during ablation was taken as a marker of good ablation. That was on the CARTO system. And we confirmed pulmonary vein isolation, and then mapping in the posterior wall of the LA had shown fractionated signals, so we went ahead and created posterior box lesion also, which comprises of a roof line and floor line connecting the two inner edges of the VACA. So this was the final result with both side pulmonary veins isolated as well as the roof and the floor lines created. And then when we were checking for bidirectional block, we had initially with the PVI, we had got a good bidirectional block demonstrated. But after the creation of the posterior box, when we were checking for conduction block from the box, we got a 1:1 conduction while pacing from the box, only at a high current output, that is 20 milliamperes. Surprisingly, at 5, 10, and 15, it was not happening. And we were getting a 1:1 conduction. As you can see, the yellow arrow, ablation distal is the pacing site, and we are getting a long stim to CS signal of around 160 to 170 milliseconds, with earliest being in distal CS and later in proximal CS, 1.2 to 9.10. So we also got double potentials in the posterior box, despite confirming that we have done a good good ablation line with no gaps. So we decided to map the leak with CS spacing at 500 milliseconds. And as we kept mapping throughout the posterior box, we started getting fractionated signals that were getting longer and longer. And finally, we got a spot where we got a very long fractionated signal, more than 50% of the tachycardia cycle length, almost 60 to 70%. And this, in this diagram, so this spot where my arrow is pointing, this red dot, this was the spot where we got the maximum longest fractionated signal. And therefore, we decided to ablate that spot, since there was no other spot where we could show any early or long fractionated signals. And on ablating that with a good 10 impedance plus drop, 10 ohms drop in the impedance, we managed to demonstrate exit block even at 20 milliamperes current output. So since we had confirmed that there was no conduction gap in the posterior box, as well as we had mapped through the posterior box and localized that particular portion bang in the center of the posterior box where we were getting a long fractionated signal with no other place for with no evidence that this is occurring endocardially, we are postulating that this is an epicardial conduction, that is an epicardial pathway from the posterior box to the other part of the LA. And since we managed to achieve a good ablation at that spot and terminate the conduction, demonstrate exit block, we did not proceed to further map exactly how this epicardial connection is going. So epicardial connections are not uncommon. These have been described in the literature. There are multiple case reports and case series. Epicardial reconduction, a majority of acute pulmonary vein reconnection that happens after doing pulmonary vein isolation and posterior box is because of epicardial reconduction. In fact, in one of these studies by Ventau Gu et al., they found that among all acute PVR connection cases, nearly 57 to 60% of the cases were because of epicardial reconnection rather than any conduction gap or a gap in the conduction line. And in one study, 17.9% of patients had epicardial connections, which gave the appearance of incomplete ablation line. So most common site of these epicardial ablations is actually from the pulmonary vein carina to the left atrial posterior wall. But in our case, we had isolated both the posterior wall and the PVI. Intercable bundle connection has also been described from the right pulmonary vein carina to the right atrium, and I'll be showing that in subsequent slides. So most commonly, when do we suspect? When we have looked for conduction gaps and demonstrated that there are no conduction gaps, or we have found one, we have done additional ablation, and still we are getting conduction across the ablation line, then we should suspect epicardial connections. So this is this is a elegant case report. Another case report is also there from Turkey. This is from Japan, which shows the intercable bundle and how that is a very common source of pulmonary venous reconnection. So in the image on the left, you can see that in the carina between the RSPV and RIPV, there runs an intercable bundle, just like how Bachmann's bundle connects RA to LA. This bundle connects the pulmonary right pulmonary carina to the area of the SVC-RA junction. And in this particular situation, what happens is, when we pace from within the box or within the pulmonary venous antrum, we'll find that there is conduction happening from RSPV to the RA, and from the RA, as seen in the right image, it then comes from the RA all the way back to the LA and gives a CS 910, that is proximal CS to distal CS concentric activation pattern. And in this particular case, what the authors did was, they could not find the exact origin here, so they did a carinal line, and then still there was conduction happening, so they had to go to the RA and ablate the RA end of this pathway. So textbooks also mention the same thing, that when posterior box does not maintain isolation or roof line is not blocking, and we have ruled out conduction gaps, then one of the reasons is complex epicardial endocardial architecture, which basically means these epicardial connections. And either one solution is to ablate the posterior wall in its entirety. Another solution, as mentioned in these case reports, is to trace the connection and find out either end of the connection and ablate it. Now in our case, we got the posterior wall, the entry point in the posterior wall, and we ablated it, and we got good clinical success. So in conclusion, whenever we do AF ablation, we get a good VACA, pulmonary vein isolation, and a posterior box, and still we are getting conduction. We should always keep in mind that epicardial connections could be the cause of it. Thank you for your kind attention.
Thank you. What's the significance of that long fractionated signal at your site of ablation? Why did you go searching for that type of a signal? You said you ablated at a site of a long fractionated signal.
So that gave us a clue that it could be transmural conduction through the epicardial connection. So on that basis, we localized that as the site where this epicardial connection is probably
connection
allowed.
shouldn't be a long signal. I mean, you're saying a long duration signal. I don't understand why it should be of long duration. I would expect that to be one early signal when you pace.
Yes, sir, that was the earliest signal also, and long.
Now, Amira can come up to present intratunnel atrial arrhythmias in a lateral tunnel fontaine.
Good morning, one and all. I'm presenting a case of lateral tunnel fontan and intratunnel atrial arrhythmias. So to begin with, what is a lateral tunnel fontan? It is a kind of a fontan in which we use a portion of RA as well as prosthetic tissue to create a kind of a baffle, separating it from the native RA on the medial aspect or the septal aspect, and connecting it to the SVC, which in turn will be fashioned towards the LPA. So our case, we are describing a 20-year-old male patient with DILV, DTJ, VSD-PS, status post BUS at 1.5 months of age, status post BT shunt at 6 months of age. He had a primary lateral tunnel fontan with BT shunt takedown and hepatic AV malformation coiling at 3 years of age, status post device closure of fontan fenestration at 4.5 years of age for desaturation. He started having evidence of Fontan failure with ascites at 5 years of age, and that's the time atrial tachycardia was also detected. So now he was 20 years of age, so 15 years of atrial tachycardia with medications. Status post LP and RPA stenting for branch PA stenosis, PDA device closure at 11 years of age. He also had an IVC stenting done for Fontan circuit obstruction. So this was his fluoro images. You can see an LPA, RPA stent. You can see multiple devices. You can see an IVC stent. On top, you can even see an display stent, which was locked here. So this was his baffle. RPA, LPA stent, PDA device on top. We had a fenestration device here. In another still frame, we see the patent IVC stent, embolized IVC stent, and a hepatic AV fistula. When we took his SVC venograms, we realized that most of the SVC to the Fontan flow was obstructed, and he had collateral supplying the Fontan circuit. So this was his baseline ECG. He had RBBB with right axis deviation. So we then started mapping. We used 3D mapping body patch as the anatomical reference. We used the decapolar catheter, which was abutting the lateral wall, as the electrical reference, and we took CS34 as the electrical reference here. Another reference we could have taken is go into the stent across the LA to get, LPA to get a stable LA signal, but we didn't do that. We have taken the electrical reference as a lateral free wall of RA. Then decapolar catheter was placed in the LV across the aorta to take the His and the ventricular EGMs. So we induced tachycardia. So this was at 1:1 tachycardia. Cycle length was 267. We had a 2:1 tachycardia also getting induced. The orientation of this tachycardia, since we had CS78 superior, so this was a craniocaudal tachycardia which was occurring. So we mapped the entire baffle, we mapped the lateral tunnel basically, and these were the maps that we generated. So this is, the first one is the activation map. So it suggests that it is a macro reentrant atrial tachycardia with early meets late pattern, and this is a propagation map showing crowding of signals at the nestimus area at the lateral incision site. So this is the common site where these circuits will occur, at the incision site between the baffle and the native atrial tissue. So this is a voltage map. The gray area you can see here, this is the scar, and on top are the slowly conducting zones. So we targeted that area, we ablated there, and we created a line of block in disconnecting the scar between the posterior inferior and anterior superior site. We did this with obviously with the irrigated catheter. Then this was the tachycardia termination. We had a sudden termination of tachycardia. Then we reinduced, and during reinduction we got another tachycardia with again superior to inferior orientation, but this time only 50% of the tachycardia cycle length could be mapped in the baffle. So then we started mapping again to find out where exactly the focus is. Then we found this split atrial signals here at the line of block. And we found the focus somewhere close to the fenestration device, which was located higher up here. Our catheter obviously could not go above because that part was obliterated by the LPA stent. So this was the earliest signal that we had got, 44 milliseconds from the electrical reference, which was CS34. And there the tachycardia was terminated. So we had two tachycardias. One was a reentrant tachycardia, one was the focal tachycardia, which was ablated within the lateral tunnel. So take-home messages here: catheter ablation in lateral tunnel Fontan for atrial arrhythmias can be effectively performed within the tunnel, and that is the most common site where it will occur, because pulmonary vein triggers are uncommon in this age group. We need not upfront take a transbaffle access to access the native atria. We can wait, we can just map within the tunnel. Resolution of arrhythmia is a very important step in managing Fontan failure. With this particular child, since he had already gone into liver cirrhosis, we decided cardiac and liver transplantation as an eventual plan for him. As of now, we have completed this ablation maybe 6 months back. As of now, he's off tachycardia. I thank Dr. Arun to give me this opportunity to present this case. Shabri sir. who has assisted us all throughout this case, and a technical team assisting us all the time when we take up such complex cases. Thank you.
What was the indication for ablation?
Persistence of tachycardia, 15 years of tachycardia episodes with Fontan.
Was there tachymyopathy or something?
Fontan failure, sir. Ascites.
Do you have any unipolar from the second tachycardia?
I think only bipolar was displayed there, so I don't have the unipolar there. Thank you.
Thank you. We'll go on to the next one. Dr. Devendra Singh Bisht.
Good morning, and thank you organizers for having me here. So my case, I depicted this case as a Janus face of scar VT because I believed it resembles the Greek god Janus, who has two faces, one looking in the past and one looking in the future. So this is basically a single circuit with two exits, and that describes the two different morphologies. So my case is a 58-year-old gentleman who has a past medical history of old inferior wall MI, and it is due to the spontaneous dissection of the RCA. The patient was suffering with ischemic cardiomyopathy and LV dysfunction. He received multiple shocks for monomorphic VT and referred for AICD implantation. And I decided for RFA to reduce the ICD burden before implanting a secondary prevention ICD. So this is the clinical tachycardia for the patient that was recorded. So this is a broad complex tachycardia who has a northwest axis, and you can see the VA conduction in the inferior lead, that is a 1:1 VA conduction. Right bundle morphology, there is a QS in the inferior lead suggesting a inferior exits of the tachycardia, and there is a small RS complex in the V5, V6 during the tachycardia. And this is a sinus rhythm ECG that suggests some old inferior wall MI for the patient. And imaging, I didn't conduct a cardiac MRI, but the echocardiography is very suggestive that the patient has a posterior lateral scar which corresponds to the RCA territory, you can see, and rest of the territories are having a healthy and viable myocardium. And this is the coronary imaging that showed a long spiral dissection in the RCA, and LCA was normal. So procedure was planned with the informed consent under general anesthesia. Vascular access which I chose was a right femoral access for the integrate approach for the LV, and left femoral vein is for the RV quad. Internal jugular was chosen for the decapolar for stability, and left femoral artery access was chosen for pressure monitoring and if required coronary angiography during the ablation. ACT was 300 millisecond. Insight was used as a mapping system, SD grid for mapping, and irrigated ablation for ablation. So I predominantly induced two predominant morphology of the tachycardia. This is the baseline ECG patient was having atrial fibrillation during the procedure because of inotropic support. And these are the VT morphology. Both were having the same tachycardia cycle length of 360. Both were clinical tachycardia. Both were easily inducible. VT2 was more consistent during the mapping, so I was able to map the VT2 morphology, that is the left bundle morphology. And right bundle was inconsistent, so it was difficult to map during the tachycardia. First, I do a quick RV map. So despite the morphology left bundle, RV was late in the during the mapping. And left bundle and the LV mapping showed a zone of isochronal crowding that is corresponding to the scar which is available on the echo. So I achieve a limited activation map of VT2, and there is isochronal crowding, and entrainment, then I proceed with the entrainment mapping just to confirm the finding which is available on the 3D map. So just to look at the epicardial aspect of the VT morphology, I placed my decapolar from the CS body to the one of the tributaries of the coronary sinus to look at the epicardial EGMs. And these are the epicardial EGMs which were recorded during that time. So CS34 was showing some early activity, but they are late compared to the surface QRS. Then I proceed with the endocardial EGMs, and these are the endocardial EGMs that were recorded from the zone of isochronal crowding. You can see there are some signals which are pre-systolic during tachycardia and they become late systolic when the tachycardia terminates. So it suggested that these signals play an important role during the tachycardia continuation. And there is some diastolic corridor of activity that is recording from that site. And this is a signal that you can say these are approximately mid-systolic, low amplitude multi-component signal that were recorded from the endocardial site of the isochronal crowding. Then started with the entrainment mapping. RV, I entrained with the RV catheter and RV was out of the circuit. The PPI minus TCL was 80 milliseconds, so RV was late, although it is a right bundle tachycardia. Then I focused my entrainment on this site, which is having a zone of isochronal crowding. So first I started with the earlier site that was recorded from the 3D map, and it showed a 12 by 12 concealed fusion and PPI minus TCL of 0 millisecond, and EGM to QRS is approximately 10 millisecond. I captured this signal and it showed it is a less than 30% of tachycardia cycle length. So as per the Stevenson model, I am at the exit site of the tachycardia. So just looking at the isthmus, I moved my catheter slightly toward the site of late signal. It is also a 12 by 12 concealed fusion, PPI minus TCL of 0. You can look at the signal. I captured this signal, and EGM to QRS is approximately 125 millisecond, and it comprises about 35% of the VT cycle length. So I am possibly in the central isthmus. As I proceed looking at the entrance site, the tachycardia terminates, and at this time I induced another tachycardia. So my catheter was at the same site. I again re-entrained this tachycardia, and now the EGM to QRS changed from the initial to 210 milliseconds. So I am at the entrance site of the the VT1 that was supposed to be the entrance site of the VT2. So I hypothesize that I mapped the VT2 that is showing the exit site in this side. So when the wavefront is exiting toward the septum, I am producing a left bundle bond morphology, and the wavefront is exiting to the free wall site, it is producing a right bundle morphology. So the wavefront, when it is exiting in the opposite direction, creates a two different morphology having the same tachycardia cycle length. So I chose the site of isthmus. I use the irrigated ablation, use 35 watts, 43 degrees, ablated at the proximal isthmus, and after that program stimulation did not induce further tachycardia. After that I did the scar modification and AICD was implanted before discharge. So in conclusion, the scar VT PVS typically induces more than one phenotype. It could be either because of different circuits or different exits from the same circuits, either because changes in the activation remote from the circuit due to functional block. However, ablation can at one site often abolishes more than one phenotype. Tachycardia with similar cycle length sharing a common isthmus and non-inducible post-ablation suggests that tachycardia likely has a single circuit with two different exits, and it is difficult to eliminate all the such channels, so it is better to identify the substrate and ablate it before modifying the substrate. And make tachycardia hemodynamically stable and mappable is an Achilles heel in poor LV, and circulatory support is often needed to increase success. Thank you very much.
Yeah, nicely done. I think we'll go to the next case.
Just for left, right, left.
Morning, everyone. So at the outset, I'd like to thank the IHRS organizers for giving me this opportunity. So this was a 65-year-old male who had an interval MI last year and underwent PTCA to LAD. Now in the last 15 days, he has had 3 episodes of highly symptomatic tachycardia. This was diagnosed elsewhere as AF because of its irregular character and was referred for further management to our hospital. Also noteworthy was to mention that he received cardioversion twice for the same thing. and the patient had normal biventricular function and a normal size left atrium. So I apologize for the ECG quality, but it was done outside. And so we see an irregular tachycardia, and in the periods of when we can appreciate regular P waves, and the P wave morphology is isoelectric followed by positive in leads 2-3 AVF, isoelectric followed by negative in lead AVL, and positive in V1. So the whole morphology is highly suggestive of a macro reentrant AT, possibly flutter, likely atypical, probably LA. So our plan in view of this, so this was another ECG, this was during the Holter tracing. So at the same tachycardia had become regularized for this brief while, and the cycle length was close to 440 milliseconds, so likely the LA cycle length was, or the RA cycle length was close to 220 milliseconds. So our plan was to go ahead with the induction of tachycardia and then proceed with GA if required. So as luck would have it, we were not able to induce tachycardia despite aggressive burst pacing and programmed extra stimulation. So anyways, we took a chance and we gave GA, and we also took a transseptal access. Fortunately, without induction, we were able to induce the clinical tachycardia of the same cycle length as in the Holter tracing, and it was CS proximal to distal. However, we had a problem. The tachycardia was recurrently, it was going into AF. This was happening spontaneously, which meant we could not map it. And also this was happening while we were trying to entrain the tachycardia, which again meant that we were clueless as to how to proceed further. As is often done in such cases, we decided to isolate the pulmonary veins before, so as to, in a bit to make it more organized and stable tachycardia. So we proceeded with the right pulmonary vein, as is our usual protocol, because they are more likely to reconnect in the 30 minutes waiting period, and also that we were suspecting an LA flutter. So after the completion of the right-sided Vecca first pass, the tachycardia became organized. This was the same tachycardia. We proceeded with the activation map first, again for the same reason, because the tachycardia initially was going into AF, was terminating recurrently after overdrive pacing. So we created a map of the activation map of the LA. So this is the LAT histogram of the left atrium. What we see here, we see multiple valleys. So this suggests macro reentry. And the other important thing is that we have mapped the complete cycle length of the tachycardia in the LA. So this is the propagation map of tachycardia. First thing is that the right pulmonary vein is still connecting. The other thing is the counterclockwise perimitral flutter, which is going around the left atrium, and there are no gaps. So we corroborated this finding with the proximal CS entrainment and the distal CS entrainment. Both were in. So we also entrained from the anterior LA. This was slightly 40 milliseconds, but based on the activation and the entrainment data that we had, we concluded that it was indeed a perimitral flutter. And since we had already committed to a right Vecca, so the best strategy would have been to make a anteroseptal mitral line. So this is the anteroseptal mitral line that we created. Unfortunately, tachycardia did not slow, did not change. The proximal to CS distal pattern did not change, and the tachycardia also did not terminate. So now we were stuck, as often happens. And we think of the usual things: inadequate mapping, epicardial bridging, ineffective lesions, or a new tachycardia circuit. So inadequate mapping, again, is not possible since we have mapped the complete cycle length of the tachycardia. There were no areas of scar or fractionation. So it's very unlikely that that was the reason. Epicardial bridging, again, there were no activation gaps in the LAT histogram as I showed you, and this was the first ablation. So again, you don't expect epicardial bridging to happen in the first ablation. The other thing is ineffective lesions. The procedure was done with a contact force-based catheter with the targeting an impedance drop of 10 ohms, which again was not possible. So we proceeded to map the RA and the LA again. Now we mapped the RA first, and so to our surprise, we had a CTI-dependent flutter, and this is the propagation map of the flutter. And of course, So we also mapped the LA again just to show that the LA was getting passively activated. And so we need to observe three things here. The first thing is have a look at the SVC and the RSPV area. So there is another tachycardia wavefront which is coming from above. The other thing is that our anteroseptal line is blocked. And of course, there is a CTI dependent flutter. So we entrained from the mid CTI and we got a perfect match. Now, so what could reconciliate all the findings that we had? So we had possible three diagnoses at this point of time. First was the figure of 8 re-entry, which is unlikely. Why? Because for figure of 8 re-entry, you need to have two tachycardias with opposite or oppositely rotating wavefronts. In this case, we had both the flutters, both were counterclockwise. So again, this is not possible. And also anteroseptal line should have terminated the re-entry in that case. The other is a biatrial single loop flutter. In that case, you would have a proximal to distal CS activation pattern. However, you won't be able to find the complete cycle length in the left atrium. So again, this was not possible. So most likely explanation was a biatrial dual loop flutter. So which would have meant that the proximal to CS activation pattern would remain, and you would have different independent isthmus for both the flutters. And in this particular case, since we were not able to terminate the flutter, likely the CTA flutter was driving the perimitral flutter. And this explains the absence of the activation gaps, the CS activation pattern, and the entrainment data. However, so why this happened? So this happened possibly because we didn't have enough catheters on the right side of the heart at that point of time. And that is why the activation pattern was not observed. The change in activation pattern was not observed. However, there was no change in the cycle length. So it's not still over. The CTA ablation led to cycle length slowing from 230 to 270, but the tachycardia did not terminate. So now what has happened is your proximal to CS activation pattern changed to distal to proximal pattern. We completed the CTI line and mapped the LA again. So this time what we had was a focal tachycardia from the RSPV. So you observe here at this point of time. So the earliest point is at the CS, is at the RSPV roof and antral junction. So at the site of earliest activation, we found this fractionated signal at the site of roof and the antrum, RSPV antrum. And this cycle length, the fractionated signal was more than 60% of the total tachycardia cycle length, highly suggestive of a localized re-entry. So we did not have high definition mapping for this. The whole procedure was painstakingly done through a mapping through the ablation catheter. So we did not want to ablate inside the vein, so we just completed the VACA line, and that led to termination, attainment of sinus rhythm. We confirmed the bidirectional CTA block with, and this is the exit block we confirmed on the right side, and we could not induce any further arrhythmias. So, so the three important points I need to highlight is that we need to have an integrated approach for ablation of atypical flutter. We can't always rely on entrainment, and as is often the case, entrainment cannot be done completely in such cases. So, and you need to have critical analysis of propagation maps, and the other thing is you need to keep in mind, even in a patient who has not had surgery, does not have congenital heart disease, has not had a previous ablation, you could still have dual loop flutters. Thank you.
I think we'll go for the next session. It was explained very well. Thank you.
Thank you so much, Chairpersons. Big round of applause, please, everybody. So right after this, we move on to the next session, State of Art lecture. As Chairperson, I would like to invite on the dais Dr. Amit Vora and Dr. K.K. Sethi. Can we have some applause, please?
Good morning, ladies and gentlemen. This is a very interesting case that has been cited in a very small box on the program, but may have very wide ramifications as we go through it. So I'd like to invite Dr. Narasimhan to take us through the journey of this patient, what the possible differential diagnosis could be, and how to approach it.
Thank you very much, sir. Thank you for the kind invitation, Dr. Amit, Dr. Sethi. This is a case that was given, and more or less over the next 15-20 minutes, I'll just go through a common sense clinical approach. So first thing is, in this patient, the questions are important. Where the patient had, of course, he had a syncope, palpitation. That is a warning sign that this patient with a combination of bradycardia and tachyarrhythmia and syncope is a high-risk indicator. And other questions are whether there is any history of chest pain, worsening heart failure, so on and so forth. Now, what we fail to understand is some common clinical conditions that we see, like diabetes, hypertension, obesity, obstructive sleep apnea, can cause a combination of both. They can cause conduction system slowing as well as recurrent ventricular arrhythmia. Why is this relevant? Because not all oral hypoglycemic drugs offer the therapeutic benefit in terms of arrhythmia reduction. SGLT2 inhibitors specifically reduce the arrhythmias, and there is an emerging evidence that GLP-1 agonist helps to reduce the arrhythmic burden. So specific drugs are useful. Similarly, when you have this in a patient with a baseline heart rate which is less than 60, it is relatively long-term survival is better compared to a person who has got a resting tachycardia and frequent ventricular arrhythmia and AV block. So resting sinus rhythm is important. Obstructive sleep apnea is again a common condition which can cause all these things, including TIA and a higher tendency for atrial fibrillation and stroke by several mechanisms. So if you see this patient having an unexplained LVH or a mildly dilated left atrium, that should make you suspect that obstructive sleep apnea is a driving force, mainly because the significant changes in intrathoracic pressure causes the left atrium to dilate, and there is an unexplained LVH in these patients. This is a very nice diagram from Journal of American Heart Association, which shows you how when there is a cessation of airflow in the airways, there is an RR interval that decreases, and then there is a compensatory tachycardia. So sometimes very often this happens in early morning, there are different types of obstructive sleep apnea. Some people have initial apnea and some people have at the time of waking up when they have it. Early morning they'll have PVCs and ventricular tachycardia when there is sympathetic activation. So during nights they'll have ventricular and blocks, and during daytime they'll have a tachyarrhythmia including PVCs, atrial fibrillation, so on and so forth. So when you have a bichamber arrhythmia, both atrial and ventricular, both brady and tachy, you need to think of more systemic causes. Similarly, just like what I mentioned about history of diabetes and ventricular arrhythmias, not all antihypertensive drugs have been shown to reduce mortality. For some reason, beta blockers have been castigated as a bad drug in hypertension, but a specific subgroup of patients where there is an LVH and STT changes, there is a significant mortality reduction with ACE inhibitors and a beta blocker combination. There are long-term studies which show. Whereas the conventional alpha blockers, calcium antagonists, do not provide the same degree of benefit even though they reduce the blood pressure. So going into the specifics matter. This is a very nice study which was done, published in European Heart Journal, about the frequency of pauses and bradycardias before the CPAP was initiated. And this is the week after the CPAP was initiated, there is a progressive reduction in bradyarrhythmias and pauses, very long pauses, all of them disappear. One of the ways that it can also present is there is an increased thrombogenicity. So the shunt becomes right. If a patient has a PFO, it will become a right to left shunt. So some of these patients can present as a TIA and instead of closing that PFO, you ask them to reduce weight and correct the sleep apnea, the shunt will disappear within 6 to 8 weeks. So it's important to make a specific diagnosis of this before you go on to this. Again, we tend to harp on this magic number of 30 as an AHI threshold. So if you have an AHI of 25 or 30, different labs define that, but that's not what is important. If a patient has even an AHI of say 20, but he is throughout the night, he is moving his limbs frequently, there is a significant sympathetic reactivation. So if you do tibial nerve activity, you will find there is an increased sympathetic activation that is coming as a small little column in the bottom saying as PLM, periodic limb movement. So even with a low AHI, if a person has periodic limb movement which is significantly elevated, that means for that patient it is pretty significant. You need to take care of this. I don't know, some of us who have been using intracardiac echo, during deep anesthesia, you can see when the patient takes a deep breath under anesthesia, that is, it's not GA, under sedation, you will find both the papillary muscles literally squeezing and producing a mid-cavity obstruction in some of these patients. So exclude structural heart disease, it's easily said than done. One of the important components of this history is a family history. Family history of someone remotely requiring a pacemaker, atrial fibrillation, patients who have had premature sudden cardiac death. Some of them can present as muscle wasting, especially adult onset arrhythmias. You need to consider very slowly progressing myopathies, like for example, Becker's myopathy or myotonic dystrophy. They appear in the 4th or 5th decade of life rather than an early onset myopathy. And a careful scrutiny of the ECG and the echocardiogram are useful, because very often when this patient comes as echo normal, you go back and see it for yourself, you will pick up something. It may be as simple as just a hyperechoic moderator band, which is passed off as a benign abnormality. A hyperechoic moderator band is a frequent finding in patients with granulomatous myocarditis. Hyperechoic papillary muscle is a frequent finding in these patients. Mitral annular disjunction with minimal MR, it is an important finding. So it's prudent to kind of go and look at the echo yourself, especially if the patient had a syncope once. Of course, treadmill to see whether the AV conduction improves, and see what happens to the PVCs or non-sustained VT with arrhythmias. There are certain phenotypes which significantly increase the VT during an exercise. For example, desmoplakin mutation, ARVC subgroups, patients with hypertrophic cardiomyopathy, forme frustrate, they can have increased VT and VF during exercise, and some of the channelopathies, I need not go into the details. And when you do a screening and if there is a high index of suspicion that you're going to have either a genetic cardiomyopathy or an inflammatory cardiomyopathy, our preference, we just have submitted this. If you are suspecting an inflammatory cardiomyopathy as an initial screen, PET seems to give you better yield than an MRI. I mean, MRI folks will disagree with us, but not all MRI interpreters are the experts, whereas PET is a little forgiving in terms of interpretation, and you get yes or no answer, a binary answer. So if you are suspecting inflammatory cardiomyopathies, we go with a PET, whereas if you are suspecting other conditions like genetic cardiomyopathy, we go for an MRI. History of prior cardiac disease, however trivial it is, sometimes the STT changes are very transient and they disappear. You don't see a telltale Q waves, especially in small OM branches or patients with an RC occlusion. Metabolic diseases, increasingly we see this as a common, because Wenckebach block is not very uncommon during a Holter. For example, during sleep, especially obese patients who are on beta blockers, it's a relatively benign finding. But in a patient with syncope, you don't know whether it's tachyarrhythmia which has caused the syncope or whether it's bradyarrhythmia which has caused the syncope. One of the things increasingly we see in metabolic conditions are patients with, it is overlooked, is hyperaldosteronism. If a patient has hypertension and the potassium, despite ACE inhibitor, is hovering around 3.4, you can be rest assured the patient is dumping a lot of potassium in the urine, transtubular potassium gradient will be high, and that patient will benefit from specific therapies. And similarly, proton pump inhibitors, increasing doses of proton pump inhibitors is prescribed left, right, and center, and it's well reported there's a high prevalence. We have also documented hypomagnesemia in this case. Family history of dilated cardiomyopathy, sudden cardiac death, and neuromuscular disease are important. Of course, substance abuse, alcohol is one. Substance abuse, especially if they have been frequenting the gym frequently, they use a lot of supplements which have adverse effects in terms of cardiac repolarization and causing these problems. Now, what about the characteristics of the PVC itself? This was way back in 90s. A French group noted that whenever the coupling interval of the PVC is very short, below 300 milliseconds, it suggests a malignant form of PVC. It very often suggests it's coming from a Purkinje fiber, and they have a higher risk of degenerating into polymorphic VT and VF, and therefore you need to take this a little more seriously. Second thing is, if you see a post-extrasystolic potentiation, the pulse is becoming a long pause and a potentiation, then these patients can have symptoms either due to brady or tachy, and they may merit further evaluation. You can't pass it off as normal. When you look at the ECG, what is it that you can look at the ECG? Very benign looking ECG, PR prolonged, and the patient has come to you with this symptom. But what is striking is you can hardly see a P wave. So why should a patient have a pan-conduction system disease? P wave is not seen, very prolonged PR interval. There is no R wave up to V3, very diminutive QRS complexes. Everything says this patient, when you see this pattern, one of the striking features is lamin mutation. So you should evaluate. We have several, in fact, Dr. Daljit, my team, she has got about 200, 250 patients of cardiogenetic clinics, and RMB mutations, filaminopathies, and lamin AC, they can present as unexplained PVCs and arrhythmias. And lamin AC especially has additional prognostic indicators because these patients have a very high incidence of stroke. So even though their CHAD score is 0, you may err on the side of, if it's lamin AC and even a small degree of atrial fibrillation, you may start them on anticoagulation. Now, this is another patient, a 66-year-old patient with effort intolerance and symptomatic PVCs. What do? It can be passed off as just therapies or ablation, whatever it is. When you see this, the native QRS has a fragmentation of the QRS. You can see fragmentation in 2 leads, non-progression of R wave. TV1 is more than TV6. TV1 more than TV6 generally indicates a posterolateral scar or an edema. It's like a circumflex. That's one of the common regions involved in sarcoid. So when you have a T wave that's upright in V1 but it's inverted in V6, you should think of either a severe left ventricular hypertrophy or the patient has a posterior wall involvement. And pleomorphic PVCs in 2 different morphologies, all of them put together, this patient was confirmed to have sarcoid. The whole picture changes because if a patient now has, instead of giving a pacemaker, you're going to give them an ICD or a dual chamber ICD as the case may be. And these patients, when you suspect there is evidence of septal disease, please, for heaven's sake, do not put a conduction system pacing. This is a progressive disease. If not today, 1 year later, they lose capture. Third is the timing of the PVC. So whenever you have a very long diastolic interval and then the PVC comes with some degree of varying cycle length, automaticity, this is 400, this is 500. So when you see a varying cycle length suggesting automaticity after long pause, it's very often stretch induced. So in these patients, if you just give them a pacemaker and if everything is benign, just give them a pacemaker and their LV size comes down, everything will be all right with a little bit of beta blockers. This is automaticity. On the other hand, this patient, you have a long PR and frequent PVCs and cycle length is relatively constant. You need to take this a little more seriously, depending on when it happens. When you have parasystole, that is the coupling interval keeps varying, but the interectopic interval remains constant, it suggests an automatic focus, and very often these have a slightly adverse prognosis compared to persons with constant coupling interval. Why is it so? If you take patients with post-infarction PVCs or a small benign RVOT PVCs, the coupling interval tends to be constant. Idiopathic VT, the coupling interval tends to be constant. Whereas when you take mutations like phospholamban mutation, lamin AC, 3 or 4 are emerging as very common arrhythmogenic mutation. Phospholamban, lamin AC, RMB mutations and phelomenopathies, they have a very high risk for sudden cardiac death. It's not that everyone in the family will, if there is a natural survivor at the age of 65 or 70 years, survived 70 years, you're not going to put an ICD at that stage. We don't know why some people survive to 70, some prematurely have a problem. This is an example of a varying coupling interval the patient, one of my colleague Abhijit had seen, and just a ELR was given and the patient developed a VF and died with a ELR and a flat line. So whenever you see varying coupling interval with varying STT changes, it used to be called as poor man's echo in the olden days. So when you have a post-PVC pause and you have a lot of STT changes, that used to be considered as you need to investigate that person further. So if you have this patient with a past, say 6 years ago or 7 years ago, this patient says, I had a Bell's palsy or I had a uveitis, then that you need to investigate this person for a granuloma. It could be tuberculosis, sarcoid. In high-risk profession, we have now seen 2 patients with syphilitic gummer presenting with AV block. So some of the old disease are making its way back. Obstructive sleep apnea and some of the drugs can cause, of course, all of you are aware. One of the increasing thing we are seeing is drugs given for cognitive decline. They produce bradyarrhythmias and can have problem. Need to work up for coronary artery disease and of course sleep apnea. Now switching gears, there is increasing recognition that depending on the genotype, for example titin mutation, even though it's a genetic cardiomyopathy, it's compatible with a very long life and they very often need a second hit for them to develop a problem. So if you have a titin mutation and the patient is an alcoholic, takes alcohol very heavily, you stop alcohol, they reverse significantly, almost to normal. Almost like a hyper-responder type of group. So whereas these are progressive diseases like lamin AC mutations, which I alluded to, are very progressive and you need to look for signs. And what about further imaging? Even in patients with normal echo, if you find a ring-like pattern, an MRI showing a scar in the mid-septum or anywhere carries a higher mortality. Especially the ones admitted, with more than 3 segments or a ring-like MRI enhancement, even with a normal EF, carries almost a 50% mortality in 5 years. This is from Muser's data from UPenn. And this is a scar burden is important. And I would suggest this is if you have a person with no scar versus 5% scar versus ring-like scar, they have a very adverse prognosis. Cardiac sarcoid, the importance of early diagnosis is if you don't diagnose early, this is like golden window, we are talking of MI, sarcoid gives you a long golden window and still if you don't diagnose, they progress to develop heart failure and need a transplant. I need not talk about the elite audience that you have to specifically look for characters. So if you have these patients with no structural heart disease, varying coupling intervals, PVCs in exercise and recovery, and pleomorphic PVCs should make you suspect that you're dealing with something more important than a benign PVC. This is Devabrata from our group looked at it. What looks like a benign arrhythmia, if the resting ECG shows a bundle branch block or a fascicular block, it is not benign. If the resting ECG shows QRS fragmentation, it's not benign idiopathic VT. If the resting ECG shows a very low QRS voltage, then it's not benign. It is a sign of myocardial edema. As you treat sarcoid or tuberculosis, you'll find the QRS voltages will come up. That's a very simple bedside tool you can use to see whether the patient is improving. So high-risk indicators are exercise-induced, pleomorphic TTs, short coupling interval, varying coupling intervals, or a family history of SCA. Resting heart rate having a tachycardia, elevated pro-BNP, QRS fractionation, and a QT that is quite prolonged are significantly abnormal indicators. So when you have this kind of a patient, do a detailed clinical history. This is being forgotten in the days of guidelines. Not all of them, you need to specify your treatment to the given patient. History, detailed clinical examination, 12-lead ECG, look for all the clues, clinical biochemistry, and then if it's required, an occasional patient may need an MRI or a PET CT. And depending on what you find, you need to think of a pacemaker and drugs or an ICD and drugs as the case may be. Thank you very much for the patient listening.
Thank you very much, Narasimhan. I think this was again a master class on, for all of us in terms of, we are all arrhythmologists and electrophysiologists. When we see arrhythmias, it's not that we need to treat it with the tools which we have, but we need to understand the comorbidities which could drive the arrhythmias, and understanding the comorbidities and tackling them is equally important. And glad you brought out certain points in terms of, treadmill test in evaluation of arrhythmias. I think it's a poor man's EP study. And it's a very easily available tool in our clinics, which we should utilize much more and frequently. Just a quick question in terms of, lot of arrhythmias are picked up on Holters, which have been done for non-specific complaints or symptoms. And, nighttime bradycardia, nighttime AV vancomycin, daytime PVC seen, but there are hardly any symptoms and clinically there's nothing. But often you get referred or you get confused because the arrhythmia is a little overwhelming. How do you approach that?
So number one is there are a lot of treatable factors, and as a clinician, if you find that the patient doesn't have anything and truly you are looking at all these subtle findings on the ECG and say that the ECG is completely normal, everything is normal, most likely it's a very good screening tool not to send the patient for further evaluation. But the warning signs are in the ECG and the clinical history. If they are abnormal, we need to evaluate the patient.
A quick question. Just recently, I've been sent I've not reviewed the patient, but a Holter that was done in a patient who has a severe sleep apnea. He has a nighttime 9-second pause, which is an AV block. He's not symptomatic. What would you do?
I would like to put him on a CPAP and repeat the Holter. 99.9% it will disappear.
I think we are, any quick comment or question, otherwise we have overshot time and we could conclude.
Atomoxetine is a good drug now for sleep apnea. If there is no contraindication, and atomoxetine used to be used for ADHD in children.
Hello.
It's a very good drug to increase the respiratory drive and abolish this quickly. Yes, please.
Sir, thank you for your wonderful talk. We learned a lot, but just to take a suggestion from you, last 1 week ago, I had a HCM patient, documented 65-year-old gentleman who landed up in another consultant's care. I was actually given a referral. That patient had incessant NSVTs. So it was an incessant NSVT, and this patient also had comorbid airway disease with a exacerbation, and saturation was around, say, 90%. And they had initially tried this amiodarone and all these things, nothing worked. Actually, and then I was referred to. And what I could find, as you've just mentioned, the source of the arrhythmia and the driver. What is driving the arrhythmia? So there was already an indication of putting the patient on a ventilator. So I sedated, paralyzed, and ventilated the patient 48 hours, just treated it as a VT storm, and then it never came back. So, things that, sir, from your clinical experience, similar thing?
Yes, yeah. I mean, I'm glad you brought this up. You are literally doing a Valsalva in the night. When a person has a sleep apnea, against a closed glottis, the airway is closed and he is trying to breathe. It's either a Muller's or a Valsalva. So that has got, this interaction is increasingly noticed in HCM literature. Now it's coming up. It worsens the LVH, accelerates the progress of heart failure. So if you have a OSA, you need to treat this, and of course you need to do an MRI. If MRI is completely negative, it's a very reassuring sign in patients with HCM.
Thank you. Thank you very much.
Thank you so much, Honorable Chairpersons, and to our speaker, big round of applause. Before we proceed to the next session, an important announcement that the industry session by Abbott CRM will be occurring from 6 to 7 p.m. at the Santosh Padala Hall, so you all can join. And the faculty lunch today will be from 12:30 at the same venue, Ministry of Kebab, because many of our faculty will be leaving early today. And the quiz Prelims round will start at 3:15 and the main from 4:15. So anybody who wants to participate and register yourself, please do it right now. We'll move on to the next session as chairperson. We'd like to invite on the dais Dr. Ankit Bansal, Dr. Daljit Sagu, Dr. Karthikeyan Ganeshan, and Dr. Ajit Thachil. Can we have some applause for our chairpersons, please?
The first talk is by Dr. Anil Saxena, sir, on subcutaneous ICD versus transvenous ICD, current status of practice in young. She said it's not happening.
Thank you. There was another talk actually before me.
Sir, shall we? I'm so sorry because
It's okay. Thank you so much and good afternoon everyone. It's indeed a pleasure to be here this afternoon and my task is to talk about subcutaneous ICD versus transvenous ICD in young patients. So what is the current status and clinical evidence? Now Dr. Sethi yesterday talked about subcutaneous ICD in his presentation, and we all know that ICD is now a very essential part of management of malignant arrhythmias to reduce the incidence of sudden cardiac death. And we have been using transvenous ICDs over 30 years, but some of the problem with transvenous ICDs are that all the acute and chronic complications, whether it's hemopericardium, pneumothorax, or lead failure, lead endocarditis, problem with the lead extraction are related to the fact that we have to place a lead inside the vasculature and heart. And if it is kept for a long time, it may fail, and lead failure rate is quite high, about 8 to 15% leads fail in different registries over 10 years. So it's a major problem as far as lead failure is concerned with transvenous leads. And those of us who have been doing extraction know that it's very difficult to extract a long-standing ICD lead with considerable morbidity and mortality. So the subcutaneous ICD was developed on the premise that we place a lead entirely outside the thoracic cage. The device is placed in the hollow of axilla and the lead is tunneled across the subcostal margin and then in the parasternal area. It has electrodes which form primary, secondary and alternate vector, which sends the surface ECG and diagnose arrhythmia, and then only shock is given. There is no pacing available here, no ATP available. So the potential advantages are that there is no need of venous access, so it avoids lead endocarditis. Obviously it avoids lead related infections, and it's better suited for children because in children we have to keep leads for a long time. And it also, in them, it also preserves the pectoral area site for subsequent upgrades or lead implants. The disadvantages are obviously that it has no ATP and it cannot be upgraded to CRT, CRTD. This is the registry showing the comparison between transvenous and subcutaneous, and as we can see that the infection rate, lead related complications are very less in subcutaneous ICD, and that was the premise which it fulfills. Otherwise, infection rate is more or less similar, but obviously it's easier to manage infection with subcutaneous ICD compared to transvenous. The inappropriate therapies were also found to be similar, although there was a different reason for inappropriate therapy. The subcutaneous ICD is better with, it is better with the discrimination of arrhythmia, SVT versus VT, because it mainly depends on the surface ECG. The other one depends on intracardiac EGM, so it's obviously not as good. But the main reason of inappropriate shock was oversensing. So it's a bit disadvantage with the subcutaneous ICD because it has a much longer sensing dipole, so it is more prone to extraneous oversensing. This was the first head-to-head comparison Praetorian study which compared transvenous and subcutaneous ICD, and the primary endpoint was all complications and inappropriate shocks. So what they found was that the complications or inappropriate shock, the primary endpoint was similar in both transvenous and subcutaneous ICD, but the lead-related complications were much less with the subcutaneous ICD, and that is the premise on which it was introduced. So that is a very important development as far as subcutaneous ICD is concerned. The inappropriate shock rate in the initial studies was higher with subcutaneous, but now it has, in the subsequent studies, it is found to be comparable to transvenous. In this study also it was not significantly higher. And again, the reason for inappropriate therapy was different in both. In case of transvenous ICD, it was mainly because of AFib or SVT, because the arrhythmia discrimination is not as good with transvenous. And in case of SICD, the inappropriate shocks are mostly because of oversensing. The discrimination is far better. This was another study which basically looked at inappropriate free rates, and it exceeded the target, whatever was the performance goal of 91.6%, it exceeded that. So it was found to be non-inferior to transvenous ICD again. And this slide also depicts how the inappropriate shock rate has fallen in subcutaneous ICD, and the latest studies, the untouched trial, for example, it was 3.1% overall, and the generation 3 device it was only 2.4%. So the guidelines indicate that all the guidelines are now suggesting that it is a comparable, it's a basically alternative to transvenous ICD, and it's particularly suitable to patients who don't have venous access or have tendency for lead infection, patients on hemodialysis or immunocompromised patients where their lead endocarditis would be more common. So we can choose a subcutaneous defibrillator. Now it would have particular advantages in young patients, because young patients often the indication is long QT syndrome or hypertrophic cardiomyopathy or Brugada syndrome, etc., where the substrate is different than adults who have mostly ischemic substrates. So ATP is generally not indicated in these patients. And transvenous ICD implantation can be particularly difficult in patients who have congenital heart disease, because they have difficult or complex anatomy, and often they have had previous surgeries making the anatomy further complicated and limited venous access. And with the transvenous ICDs, leads have to stay in body for a long time, and complications are obviously more, lead failure, lead endocarditis, etc., and extraction is even more difficult. So we can preserve the pectoral sites for future usage in case the patient requires ICD or maybe pacing is required, or CRT or CRTD is required. So we can use those sites for later use. So in children, it is particularly attractive option to implant a subcutaneous ICD. Now I'll review some of the recent literature that has been published in children. This is a Save Children registry that was published last year, where they had enrolled 62 patients from 30 centers. The main indication was, as we can see, secondary prevention. 88% had ventricular fibrillation and another 2% had VT, so it was secondary prevention. The etiology was mostly, as we can see, long QT syndrome or idiopathic ventricular fibrillation, CPVT, Brugada, etc., as expected. They used 2 incision technique in most patients, 66%, and some 1/3 had 3 incision. But in very small children, they bent the tunnelers to increase the course of lead hair and the lead, because in very small children, this lead is too long. So they placed it, instead of left parasternal area, they placed it on the right side, and also bent the lead with the help of tunneler so that it covers more area here. So that was the technique used. And they found that it was equally good, and the number of suitable sensing vector did not change during the follow-up, and there were no complications or lead fracture in their experience. Another study, sidecar project, where they included 81 patients published last year. 42% were female, and average age median age was 15. The weight, etc., is mentioned, but indication was 60% primary prevention, 41% secondary prevention. Most patients, as we can see, had either cardiomyopathy, 38 patients, or congenital heart disease, or idiopathic ventricular fibrillation, or channelopathy. And the procedure time was about 90 minutes. The device was placed in intramuscular in 41% and subcutaneous 59%, and they kept left parasternal area. So what they found was that the composite safety endpoint was better with the 2-incision technique, and the device-related complications were also better with 2-incision technique. It was also better in as far as the BMI relation is concerned. In patients who had a higher BMI, as expected, the device-related complications were less as compared to those who had a very low BMI. And intramuscular placement was better in terms of complication, because if you place it between serratus anterior and latissimus dorsi, between the layers of that, it gives the, it is much better to, it avoids long-term erosion complications, etc. This is another study, Monaldi Care Registry. 21 consecutive children and adolescents from the Monaldi Care data was used. This is another study, which is Monaldi Care, which is a larger study, but 21 patients were small, between 8 and 18 years. And they concluded again that it can be used in children, very small children, with similar rate of unwanted side effects, and it was found to be equally efficacious. There were no complications. One patient had repositioning, and another patient had a replacement. So other than that, there were no issues. This is another registry from the Pediatric and Congenital Electrophysiology Society multi-center review. So they have reported data on 115 patients, and again we can see that mostly it was primary prevention, 55%, and 45% as secondary prevention. Cardiomyopathy and structural heart disease were the dominant reasons, and along with idiopathic ventricular fibrillation. So the indications are fairly similar. And most patients had normal ejection fraction. The procedure specifications were similar, about 113 minutes, and 3-incision technique and 2-incision were used like in roughly half of patients. And most patients had in this study subcutaneous placement. Few had intramuscular, which is now preferred, and sternal lead was again on the left side. So they also found that it has complications similar to transvenous ICD based on previous literature, and they didn't report anything different. This is another study recently published, again with the complications between the comparison of complications between transvenous and subcutaneous ICD. And they also found that the overall device complications were similar, but lead complications were much less with subcutaneous. So I think it corroborates the same. So the key messages are that both subcutaneous and transvenous ICDs are effective in preventing sudden cardiac death in children. In terms of efficacy and safety, both are now similar. In terms of inappropriate shocks, also both are now similar. But SICD offers certain advantages in certain group of patients, especially in young children, patients who have venous access issues, patients who are prone to infections. It offers some advantages. And in future, we are looking at smaller devices and a lead suitable for pediatric use, so that it can be placed in young children. I think I'll stop here. Thank you very much for listening. I'll be happy to answer.
Thank you
if
very
there's
much,
any
sir.
question.
Another technology which is not much evolved in our country. Do we have any queries from the? Stage at which it was
3-4 years. Yeah. Body weight, I don't remember, but yes, it has been very young. 3-4 years also there was one patient. Right. And that's why it was not possible in many patients in very small body weight to place it intermuscular between the two layers of serratus anterior and latissimus dorsi as we prefer to do in adults. So it had to be placed subcutaneous. So it is definitely a problem. Now the new devices are a bit smaller, but
is
still
there
they
any
are.
guideline given as to this should be the minimum body weight or?
No. I'm not aware of any guidelines, sir.
Any of these registries could have, discussed that point. That was all.
Sir, any data is there on the difference between inappropriate shocks between sub-Q ICD and transvenous?
Yes, of course. Okay. So this Praetorian study, which was a head-to-head comparison between the two, it showed that the lead-related complications were very less. The overall, there was no difference in the overall complications and inappropriate shocks. And if you see inappropriate shocks alone, then again there is no significant difference between the two. Numerically, it was slightly higher. The other trial, untouched trial, had a very low inappropriate shock rate of around 3.6% overall. And in the new generation device, which had the smart pass filter, it was only 2.4%. So 2.4% annual incidence of inappropriate shock is very less. It is comparable to what we see in the transvenous ICDs in recent literature. So in terms of inappropriate, because the initial studies had shown up to 13 to 15% when the first generation SICD had come. But the subsequent use of algorithms has lowered the incidence of inappropriate shocks and brought it comparable to transvenous.
Anil, I just want to ask you that, do you think the extravascular ICD may replace the subcutaneous ICD in future?
Yeah, it's a very good development because it also offers the advantage of pacing, particularly at least ATP, if not brady pacing, but ATP can be delivered because it is under the sternum and it has a couple of electrodes which are in touch with the heart. Of course, sometimes it may lose contact and it may not be possible in everybody to deliver, but 80-90% patients will receive ATP. So that is definitely an advantage. The disadvantage is that the placement is a bit more invasive. One has to go from subcostal margin under the sternum. There is a space there, and we have learned to basically use that space for pericardial access. But it's a good development. But we don't have much long-term data with that.
Does anybody know that in extravascular ICD, the procedure was done by the surgeon or the cardiologist?
Cardiologist.
EP guys.
Yeah.
Thank you very much, sir. Thank you.
you.
Good round of applause for sir. We'll go to next talk, I'm sorry sir, by Ajay Naik sir on replacement dilemma for ICD and CRT in recovered LV dysfunction.
This is a question we come across every once in a while in our clinical practice. Probably it's a bane of doing too good a job. This is regarding patients who previously had reduced cardiac function and subsequently improved. There is no single unified definition of this phenomenon. And this is important to know that recovery of LV function does not necessarily correlate with remission from the detrimental physiology or pathology of heart failure and its consequences. So the question of utility of defibrillators and maybe of CRTs in these patients, should they be replaced at the time of battery depletion? There are a couple of recent reviews and some data from the past. Recovered EF generally considered in different studies from anywhere from between more than 35% to even more than 50%. So different studies have considered different number, but generally improvement of LVEF by 10%. And it's also called heart failure with improved EF. Some studies have divided into heart failure with partially recovered EF, 35 to 50%, and fully recovered, more than 50% EF. Many societies have now considered, including the Heart Failure Association of India, that this should be considered as if a patient has a baseline LVEF of less than 40%, there's a 10-point increase from baseline LVEF, and then a second measurement is done sometime later, and it shows an LVEF of more than 40%. That should be considered as recovered EF. This is a ACC NCDR registry of about 26,000 patients. almost 17% had partially recovered EF, between 35 to 50%, and 7% had recovered EF, more than 50%. About 40% patients each had dual chamber ICDs and CRTD. So LV function can recover in a major proportion of patients who got an ICD placed for primary prevention. And so the question comes, the risk of ventricular arrhythmias or sudden death and the impact to replace the device at the time of battery depletion. Cardiocus CHOP registry, this was predictors of LV function recovery. Generally it happens in patients who are younger age, lower NYHA class, who are on optimal medications, absence of defibrillator, non-ischemic etiology. And heart failure recovered EF group was less likely to have LVBB on ECG, more likely to have AF, so more things you could correct. Slightly higher LV function at time of heart failure diagnosis and fewer comorbidities. On other hand, predictors of worsening LV function after recovery, older age, longer duration from initial presentation, comorbidities like diabetes or a larger LV EDD. And ischemia, ischemic disease had poorer prognosis, and there are certain biomarkers which have come up, which we'll talk about a little later. Also additional factors were global longitudinal strain had worse outcomes, if there are slightly higher BNP levels or troponin levels, or patients who continue to experience heart failure symptoms or had hospitalization, they had worse outcome. So heart failure recovered EF is better than reduced EF or heart failure preserved EF patient, but not as good as healthy individuals. So heart failure recovered EF patient had better overall prognosis than HFrEF and HFpEF, but the overall survival was worse than healthy individuals. And the mortality, various parameters, hospitalization, it was less than HFrEF and HFpEF, but still higher than healthy controls. And heart failure recovered EF patients can deteriorate. So this was 1800 patients. Nearly 20% of patients with heart failure recovered EF, more than 50%, suffered from death, transplant or VAD placement by 8 years of follow-up. And these patients continue to have clinical and physiological characteristics of heart failure and required continued therapy. Also, appropriate ICD shocks following generator change. Various studies, almost 2 to 36% and a mean of 17% of patients had ICD shocks following generator change even after recovery of EF. Appropriate shocks after generator change, 36% of patients with heart failure recovered EF had appropriate ICD shocks very similar to the heart failure reduced EF group. And this is also important for us that patients with heart failure recovered EF, 12% had their first appropriate ICD shock after generation replacement. This we have seen in our clinical practice a fair number. So heart failure reduced EF, recovered EF at the time of generator replacement. Currently no guidelines for HF heart failure recovered EF patients, but 70% of heart failure recovered EF patients receive appropriate shock therapy at an average of 3.2 years. And improved EF at follow-up is not predictive of reduced appropriate ICD therapy. Coming to CRT population. So CRT patients, this is MADIT CRT study, 700 odd patients. Patients were either super responders, more than 50%. They had the risk of ventricular arrhythmias reduced by 76%, or those with recovered EF between 36 to 50% had the risk of ventricular arrhythmias decreased by 66%. So fair amount of decrease in ventricular arrhythmias in these recovered EF patients. And this has also been studied in various other places. But what is important is, although the ventricular arrhythmias were reduced, but still these patients had 12% risk of ventricular arrhythmias in the 2 years following initiation of CRT. So low incidence of ventricular arrhythmias and heart failure recovered EF super responders, but there is still 12% risk of ventricular arrhythmias. So the risk is low, but it is not zero. Some patients may benefit from continuation of defibrillator therapy more than others according to the etiology of the cardiomyopathy. So patients with, when you compare ischemic versus non-ischemic heart failure recovered EF, the patients who had non-ischemic recovered EF, they fared a little better. Those patients with ischemic etiology, they had a higher incidence of ventricular arrhythmias. So ICD generator change recommended for most patients with heart failure recovered EF, especially if they have a deleterious genetic mutation. We'll heard a lot about lamin mutations today. If there is history of appropriate shocks documented, or the ECG remains abnormal. So these are clues which you can help. And as a rule, CRT should be maintained because electrical dysynchrony and forward LV remodeling are known to recur with loss of revascularization. On the other hand, you have risk of ICD or device replacement. So almost 8% of patients will have major device-related complications in the ensuing 6 months after device exchange. And those who are undergoing lead extraction, etc., the mortality could go above 1%. So is there something which will help us beyond LVEF, imaging, etc.? So a little more data about MRI, echo, and biomarkers. The Gaudy CRT study used contrast-enhanced imaging, and they looked at the scar size, heterogeneity. Increased scar parameters were associated with appropriate ICD therapy, and if the scar mass was less than 10 gram, it was associated with a 100% negative predictive value for appropriate ICD therapy. So something we can go by. LG was associated with ventricular arrhythmia, transmural scar extent, scar mass was all associated. Greater scar mass, scar heterogeneity, entropy, that is variation in signal intensity, higher border zone channel mass, all indicated towards higher risk of fibrosis-related ventricular arrhythmias. On echo, there is something described as relative wall thickness. So a low relative wall thickness was associated with higher increased risk of ventricular arrhythmias. And every 10% increase in relative wall thickness was protective. There's 34 to 30%, 36% reduction in subsequent ventricular arrhythmias and sudden death. Another thing people are looking at is strain echo, mechanical dispersion. The worse it is, this is predictive for ventricular arrhythmia. And certain biomarkers, the most common among them talked about is soluble suppression of tumor. It's a predictive factor for SCD. Elevated ST2 increase the odds of sudden cardiac death by nearly 40%. So these and NT-proBNP are indicators which we can use that there is still underlying disease going on, and we may not, although there is heart failure recovered EF, should not take these patients a little too lightly. So this is a summary of all these things which are looked at, predicting LV reverse remodeling in patients with heart failure reduced EF. So now comes to what we talk about, shared decision making. So whenever we come to this juncture of patients with heart failure recovered EF, there could be a spectrum. So scenario one is patient with heart failure recovered EF, history of known ventricular arrhythmias, recent appropriate ICD shocks. In addition to continued medical management, it makes sense that replacement of the device would have significant benefit to this patient. So in this patient, obviously, you would go ahead and replace the device. Patient with who is a super responder, EF more than 50%, low risk features of ventricular arrhythmias like non-ischemic cardiomyopathy, no factors associated with reworsening of LV function, like older age, longer duration, diabetes, increased LV dimensions. Or if the patient has had severe anxiety due to the defibrillator, inappropriate shocks, has had a complication from ICD, it may be an option not to replace the device, but obviously it has to be a shared decision and not to be taken lightly. These are two extremes, but the vast majority of patients are going to be in between. So heart failure recovered EF, mixed picture, borderline improved LV function, some factors that increase risk of worsening EF like dilated LV. There have been some minor complications from ICD. So then the issue of additional imaging could assist you in deciding. So CMR, LG, scar mass, entropy, border zone mass or wall fibrosis, that may help you take a decision, echo the wall thickness, mechanical dispersion, strain, all these factors can be taken into consideration. Most of us would err on the side of safety and replace the device for the patient. So just concluding, there is appreciable risk of ventricular arrhythmias in patients even with heart failure recovered EF. 17% of patients with heart failure recovered EF receive appropriate ICD shocks following generator change. Almost 12% will receive their first appropriate shock after the device change. Patients with EF less than 50%, ischemic etiology, have highest risk of sudden death. We need standardized definition of heart failure recovered EF. You need to look at the etiology more carefully. And these additional factors like CMR, echo, all the biomarkers may help you. Shared decision making would always is what we talk about nowadays. Thank you.
Thank you for that presentation on a very difficult topic. I mean, it's not like you can't really put a finger on it and say yes or no. One of the comments I'd like to make is that most of the data on the recovered EF is actually pretty old. And it's not in the current era of medical therapy, which we know is far superior. The current heart failure medical therapy is far superior to what used to be. Most of the data is published 10 years back. And the medical therapy would have been, what was there 15 years back. So I'm not sure what to make of it.
Yeah, so none of this is with SGLT2 or ARNIs or anything. Yep.
Can I ask a quick question? So, Ajay, you've covered almost everything, but just in a couple of patients, in my experience, when CRTD for a non-ischemic cardiomyopathy comes for a replacement, has had no ventricular arrhythmias whatsoever, and super responder, LV function is good, to replace it with CRT or continue with CRTD. And I have done EP study with the old device, and EP study shows no inducibility. I have dared to cut down from a CRTD to CRTP. The reason in our context is because the device is not free. See, if the device were free of cost, I would have erred on the side of replacing the CRTD.
Yeah, but now that option will go away. Once you have the DF4 leads, you will not be able to step down from CRTD.
So we were fortunate that we are talking of era when DF1 were available, yes.
Yeah, no, sir, but adapters, they are not giving it here. Adapters are available for converting from DF4 to DF1 devices.
Yeah.
Thank you, sir. Thank you very much.
I think the issue is basically from ejection fraction 35 to 45% or 50%. More than 50%, I think patient is reasonably safe, because even if the VT occurs, he's not going to die by and large. This is what my assumption is. Of course, if you know the appropriate shock was in the VF zone in last 3 years, that patient even with the 50% ejection fraction, I will be concerned. But I think if there was no appropriate shock for last 3 years and ejection fraction is 35 to 45%, I think there is no study, but I think doing an EP study, as he mentioned, will be very useful. If you are not able to produce any monomorph VT, those patients hopefully will be safe.
Thank you, sir. Next talk is by Dr. Amit Vora on inflammatory cardiomyopathy, device selection and how to program the device.
I must thank the scientific chairman for selecting this topic, because it really made me think and review the literature on this subject, and honestly, from whatever I reviewed, I found more questions than answers, and therefore I think you will have to bear with me in terms of, I'm going to basically talk about what my understanding of this subject is, rather than being very sure and thorough of the problem we have. Now, this is a new terminology that is coming up, arrhythmogenic inflammatory cardiomyopathy, and this, as electrophysiologists, we are seeing because patients with non-ischemic cardiomyopathy are being referred to us for ventricular arrhythmia management, and as EP specialists, we often tend to do additional imaging, and we pick up inflammation with PET, FDG PET, or cardiac MR. And as Narasimhan pointed out earlier, if we want to look at myocardial inflammation, it is FDG PET which is much more superior. And a brief note that in the early stages, you will have a perfusion which is completely normal, but an abnormal FDG PET uptake. So this is the early stage of the disease. And in the late stage of the disease, you could have a perfusion defect with or without a FDG uptake. So if there's no FDG uptake, it's a burnt out old disease. So that's how we come up with these people. And you realize that the non-ischemic cardiomyopathy group is a wide spectrum, and it is the etiology of the non-ischemic cardiomyopathy which is equally important. So far, all the device trials, they would just club into ischemic and non-ischemic, but the behavior of the disease significantly also depends upon what the etiology of the underlying non-ischemic cardiomyopathy is, and many of them we know that it is the viral myocarditis going on to the non-ischemic cardiomyopathy group. So past infection is probably one of the commonest. And the other thing which we see is sarcoidosis as an autoimmune that we see keep on seeing more and more of such patients. So this is the group of people who land up with arrhythmias and inflammation. And now in terms of when they have these ventricular arrhythmias, what type of device to select. Before that, a brief about device indication. So if you take the group of myocarditis cardiomyopathy, in the acute phases, some of them have ventricular arrhythmias and bradycardia and AV blocks. Now, what do you do about these patients when a time comes when they have stabilized from their myocarditis and a time comes when you're likely to discharge them? Now, the general concept, and that's what I also follow, is that despite them having arrhythmias in the acute phase, you have started all the supportive therapies, and over a period of time, there is likelihood that this myocarditis recovers. So it's 1/3 of the patients do tend to progress and have a worst LV function status. 1/3 would remain the same, and 1/3 would completely normalize also. So in the acute phase, it's very difficult for you to decide, and therefore one would err on the side of optimizing medical therapy. And despite there being ventricular arrhythmias in the acute phase, just like a primary VT-VF in a ischemic setting, the understanding is that you wait for a few weeks to few months for the heart to recover and your stability to come up, and then take a decision in long term. But unfortunately, there have been sufficient data coming up in small trials that when you have conserved these patients with presentation as ventricular arrhythmias with acute myocarditis, the 1-year attrition rate is pretty high. There is a 20% chance of sudden cardiac death in the first year, and therefore people recommend that as a ICD should be considered if there has been hemodynamically unstable VT-VF. Even the acute phase, the class of indication is class 2A, level of evidence being C. But in the chronic phase, beyond a couple of months, ICD would definitely be indicated if there has been a sustained monomorphic ventricular tachycardia, class 1C. So secondary prophylaxis, there is no question that they would get the ICD. As a primary prophylaxis, obviously when you have a lot of stormy acute phase, you would ideally want them to be on a variable cardioverter defibrillator. There is some evidence to that. Unfortunately, we don't have it at all, but that's something which is considered in many centers. And of course, in people who have a chronic, those who are in the chronic phase, the primary prophylaxis is considered with ICD in those who have a persistent LV dysfunction. I think what we are not sure of, because in these group of patients also we tend to do imaging, and if we have an LG positive, if you have fibrosis which is we identified, but the LV function is improved, the LV function has become 35% or more, and you have not had any arrhythmias to begin with, what should we do? Should we give an ICD or should we consider an EP study before implanting an ICD? I think the other group which is important is cardiac sarcoidosis. And cardiac sarcoidosis, we know that ICD is indicated if you have as a secondary prophylaxis, as a primary prophylaxis in those people with LVF less than 35, those with AV block should get an ICD. those with LVF more than 35 but with significant LG uptake, where we still struggle with what is significant LG, more number of segments, percentage is not very clear, but more than 20% is generally taken. But these are class 2A indications, class 1 indication being clearly the ones as secondary prophylaxis and those with significant LV dysfunction. And of course, there is data coming up in those who are LG positive but good ejection fraction. They also, so sarcoid patient, despite having a good ejection fraction, they may have ventricular arrhythmias and sudden cardiac arrest, and therefore the role of LG and also programmed electrical stimulation to induce VT, and if they are inducible VT, then probably to consider an ICD for them. Now, the type of device which we need to select. So basically, it's single chamber ICD, dual chamber ICD, and I think in terms of myocarditis cardiomyopathy, most often when pacing is not the need, a single chamber ICD should do. If you have a bradycardia or a pacing indication, then obviously you'll put a dual chamber ICD. And in some people, you could potentially, as a primary prophylaxis, consider even a sub-Q ICD in the younger group of individuals. With sarcoid, it becomes more often that you are going to use a dual chamber ICD because AV block bradycardia is a significant burden to them. But yes, there are some people who may have only ventricular tachycardia, and you could do with single chamber ICD when there's no pacing indication. And yes, in people with LV dysfunction, you will have to think whether he will benefit from biventricular pacing and cardiac resynchronization therapy. Those who have AV block, percentage of pacing is going to be high. Then you will have to think in terms of also, doing a coronary sinus or a left ventricular pacing to improve the resynchronization. One should have a high threshold for a left bundle area pacing in sarcoid patients because the basal septum tends to get affected more frequently. So maybe imaging would guide you whether you could consider doing a left bundle area pacing as a backup when you are planning to do a CRT, but that seems to be less likely, and you'll more likely require a coronary sinus lead. In terms of the programming of the ICD, again into two groups, those with cardiomyopathy, non-ischemic cardiomyopathy group generally, I would say that we should realize these are young people and it's better to keep a very high VT detect rate and longer intervals to detect the VT also. This is very often the need so that we don't have inappropriate therapies happening. And the number of ATPs may be very minimal, especially if it's been used as a primary prophylaxis. But aggressive ATPs would be required if a patient is presented with sustained monomorphic VT and scar-related arrhythmias is what is suspected. And then you have multiple ATPs with more number of stimuli also being given. Normally 5 to 6 is the burst which we give, but 8, 10, 12 may help to terminate these reentrant arrhythmias more frequently. Pacing in these devices, obviously you'll keep a lower pacing rate. Unnecessary pacing, the ventricle should be avoided. And in terms of SVT discrimination, again, it depends upon what stage of the disease the device has been put. If you think that inflammation is the cause of ventricular arrhythmias, often automaticity is the likely mechanism. There might be wobble of the tachycardia cycle length, and therefore you might want to keep the SVT discrimination criteria off, especially the stability criteria. But if you have a scar or a re-entry variety, then you might want to have these on. And yes, whether we should do a programmed electrical stimulation before choosing what kind of programming we would do. So whether ATPs terminate the arrhythmia, if we understand before, at the time of implant, it would be helpful. In sarcoid patients, we know that it is scar-related arrhythmias most often, and therefore multiple zone programming with aggressive ATPs is required. And I think it's a reasonably good tool at the time of implant to do a programmed electrical stimulation to see what ATPs work for him so that you can program it accordingly. And sometimes they have a high PVC burden, which may also lead to VT-VF, and therefore doing a higher atrial pacing might work in some of these people to suppress the PVCs. Optimizing the AV delay, improve the diastolic filling time and LV function is important. And not to forget that ICDs in these group of patients also tend to have higher appropriate therapies than the the other cohort of patients, especially in sarcoid, and there is a high incidence of inappropriate therapy also happening in this group of patients. So this is the registry data, so we need to look into this a little more carefully for us to understand this. I think in the interest of time, I will just briefly say that in our country, myocardial tuberculosis is also not unknown, and this is our series which we had presented, where almost 30% of granulomatous VT tuberculosis was found, and therefore in tuberculosis we have a good response. They may present with VT, but the anti-tubercular therapy, the steroids given, can lead to a complete resolution, and many of them don't require an ICD, and therefore we should also not forget, when we managing these patients, that role of antiarrhythmic drug, immunosuppressive drugs, appropriate use of ablation, and cardiac sympathetic denervation for rapid pleomorphic VTs is worthwhile. So in conclusion, I would say that arrhythmogenic inflammatory cardiomyopathy is an entity which we need to recognize and tailor the treatment. FDG, PET and cardiac MR, these imaging are gaining importance in understanding them better. We need to have a ICD selection and programming customized to the patient, and EP study may have a role, and I think ICD is always in conjunction with all other therapies for this group of patients. Thank you very much for your patient listening.
Thank you, sir. Very balanced presentation you have tried to make. Anyone is having any queries?
Just a comment that in sarcoidosis, I think from the beginning we should give it a double chamber ICD. Why? Because first of all, future AV block can occur. Then many of these patients have BPCs or non-sustained VT. You may need drugs, beta blockers plus amiodarone. They have cardiac. So it's better to just give from the beginning a dual chamber. You may not use it initially, but when the need arises, you can use the atrial.
Agreed. It makes a lot of sense in sarcoid to have a dual chamber ICD as a first step, yes.
So, small question. You have a patient, you have some inflammatory cardiomyopathy, whatever may be the cause, sarcoid, or you don't know, or viral patient has a VT storm, young patient recovered now, whatever drugs you have given. So, you are very sure that now you will send the patient back without any device. Patient is in VT storm, stabilized, you have given drug, maybe I'll remove TB from the picture, maybe some myocarditis, maybe sarcoid, or you don't know, or viral, but settle completely with the acute therapy. You will send him off and say that, no, we will not need an ICD. EF is normal.
Yeah. So I think that's where we again look at the imaging. So if the imaging does not show a scar burden, then I would be confident in saying that whatever therapy, obviously some immunosuppressive therapy has been given, or some which has stabilized things. So I think imaging and showing a scar burden is important, because some of the people may improve in their ejection fraction, but that does not mean that they don't have a scar burden. So if the scar burden, and yes, the question is that what is actually the extent of scar that you're looking at. I think the distribution of the scar, the number of segments the scar is present, and the percentage of scar, all these things are important. This is something which is evolving and we are learning about it. But yes, in short, I would look at imaging. If there is a scar, I would favor an ICD.
So I think there is something overlap between the genetic and the inflammatory cardiomyopathy, because it is not that all inflammations are due to sarcoid or some this thing. So even a lamine cardiomyopathy can show some inflammation. So would you suggest us to do genetics in these cases, and does that tailor your management strategy?
So I think this is a recent evolution that is happening. So the people have questioned that why some myocarditis go into developing a cardiomyopathy picture and some of the myocarditis resolve and improve. So when they studied both these groups, they found that there is a genetic proneness in some people to progress towards cardiomyopathy, and in some it is not. But I think this is still in the research phase where it's being studied, and I think it may be good for us to learn and know, but I don't think we have the handle how to interpret it.
One query more I want to talk to you. At an acute phase of the disease, so you have a monomorph VT, for example. It could be because of two mechanisms, either re-entry or automaticity. So we don't have any clinical way to differentiate between these two. So whether you want to give ICD in acute phase do you think the EP study will be useful in those patients?
Yeah, I think this, so this is...
because hopefully the automaticity will be suppressed with the immunosuppression and the healing of the... but if a re-entry, it's a scar-based, that is going to be there. That is not going to be...
I think this is also we are understanding that the scar formation, we generally understand that scar formation is going to take few weeks, months, or going to happen later, but that is not necessarily true. It may happen early, and I think Narasimhan had this paper, even in ischemic heart disease, in the acute phase, 7, 8, 10 days and you have a monomorphic VT as a presentation. So I think if you have a VT as a presentation, my threshold for implanting an ICD would be low enough. You may have stabilized him with all therapies, but you should have a low threshold to implant an ICD, especially with monomorphic VT. That tells you re-entry, that tells you scar. We can additionally do imaging to confirm that, but yes.
See, even the cardiac MRI, for example, is not going to tell us whether the mechanism is re-entry or automaticity, because we are talking again the quantity of scar. So it's very difficult to differentiate between these two entities. So I think maybe there is a role of VT stimulation even in a relatively acute phase.
Absolutely. I think we, though we rely very heavily on imaging, we have to realize the limitations of imaging. One is every Tom, Dick and center does imaging. They come up with some reports and we are unable to interpret it. And as clinicians, we'll have to take a call whether it's, what is the state. And that's where I think in some of these cases, the EP study might be worthwhile. Yeah, Narasimhan.
Thank you, Amit, for a nice talk. There are a couple of things. It's extreme. This is not theoretical. It's very important to decide whether you're going to put a device or not. If you're planning to put a device, please put it in before you start steroids, because steroid-related complications, wound dehiscence, infections are common if you give it after loading them with steroids. Second thing is the misconception that tuberculous myocarditis doesn't need a device. We have had patients at the end of 4 months, 5 months coming with incessant VT due to tuberculous myocarditis as the scar phase happens. So that is the second one. And third is, in programming the device, we have observed that there is a delayed detection of VT in these patients because of varying cycle length. So it tends to bin it as atrial fibrillation and delays the delivery of shock. So if you have sarcoid VT, we would be a little less aggressive about positioning the cycle length variability in these patients.
Yeah, I think the stability criteria should be put off only. That's absolutely right, yes.
Thank you very much. Thank you.
So next up is Joseph Theodore, cardiac arrest in athletes and managing it. Oh, Joseph not here, sorry, I'm sorry. So Somshekar is here. Okay. That means we're going to have lunch 3 minutes ahead of time. Good.
Just a couple of announcements that whoever wants to participate in the quiz, please give their names to Dr. Rakesh Sarkar or Sanjeev Mukherjee before 2 or 2:30 p.m. today. And secondly, we have a very exciting tech village in the mezzanine floor. So if any one of you wants good hands-on both on EP as well as devices, there are simulators as well as excellent case simulators on 3D. They have a ICE simulator also in the mezzanine floor. Similarly, Medtronic and they also have good kind of newer tools on the mezzanine floor. Please visit the floors whenever you get time. Thank you so much. Let's break for lunch and we'll rejoin at 2 o'clock. Thank you. Yeah, please.
Welcome back, everybody, post-lunch. We'll be starting with the session. As chairperson, I would like to invite on the dais Dr. C. Narasimhan sir. Big round of applause. Dr. Sanjeev Mukherjee and Dr. Sam Asirvatham sir also. Welcome.
Good afternoon, friends. And I think you have been seeing a lot of 3D maps and pretty colors. It's very, very important to kind of understand the role of the basic EP, role of entrainment in this modern day era of multi-point mapping and multi-electrode mapping. I can't think of a better person than Dr. Samuel Asirvatham, who is well grounded in basics of EP and a phenomenal teacher to walk us through this topic. Sam.
Can get the slide up here. Okay. Thank you, Narasimhan. So, spend about 20 minutes mainly looking to see if you have mapping, and the problem at hand is you want to map the VT. Is there still a role for entrainment, and if so, why? So first few things is we have to understand limitations of any kind of mapping. First step is EKG mapping. While for automatic tachycardias, most of you who are experienced, quite easy to look at the ECG, make a very good guess about where you will ablate. But it does not work for re-entry. It does not work reliably for re-entry. The reason is we want to ablate critical parts of the circuit, whereas the ECG is telling you where the normal tissue is getting activated. The circuit is in very complex, hardly alive type tissue, mummified myocardium, but where this diseased tissue houses the circuit can be very different from where you're able to generate enough of a wavefront that you are able to see the pattern on the ECG. So ECG mapping is fundamentally limited in patients where there's diseased myocardium and there's a circuit that's housed somewhere inside the myocardium. And if we take that one step further, what about our electrogram mapping? Same issue. Most of the clearly discernible mappable electrograms will be beyond the place where our ECG QRS onset starts. The challenge is trying to actually find the whole cycle length of the tachycardia within this abnormal tissue. Now, this was pretty much considered impossible, and we relied on entrainment to try to find those critical parts of the circuit and use the ECG and other maps just as a clue where we are having the abnormal tissue. Now, does that change when we have high density mapping? Now, some of the things that make high density mapping as challenging as standard mapping is there's overlapping electrograms from surviving tissue. For instance, we will pick up with just the antenna of the catheter electrograms at sites that may not be involved in the circuit, and surrounding areas that may be peripherally connected to the circuit. All of those electrograms will show up from one data point, and it's extremely challenging without maneuvers to actually try to see which part is relevant, which part isn't for a mappable ventricular tachycardia. Now, if we take a step back, fundamental step with entrainment is not so much to know where are you going to ablate, but to define for yourself that you're dealing with re-entry. And this is a step that I would urge, especially those of you who are new to EP, always take before you start with a mappable VT. And it's a very simple idea. It's pacing faster than the tachycardia. If it is an automatic tachycardia, it will suppress the tachycardia, and you will only see your paced morphology. If it is a re-entrant tachycardia, you speed up the tachycardia, it mixes and fuses with your pacing, and you get a fixed fused morphology that will only change when you change the rate with more and more fusion as you pace faster, looking more and more like your pacing site. This is defining the mechanism that you're dealing with re-entry. Now let's take an example of why mapping of ventricular tachycardia in structurally abnormal hearts is so challenging. One is you have to annotate the signals. So you can get 100 points, 1,000 points with multi-electrode catheters, but the sequence of activation will be dependent on the annotation of those signals. Forgetting about the challenges of automated annotation, even if we mechanically try to do it, to try to see which is the actual moment where activation is going under our catheter is very difficult with abnormal tissue. Straightforward if you have very normal tissue, but that's not the areas that we have interest. There's still a value for the mapping to give you an idea where to kind of focus your entrainment information so that you'll know which abnormal tissue to focus on. Part of that will be voltage, part of that will be speed of conduction. Both have limitations. You can have circuit where the voltage is fairly large because there's a superficial area of slow conduction, and because of overlapping signal, sometimes predicting conduction velocity can also be difficult. There's another challenge with mapping, and that is surrounding tissue may be normal. So what happens is we put our catheter at a site where can be a near transmural infarction, but because of the nearby structures, the overwhelming signal, the large signal that's very easy to annotate and map, has nothing to do with the activation sequence within the circuit itself. Now, with experience, with maneuvers, it is possible to actually map out the circuit, but it's exceedingly difficult. It takes hours, trial and error, re-annotating signals to try to find where it is that we're doing it. On the other hand, when we entrain from that site, we don't have to discern complex signals. What we want to know is if you deliver energy from the distal electrode, are you likely to terminate or affect the circuit, or with a line terminate the tachycardia? All we want to know, regardless of what that signal looks like, is if I deliver energy there. So you pace from that distal electrode, and this is very important that you don't have capture from the anode. Simplest way to do that is to just fix the tip of the catheter and torque the catheter to see if your electrocardiographic morphology is changing. If it is not changing, you only are pacing from the tip of the catheter. If it changes, it's likely there's anodal capture at some site or the other. And then you can interpret to say, if I am getting no evidence of fusion, even though this is re-entry, my post-pacing interval matches the tachycardia cycle length, and I'm clearly in diseased tissue with a long time of capturing small signals before I exit to the normal part of the heart to create the QRS, I am very likely to be within the circuit. Now, there are other side benefits when you try to entrain from those locations. You may notice that when you try to pace, you may terminate the tachycardia. And this can happen because of either local capture or sometimes just subthreshold stimulation causes refractoriness of the tissue underneath your electrode, and that causes the tachycardia to terminate. All of these phenomena, the entrainment, subthreshold stimulation, local capture without global capture, causing termination of the tachycardia, is very valuable information that if you deliver energy at that site, it's not a large isthmus, it's not a large area that you have to affect, you will probably terminate the tachycardia. So the strengths are clear. That is, you can be very specific in predicting what will happen if you ablate without the need for sorting out the local electrograms. But the primary weakness of entrainment mapping is you have to have a mappable tachycardia. And this is the real value of high density mapping. So they are like adjunctive uses. The high density mapping is getting you finer and finer and finer information on what's normal tissue, what's abnormal, what's totally dead tissue, and what has surviving myocardium. So a combined type approach, which is probably the most common approach if we take maybe 60-70%, is if there is a mappable tachycardia, then map, get an idea with the map, and then focus the entrainment, find the area that's likely to terminate the tachycardia, ablate, but then you have to address the substrate. So that initial map itself is serving two purposes: to know where are you going to do the entrainment and where are you going to do some kind of substrate modification. Now, the early types of substrate modification really tried to kind of cut off the entire abnormal area. This is extremely difficult to do, and even small gaps will create recurrence of tachycardia. Field has completely changed to where there is really no attempt anymore. I don't believe anybody is trying to do that, but rather, with the use of the high density mapping, try to find the sites within that area of low voltage that are housing abnormal tissue. And our main clue to that abnormal tissue is abnormal electrograms. And although there is a difference in meaning when we see multiple near field signals, or we see some near field and some far field signals, or we see discrete delayed signals, in the context of substrate mapping, it probably doesn't matter. If it's living tissue with abnormal signals, there is very little downside to ablating that site. That's not myocardium that's going to contract, and it could be a slow area of conduction for a variety of tachycardias. It really has made electrophysiologists think what we mean by scar. It's clear. In our world, we don't mean dead tissue when we say scar. We have to distinguish those when we are doing our mapping. Sites there is no discernible electrogram versus sites where we have abnormal electrograms. Now, some of the areas that we have to deal with that are difficult with substrate mapping that still has value with entrainment, even if we don't have a long duration tachycardia, is to get an idea of why we still have inducible tachycardia after we have done some amount of substrate mapping. And the idea there is, have we missed a scar? Is it deep in the tissue, or is epicardia? So here, for example, if we have signals that are clearly abnormal, and yet you've ablated trying to get rid of the signals and you have continued tachycardia, if you induce the tachycardia stable for enough time to do entrainment, you will find a bystander response. That is, you are able to entrain the tachycardia. The morphology is very similar to the tachycardia, but you have a long post-pacing interval. That's a clue that the reason for your failure is you're in a bystander channel. And then you think for yourself, where all have you ablated around it? And if those sites are already taken care of, then you think about this construct that the circuit may be deeper in the tissue or epicardial, and you'll map directly in those locations. Few other caveats about why mapping alone for a mappable tachycardia is challenging is because catheter orientation can give you very different signals. Same location, but perpendicular versus parallel for bipolar recordings can make you think it's normal tissue with easy to annotate signal, or it's extremely complex tissue in that same location. The same thing, something I believe you'll hear later in this meeting as well, is the wavefront of activation changing can give you innumerable patterns of electrograms. This is okay when you're doing substrate, but when you're actually mapping a tachycardia, if there's that much change with small changes in wavefront or small changes in catheter orientation, it's essentially impossible to try to map the circuit. Other examples is where you have very small signals for reentrant VT or reentrant PVCs. Sometimes the abnormal signals can be within the QRS itself, drowned out by the normal tissue, normal signals that you see in that region. Example from a patient, multiple shocks, but you get an idea of where the abnormal tissue is, but it's not just one. There is one area, there's another area, there may be channels between that area. Doesn't take much duration to induce VT and entrain at critical sites, maybe 3 sites, to tell you, here's my high yield area that I need to be sure that I'm hitting the critical areas, and I will do my maximal effort at substrate mapping. Now, we should know that in some variants of cardiomyopathies, heavily favors mapping versus heavily favors entrainment, linear ablation, and checking for block. I'll just give 2 opposite areas of the spectrum. Right ventricular cardiomyopathy, entrainment is very difficult. And the reason is you have layers of issues, fat, scar, epicardial, some endocardial, aneurysms. So entrainment there, the problem is too much tissue is captured and can give you pretty difficult to interpret results. The primary method for VTs with arrhythmogenic cardiomyopathy should be substrate, and when you're left with a minimum number of VTs, then map and then entrain to find the critical area and ablate. Contrast that to, for example, tetralogy of Fallot VT. Here, entrainment is key because you have a discrete number of areas that can be isthmuses. And all you need to know is which is the critical isthmus for the main VT, and be sure that you have ablated, you have anchored your lesion, and you have block across that site. Here, doing a large substrate map like you do for arrhythmogenic cardiomyopathy will probably give proarrhythmic lesions without confidence that you've ablated the main tachycardia. It's very important when you do have a discrete isthmus and you are doing a line anchoring to sites that you check for block. Good thing to keep in your mind is when entrainment was key, but it's not a small isthmus, check for block. And you can always check for block wherever it is. You just need one electrode for pacing, one side of where you ablated, and then make sure the wavefront of activation is around that area of activation. So to summarize, with high density mapping, night and day, the accuracy of substrate mapping. But for mappable VTs, there hasn't been that much gain with high density mapping, mainly because of the trouble with annotating signals and finding your activation sequence. Skill of entrainment combined with areas which you want to target can give you success in both of these scenarios. Thank you for your attention.
Focal, you go with an idea, patient has a old infarct, multiple problems, but so you're surprised to see it's focal.
Yeah, very much so. So, there's two issues. One, normal heart, ventricle, you will not find re-entry. Normal heart, other than fascicular re-entry, you're not going to get re-entry. So, but in abnormal heart, there's nothing that says you won't get automaticity. In fact, ischemic border zone can be focus of automaticity. Purkinje can be focus of automaticity, especially in ischemia or some cardiomyopathies. So you have to be alert to automaticity. But many times in badly damaged hearts, what we think is automaticity is probably localized re-entry. And to get truly automatic, unusual, but be alert if you're in the outflow tract, if you're in the area of the fascicles, if you're in the papillary muscle region. Be alert, very easy, pace faster, never get fusion, suppress the tachycardia, comes back. You're dealing with automaticity, then much easier approach to try to map and ablate.
So when you are seeing a VT, which is otherwise hemodynamically stable and can be mapped, in that case, do you want to induce the VT first and do an entrainment, go to a suspect area, or you want to do substrate first and then go to a area of the substrate and then induce the VT?
I mean, you can do either way, but my method, my way of doing is if you have a clinical VT or think you have a clinical VT, you're inducing VT and it's stable, that's golden opportunity to map and ablate. But I still map the VT. One, you're getting a very good idea of substrate. Second is you will have a good idea where to focus the entrainment, where there is slow conduction, where voltage is abnormal, where you have bystander signals. You will also get a good idea where not to entrain. For example, there are some areas where you will see the electrograms are not keeping time with the tachycardia. It's diseased, but these are bystander sites. They can have Wenckebach, they can block, sometimes you see, sometimes you don't. Waste of time to try to entrain in those locations. So I do definitely will map, but it's more for what to do after we have ablated the tachycardia.
Then substrate mapping again after ablation?
No, you can do the substrate map during VT if it's clearly abnormal area and the rest of the heart is normal. There isn't that much value to repeat the map with ventricular pacing, left ventricular pacing. But if you have multiple discrete scars, then your pacing wavefront becomes very important in trying to find where the signals are split. So some types of like post-myocarditis types of situation. There also you have to ask yourself, am I really going to do substrate map or am I going to focus on the main VTs? If the goal is to substrate map in that patient because 17, 18 VTs, then it's a good idea to have one in your stable VT and one with pacing. And choose the pacing site to be orthogonal to the exit site of the tachycardia. So if exit is on the septum, then do RV outflow pacing. If exit is near the apex, then do LV free wall or septal pacing.
Thank you.
Isn't it that the low success rate of the sustained monomorphic VT ablation in structural heart disease is related to the three-dimensional nature of the VT circuit? Because then your high density mapping doesn't pick up a part of the circuit. and your entrainment mapping doesn't always give you a good return cycle length because the isthmus is mid-myocardial or something like that.
Yeah, you're right, but there's a difference between the two things. So when you make an error with mapping, there's no information you're getting with it. In other words, it can be misleading because you took the wrong signal. But when your entrainment is off, you still have information. So if you have 3 sites on the endocardium and your post-pacing interval is exactly 30 milliseconds more than the tachycardia cycle length, 3 different sites. Even though it's off, all 3 are in the circuit. But on the other hand, if all 3 are off and you have a different QRS for each, then there's something deeper or on a direction you didn't map where you actually have the circuit. You can also entrain at high and low output. And if high output finds that you're in the circuit, although the morphology is fused, that's also telling you. And the output that you needed to get that will give you an idea of the depth that you need to get to. So while it's true both have errors with 3D circuits, mapping errors, they just don't help. But entrainment errors, if you're alert to what it's telling you, will give you clues what you should do next.
Beautiful insights, thanks.
Most of the VT, post-MI scar VT is usually so fast, hemodynamically unstable, majority. So we are bound to substrate map rather than entrainment map.
Yes, that's correct. But you will also have a lot of patients that have been on amiodarone, some other drug, doing pretty well, and then have a VT, ATP worked for some time, stops working. Those patients, usually you will have enough time to map the tachycardia. So some things you have to think about, how are you going to sedate, avoid any vasodilating type of anesthetic agents. If possible, try to slow the tachycardia. Give breaks if you're reproducibly inducing. Give a chance for recovery. And if it is a redo 5th time, 6th time procedure, then I don't hesitate putting the patient on ECMO and then mapping and getting rid of it. So sometimes patient is coming, they are going to hospice, they are having this multiple shocks, 4 or 5 ablations have been done. Then you just do everything you can to try to map and ablate the tachycardia.
So if there are no further questions, I'll now invite Dr. Ajit Tachal from Lissi Hospital, Kochi for his talk. Dr. Ajit.
Good afternoon. Thank you to the organizers for giving me this opportunity to talk about what would be VT ablation in the hemodynamically unstable substrate, in the unstable patient. So, I don't think it's a great idea to overdo the drugs because we are scared of mapping or ablating a hemodynamically unstable VT. I think it's worse than trying to ablate. Of course, we have to anticipate that the VT may be hemodynamically unstable. And in extreme cases like Dr. Sam alluded to, we might just institute prior mechanical circulatory support and then just go ahead with inducing. But I'm not going to talk about that. I'm going to talk about how to identify and ablate the abnormal substrate with or without inducing the VT, usually without inducing the VT before the ablation. So I'll just start with this tracing. So here is a patient who is in sinus rhythm. Here's the sinus beat. There's a potential after the sinus beat. And then a ventricular tachycardia starts. Let's try to understand what this means. So this would be a putative scar. And I would think that this scar, like Ashish alluded to, we have to think of this in 3 dimensions. Even though this picture is in 1 dimension, we need to think of this in 3 dimensions. So this is the easiest part to understand. That is going around this scar and producing the normal QRS, and that is producing this normal electrogram with the QRS. This electrogram, I would assume, would be either a conduction into a blind channel or a conduction into a potential isthmus which couldn't propagate and therefore just stop there. But what we are interested in is in the next electrogram which has started the ventricular tachycardia. Now, see, this is all of these electrograms, I would think, is because a circuit has now developed in that myocardium, and part of it is slow. So how exactly did this circuit develop? I would either think that either the conduction which was blocking here now found a way to get across there. It was no longer blocking, so it was going across. Or maybe the conduction changed from the slow to the blind channel to going through here. The resistance to conduction in this area is no longer there, so it's going around. So now the key is, how are we going to look at this and guess that this is going to come from here? So that is essentially what I'm trying to say. How can we figure this out? Now, a few more questions. That is in sinus rhythm. If we pace, like Dr. Sam said, and we made a different wavefront, will it make the conduction slowing areas more obvious? Will different wavefronts of pacing make these conduction slowing areas more obvious? Does the rate of pacing matter? This is a patient, same patient we are pacing at 600 milliseconds, this is at 400 milliseconds. You can see that there is some delay here, but there is more delay here when we are pacing at 400 milliseconds. And does the multiple wavefront matter? Well, if you look at the data from Chicago, from Rod Tung's group, they said that actually the pacing, sinus rhythm versus RV pacing versus BiV pacing versus LV pacing didn't make a difference in the zone of maximal decrement. But then again, that paper had limited number of patients who had LV pacing or BiV pacing. It was not expressly made to look at that particular issue. The paper which was specifically looking at this issue was the Physio-VT by Anter et al., which basically said that, well, the area of maximum decrement is more or less the same, but it said that it increases a little bit if you put multiple wavefronts in it. It said that this is the area of maximum decrement during atrial pacing. It changed a little bit during RV pacing, and it changed far more during LV pacing, to the effect that they ended up ablating more areas. If you put a number to it, they said 60% were identified during atrial pacing, but the other 40 they required RV or LV pacing. I have not put up all the figures. They have also put up LV pacing from multiple areas of the LV. So the paper which specifically looked at it said that yes, it makes a difference where you pace from. So that's the figure I was alluding to. So their area of ablation extended from here to here, and they finally ablated all the decrementing areas. Now, another question, should we use extra stimulus or should we just pace continuously? Now, logic says that if we want to find a slowly conducting or decrementing area, we put an extra stim. The original paper had only a limited number of patients, but this concept, and it used only bipolar electrograms, but the concept has been reconstructed with multipolar electrograms, and it seems sound that you do use extra stimulus. And finally, are all the signals from the surface being mapped? We are seeing all these signals on the omnipolar catheter, but are all of them from the part we are touching? If they are they because of local slow conduction, or is there a line of block between here and here, or is there conduction through a remote layer of tissue? Like, what I mean is, when we see these signals, we tend to think that it is because there is slow conduction happening through here. It might very well be this also. The wavefront might be just digging somewhere deep, and we might be just picking up the far fields from here. So these are limitations which are bound to exist, but we must keep this in mind that what we are seeing may not be coming from there. It's virtually impossible to look at the signal and say, okay, this is from under my catheter, this is from far from the catheter, unless you use some entrainment principles, and we are not going to entrain from here. And finally, the so-called isochronal late activation map. Here I've used a voltage ID of 0.1 because the system was noisy below 0.1. Ideally, you're supposed to use 0, so you get all the signals. Now, you can see that we are pacing from the right ventricle. This is the septum. This is the earliest activated area. This is the last activated area. But that's not what we are interested in. Let's take a closer look at that picture. You can see that there is an activation wavefront which goes from here, from the septum, and then slows down here, and then goes into this area. A similar wavefront goes here. This mapping is not all that good because there are no points here. This point is extrapolated. That shouldn't be the case ideally. So we should have points throughout the circuit. And you can see that it slows down here, but finally it goes into one area. So this last area is being protected by an area of decrement all around it, which is not the case with these three late activity. Of course, you first make sure that the signals are correct, that they are late. It's like you have very early and very late. That's just basically a line of block. There is no activation going on from here to here. It's just line of block. It's just going around and finding its area there. So they've defined a deceleration zone by the paper from Rotting et al. As 3 isochrones within 1 centimeter, Anter said 4 isochrones within 1 centimeter. Basically, what we are looking for is 3 isochrones crowding together, or isochronal crowding, not the last activated area. Now, you can think of last activated area as a potential exit site of the VT circuit. So that's not the area that we're interested in. The slowly conducting area rather than the latest activated area are likely to sustain reentrant ventricular tachycardia, so ablate them. Now here again, let's take a deeper look at this. These signals are different from these signals. We are pacing faster, but are we seeing slow conduction into just blind loops? Or is it that this particular channel is unable to sustain 1:1 conduction even at 600? So, it's very unlikely to sustain at 400, so it's unlikely to sustain a VT. We don't know. The answer is we don't know, but we have to keep these things in mind when we see these signals. And what about future VT isthmuses? Well, a channel which is not active now might become active in the future. So why don't we just knock out all the channels in the low voltage areas, all the relatively late activated? It's okay. If the patient is stable, I think it makes sense to first concentrate on the decelerating areas and then knock out all the channels like this. Now, are all VTs in patients with scars reentrant in nature? Well, Dr. Sam just alluded to that they're not. Like, for example, this is a patient who had 26 episodes of VT, a septal MI. You can immediately make out that this is coming from the fascicular system just by the QR morphology that everybody is sensitized to by the left bundle pacing. So this is what was going on. Shocking, and VT is not reverting. During the EP study itself, there were 27 episodes, but during a small gap in the VT-free period, we could find that this was actually being triggered by a Purkinje. So I have not put the sinus rhythm here. In sinus rhythm, this was the left bundle and this was before the Purkinje. So there was actually a retrograde block into the left bundle during the Purkinje fiber firing. And that Purkinje fiber firing was what was triggering the VT, and we could ablate the peri-infarct Purkinje fibers. And this patient has remained VT free ever since for the last about, I think, 2 or 3 years. Are all peri-infarct Purkinje potentially arrhythmogenic? Definitely not. In this case, it's clearly a bystander Purkinje fiber. It's there in sinus, but you can see there is no relationship to the VT at all. The Purkinje fibers are just bystanders there. So just because we find a peri-infarct Purkinje, it doesn't mean that that is what is causing this. But I think one of the clues would probably be those rapid changing morphology, polymorphic ventricular tachycardias coming from areas of Purkinje fibers. It's reasonable to assume that if you have Purkinje fibers around there, you take them off also. And are all the isthmuses on a mappable surface? Definitely they would not be. So this is a patient who came while being shocked to the hospital. She was being continuously shocked, and about the earliest electrogram I could get anywhere on the endocardium was this thing on the LV side of the septum. The RV side is worse. So we just put a wire into the distal LAD, agreed it's a unipolar recording, and that was the earliest I could get. That doesn't prove that it's coming from there, but at least some idea that this is coming from an intramural substrate. Well, the only thing I could do, and this patient was having incessant VT, it would shock and it would come right back, and that's where you have to take a little bit of an agricultural approach. I had to do bipolar RFA in the entire distal septum during ongoing cardioversion. There was no time to take my hand off the catheter, so shock, you just keep ablating while shocking. You actually gave 122 shocks during the ablation, and this was 6 years back. Patients not had a VT after that. So these are just to expose some of the limitations of substrate mapping. We will not be able to see everything.
What about pace mapping? Yes, I think if you do get these responses where you can pace map an entire circuit with all the entire range of stimulus to QRS with the same morphology, it makes sense. And there's also a recent study saying that passive correlation pace map with this, that's a VT isthmus. Also, if you would pace map and induce a VT, and then you would see the diastolic potentials during the VT at the site of the pace map, especially if you're pace mapping from an area of late potential, that would make sense. And finally, image guidance has come in. Basically, it says that if you look at the 40 to 60% of maximal signal intensity and put the LV into 10 different concentric layers, and these areas of signal intensity would correlate with the VT critical channels. And if you look at the meta-analysis, which actually has only very small numbers, so I wouldn't put too much importance to it, it says that it's actually better than conventional mapping. Not really sure of that, but at least it's another way of thinking about it. So what are the methods of identifying the endocardial substrate in unstable VT? Voltage mapping within dense scar is not such a great idea anymore. Local abnormal ventricular activity is way too non-specific. Late potential, we might get rid of all late potentials or do a functional late potential mapping, and might do pace mapping if we get those specific responses. Do not forget to map the peri-infarct Purkinje potentials, and imaging may help. This is how to do functional substrate mapping. I'll skip that. And if you do it correctly, you'll get these sort of deceleration zones. This is one thing I wanted to allude to. In this paper, they said from the end of the local electrogram to the late potential was a mean of just 77, which doesn't sound right to me, because if we do it, we do get far more than 77 to end of electrogram to the late potential. So if I got a potential local V to electrogram, let's say 130, 140, 150, even if I'm unable to show that decrement, I would definitely go and ablate that area rather than insist that I must show the decrement, because this 77 just doesn't sound right. So to summarize all that, this is an excellent review for substrate-based approaches. I will just summarize what the table says. This is basically what it says. If you do extensive ablation, it is still likely to work, but the question is, in a sick patient, can we do extensive ablation? If we cannot do extensive ablation in a sick patient, we do a functional substrate map, which may be, these are basically different ways of doing extra stim to bring it out, or multiple wavefronts, or just a single deceleration zone. CMR-based ablation is coming up. I think it's too early to take a call on that. And don't forget the peri-infarct Purkinje potential. If you find them in an unstable VT, just ablate them. They may or may not be the culprit. And pace map from late potentials with a moderate stimulus to QRS delay, not a late potential which has a QRS after a 300 milliseconds. That may be far off. So I'll stop with that. Thank you.
Narasimhan, maybe just 3 quick comments, especially for the junior EPs, fellows in training. Just what Ajit said is very nuanced, but I want to make clear for you, in re-entry, there's no early, there's no late. No matter what early signal you get, you'll get something earlier. So once you have that in your mind, you're mapping re-entry. Forget about the timing of the signals. Your idea is you have to find the circuit, either entrainment or with actually mapping the circuit. Second thing is, when you, during VT, do not focus on just these signals that are between the QRSs. It's a whole circuit. So you will have signals in that circuit during the QRS, during the T wave, unrelated to these two. They are throughout the circuit. These are 2 very old ideas, mapping early, and second is focusing on mid-diastole. Circuit is entire cycle length. Just one comment about peri-infarct Purkinje. Peri-infarct Purkinje is often just endocardial to the infarct, not necessarily in the border zone. It's because Purkinje rely on glycogen mainly for their nutrition. They can survive even in a transmural infarct. So when you say peri-infarct Purkinje, it's not so much around, but even within the infarct, like some of the examples.
Thank you, Ajit. That was a very nice presentation. Yes?
Core isolation or homogenization or isolation all around the scar?
No.
No, you based only on what? Pace map? In substrate-based
in
mapping?
any patient where I can induce VT, I would love to induce
No,
VT.
induced VT will give you a localization that where from it is coming.
Yes.
And then, and it is unstable.
Okay, for the substrate modification,
hemodynamically unstable, then you have to go that area.
That's right.
And then either you do pace map.
Right. For substrate
at what rate you
modification,
will
I
do the
wouldn't
pace
go
map?
to
VT rate or?
core isolation or substrate homogenization. I would delay on I would do that only if I map the endocardium and the epicardium and I still don't get any late potentials, I would do that.
So in all cases, you say post-MI infarct patient having VT, you will do all epicardial and endocardial both?
No, I would do the post-MI, I would start with the endocardium. And if the endocardium doesn't make sense, I would go to the epicardium. It depends on the indication.
Means you are not able, because
I do not
hemodynamically
see
VT
the
is
late
not-
potentials that I expect.
Hemodynamically, VT is not stable. So you will deceive, and then you will map.
Yes.
Your mapping is only based on that initial VT will give you the localization that where from it is coming. And then your target or mapping will be on those areas where it can exit. And then you will ablate based on what? Pace map or by late potential, lava, whatever.
Decelerating late potentials. If I do not get sufficient decelerating late potentials in the
So deep
endocardium,
mapping
I
you
would
will
map the epicardium. If I get sufficient amount of decelerating late potentials in the endocardium and I ablate them and I induce and VT is not inducible, I wouldn't go to the epicardium.
I think in the interest of time, we'll have this discussion. Thank you very much, Ajit. That was a very nice talk. We have another very nice presentation, very relevant for us now. The emerging role of ablation in idiopathic VF. I can't think of a better person than Dr. Nogami to speak about this. Dr. Nogami is a senior electrophysiologist and professor of medicine and electrophysiology clinical EP at Tsukuba University in Tokyo.
Thank you for the kind introduction. I'm very honored to be invited to this meeting again. Now, I'm going to discuss about the idiopathic VF. Is ablation a palliative or definitive therapy? And first, I want to talk about the history of the idiopathic VF ablation. And Professor Joseph Kautzner is the first who presented the successful catheter ablation for the idiopathic VF, so-called shock-coupled variant of tosorb1. And he summarized that arrhythmia is targeted from the arrhythmogenic focus in calcium-dependent tissue of the posterior fascicle. And here you can see the spiky potential during the sinus rhythm and during the trigger BPC. And later, Michel Heisagel summarized the result of the mapping and ablation of idiopathic VF. In this paper, he reported the 4 patients with a trigger from the RV outflow tract and 23 patients with a trigger from the Purkinje system. And this slide shows the location of the PPC trigger site of VF, and the Purkinje is the most common site of the trigger of the VF in the idiopathic VF, and followed by the RV outflow tract trigger and the papillary muscle trigger. And this is the ablation of the idiopathic VF. The first one is a trigger elimination, and the second one is a substrate modification. I will talk the trigger elimination first, Purkinje trigger. Let me show an example. The patient was a 24-year-old lady with a multiple episode of syncope, and during her stay in the emergency room, there was a VF, and the trigger beats are always the same. And we did an emergency ablation, and we found the site of the trigger. That was the inferior right ventricle. And from this side, during the sinus rhythm, Purkinje potential was recorded. However, it was buried within the QRS. And during the trigger VPC, spiky potential preceded the onset of the QRS by the 133 milliseconds. And the ablation was successful, and after that, the VF storm subsided. Next trigger is the RV outflow tract. This is an example of the 50-year-old year-old lady with a multiple episode of syncope. And that this kind of polymorphic VT and VF were recorded. And the trigger VPC was this one, left bundle branch block pattern and inferior axis. And in this patient, we position the link catheter in the pulmonary artery. As shown in this view, the link catheter was in the pulmonary artery. The injection showed this is the site of the pulmonary valve. And during the sinus rhythm, we could record the late potentials like this. And at the initiation of the polymorph VT, this spike, this potential preceded the onset of the QRS. And we decided to eliminate, or we decided to make an isolation of the pulmonary artery. This is a recording during the ablation. This is before ablation during sinus rhythm. As I said before, there was a late potential in the pulmonary artery like this. And after the ablation to this side was delayed after the ablation, and this side became the earliest one. And after the ablation to this one, the sequence changed, and lastly, we did the RF energy application of this side, and after that, this potential disappeared. And this is the PA isolation. And after the ablation, we could record this kind of dissociated PA potential after PA isolation. It's almost like a PV potential, automatic PA potential after the PV isolation for the VF, with the AF. And lastly, I want to show you the other trigger site, papillary muscle. The patient was on the VF storm, and we could search the origin of this trigger that was right anterior papillary muscle here. And the intracardiac electrogram shows the modulator band and the anterior papillary muscle here. And this is the exit site, and we could successfully suppress the trigger BPC, and we have subsided after this. These methods are targeting the initiation phase of the VF. Another approach is targeting the maintenance phase of the VF that was called substrate modification. I will show you the good example of the substrate modification. This case is an idiopathic VF, short couple volume troponin. The trigger couple interval of the trigger BPC was 260, very short, and that induced the VF. And we positioned the multiple catheter on the left medial septum as viewed in slide, and we could record the many Purkinje potential at the initiation of the VF. And I want to say that in this case, burst atrial pacing repeatedly induced polymorph VT or VF. And at the initiation, as I said before, we could see the many Purkinje potential. However, it was little challenging to pinpoint the trigger origin of this Purkinje, and it seems to be more proximal site, and we saw there is a risk of the creation of the left bundle branch block. Therefore, we decided to do the substrate modification at the LV34 site. This slide shows the before and after the Purkinje network modification before ablation. During the atrial pacing, you can see the contiguous Purkinje potential like this. And at the initiation of the VF, you can see the many Purkinje potential here, and also this one. And after the QRS, this diastolic Purkinje, presystolic Purkinje. After the ablation, during the atrial pacing, Purkinje activation blocked here, and the distal site activated from the distal to the proximal. There was a significant change of the Purkinje activation. And we tried to induce the VF again. However, we could not induce any VF, and only this kind of single isolated VPC was inducible. And the QRS morphology of this one is different from the previous original trigger VPC. However, when we see the intracardiac electrogram, there was a Purkinje filing there, and there was a Purkinje conduction block here. Therefore, the suppression of the VF was achieved by not by the suppression of the Purkinje filing itself, but by the Purkinje network modification. Well, what is the mechanism of this suppression of the VF by the Purkinje network modification? Dr. Meyerberg proposed the gating mechanism like this, and the refractive period is the highest, little bit proximal from the Purkinje microjunction. And it is a higher site, and that prevents the reentry at the very distal site of the Purkinje muscle junction. If there is a collapse of this kind of mechanism, there is a risk of the occurrence of the Purkinje distal reentrant VT or reentrant VF. And they also did a Purkinje network ablation. This is before. This is the anterior fascicle, and this is the posterior fascicle, and the black number indicates the conduction of the Purkinje or vascular, and the white numbers indicates the conduction of the myocardium. Before ablation, it's like this, down and upward. And after the incision of the posterior fascicle, because of the lot of collateral conduction, the sequence did not change so much. And after the incision, after the linear incision like this between anterior and posterior, the conduction significantly changed like this. There was a conduction block here, and the distal part activated from the distal to the proximal. And this figure is quite similar to our case. In our case, after the ablation, distal side conducted from the distal to the proximal. It's quite similar to this one. So this kind of linear ablation can create the Purkinje network block. Recently, the German group reported the denetworking of the Purkinje system like this. They did 2 linear lesions between the very distal anterior fascicle and the posterior fascicle, and they also added the linear lesion like this between the anterior and posterior to prevent the creation of the hemiblock. And this line is quite similar to the Dr. Meyerberg's experimental linear lesion. Lastly, we have to discuss about whether the VEF ablation is palliative or definitive therapy. In the Michel Heisager's report, they reported the no VF, no syncope in 4 patients with RV outflow tract triggers, 0%. However, 3 ICD shock or non-sustained polemic VT was observed in patients with a Purkinje trigger. 30% of the patients with a Purkinje trigger had a recurrence. This is from the Japanese hospital. They reported 16 patients with a trigger from the RV outflow tract, and there was no recurrence of the syncope, VF, or other cardiac arrest. So the RV outflow tract ablation has a good outcome. However, the Purkinje ablation had several recurrence of the VF. How about the Purkinje modification? In this report, after the Purkinje modification, no VF recurrence was observed in the idiopathic VF. However, if the patient had a cardiomyopathy, there was a 29% recurrence of the VF. However, important thing is the diagnosis of the idiopathic. In this Dutch VF registry, during the 6-year follow-up period, 9 patients received the diagnosis other than idiopathic, and 25% received appropriate ICD therapy. In conclusion, ladies and gentlemen, the prognosis after ablation for the RV outflow tract trigger is extremely favorable, and ablation of the Purkinje trigger is also effective. However, similar to ischemic VF, there is an approximately 10% risk of VF recurrence. Additionally, modification of the Purkinje substrate may help suppress VF recurrence in idiopathic VF. However, another issue concerns the accuracy of the diagnosis of idiopathic VF. Thank you for your attention.
use any provocative testing after the baseline? You demonstrated a block. If you had used a pharmacological challenge or anything, can we reinduce this?
You mean to induce the VF?
Yes,
in the lab?
after the ablation, the endpoint is not baseline.
Yeah, I think the overdrive atrial pacing is the best way to induce the VF. And if the VF is not inducible, we sometimes use isopropanol or sodium channel blocker.
Intravenous sodium channel blocker.
To recreate the slower conduction in the Purkinje system.
Do we have patients with early repolarization idiopathic VF in this subgroup, or that has been excluded in this?
These idiopathic patients has no repolarization. If there is a repolarization J-wave, we have to think the another type of the VF.
Okay.
And the trigger is sometimes from the Purkinje and sometimes from the early myocardium in the repolarization syndrome.
Because there it's the slow rates which precipitate. During bradycardia, they have an excess tendency to develop this. And here during isopril and atrial pacing, and if it's not there, you are comfortable.
Yeah.
How frequent is the posterior papillary muscle or anterior papillary muscle BPCs leading to VF?
You mean the papillary muscle? There are two types. One is truly papillary muscle myocardium origin trigger, and the another one is Purkinje origin near the papillary muscle. These are different. The QRS only the differentiation is a QRS width. From the papillary muscle origin, QRS width is a little bit longer, and from the Purkinje origin near the papillary muscle is shorter. But however, there was a lot of overlap, so we cannot.
In moderator band VT also they develop VF.
Beg your pardon?
In moderator band VT also develop VF.
Yes, in some patients.
Is their trigger is what, Purkinje or BPCs?
Yeah, but I think in my feeling, in my experience, the trigger from the moderator band is usually BPC or non-sustained VT. The VF is originated from the anterior papillary muscle. It's a junction between the papillary muscle and the moderator band, more distally.
Thank you very much. That was a very nice talk. Thank you so much, Dr. Zudan.
Yeah, if there are no further questions, I'll invite Dr. Anis Tajuddin for his talk. Dr. Anis.
Good afternoon, Chairperson and colleagues. Thank you for the invitation. So my presentation is curiously titled Art of Outflow Activity, but I'll start by saying there is nothing more artful than entrainment in VT. But so some basic about RV and LV outflow activities. We'll stick with the basics of anatomy, ECG and EGM as the three important scenarios which we'll discuss here. As you know, anatomically, RV outflow tract is almost like a standalone structure beneath the pulmonary valve, centered around the aortic valve, which is the central structure, aortic valves and sinuses. Then the part of the RV outflow tract is in close proximity to the anterior aortic root and the continuation of the interventricular septum. And part of the RV outflow tract, especially the lateral part, is a little bit freestanding. But if you come behind, if you look at the aorta, it's on the right side, the right coronary artery comes a little behind the inferior and posterior aspect of the RV outflow tract, while the left main coronary arteries are actually posterior to the anterior cusp of the pulmonary artery, pulmonary valve, and are more posterior. And there is a freestanding RV infundibulum in close proximity to the proximal LAD. So these are important as we go along with ablation. So the usual RVOT fluoroscopy appearance is somewhat similar. So there is a danger area here where the RV outflow tract is thin and anterior and just below the subpulmonic valve area, the anterior cusp of the pulmonary valve, where it's free and also in relation to the left LAD and proximal left LAD and LMCA. While the posterior RVOT is a thick area separated from the LVOT by thick muscle, and sometimes in close proximity to the right coronary artery. And this area of the his bundle region is the rightward most end of the septum. Similarly, as I mentioned, the left LAD especially can come in close proximity to the free wall of the RV outflow tract, like 1 or 2 centimeters below the pulmonic valve, where it may be at risk for injury during ablation. So most of the perforations or injuries to the RV outflow tract during ablation happens because you are poking on the free wall, which is a thin area below the anterior pulmonic valve. And similarly, on the septum, the risk of perforation and all are low because of the thick area, but when you move the catheter towards the free wall, there is a risk of perforation and injury. So the movement of the catheters should be always along the septum when you are ascending, especially when you are ascending the RV outflow tract, and then you can map the different areas of the RV outflow tract. Just a fluoroscopic image of the RV outflow tract so this is the pulmonary valve level, and oftentimes when you are ablating in the septal RVOT, which is the most common site of RV outflow tract tachycardia, your catheter has to be so far bent backwards to attain good contact with the septum, and then that will give a better result for mapping and ablation and also prevent injury. One important thing to note is when you are entering the RV outflow tract, you will often require a clockwise torque to enter into the basal RV outflow tract, but once towards the valve, you will often require an anti-clockwise torque to keep the catheter approximated to the septal surface. So this is one way of avoiding injury, and I often look at RV outflow tract LAO and RO views in fluoroscopy while there is significant shift in the catheter. Now coming to the ECG, there are a lot of algorithms on ECG localization trying to identify the source of origin of the VT. I will not go into too much detail, but we look at mainly the V1 V1 complex, where it's a QS complex in V1, and the transition is much later in V4 or later. It's usually RVOT free wall, but between V1 and V3, it is usually between. If it's V3, it's usually RVOT septum, but anything more earlier transition means it is LV outflow tract. Lead 1 also you have to look at, because if it's a Q or an RS complex, which means the source of origin is more posterior or to the right side, and if it's a biphasic, it's maybe anywhere in the RVOT. If it's a Q or RS, it may be on the left anterior aspect of the RVOT or the LV outflow tract. Then you have to look at AVL-AVR ratio. Similarly, a deeper AVL than AVR may indicate a high origin, like in the pulmonary valve or sometimes in the LV summit. And also lead 3 by lead 1, lead 2 ratio is useful to look at from how leftward it is originating. But rather than understanding and memorizing all the algorithms, you could remember some of the patterns, like in LV, OTVT arising from the left cusp, you will get an M pattern or W pattern in V1. You will get an RS complex in the typical RVOT with the transition usually at V3. And an earlier transition may indicate a more posterior structure, like a posterior RVOT or a right coronary cusp. A left cusp or a LV summit VT usually produces a QS complex in lead 1, while a truly RVOT posterior focus will produce a positive complex in lead 1. So these are all things you look for, and this is the work from Dr. Sam showing the importance of looking at the R wave in V1. You will get a broader and taller R wave as you go posteriorly from the RV outflow tract towards the LV summit. And mitral annulus VT is usually typically RBBV. So there are numerous things which you can look at. There are various reviews on localizing, which is useful. That next important step is about the electrogram, the scene of the electrogram. And this is very important as a beginner to look at, to correctly find the spot from where this is coming. So your target is to identify a bipolar electrogram which is sharp at onset, much earlier than the bipolar electrogram recorded from the mapping catheter 3 and 4, and also to get a unipolar electrogram which is in timing with the sharp onset in the distal bipole and with a sharp descent in the QS as a QS complex. So on the left hand you have a typical example. On the right hand you have an example where the unipolar is delayed and there is an late far field signal before the QRS complex, before the EGM, so indicating you are not at the site. So this is a typical RVOT VPC located to the septal posterior wall or septal mid wall, the typical ECG transition. And this is our case, just to look at some adjacent structures. So this one has, we had a case where RS complex in lead 1, tall complexes in 2-3 AVF, and you can see that there is a transition much earlier in V2 with a broad R wave, indicating it may be coming from the LVOT. Actually, this patient had a previous ablation where the earliest ablation was in the pulmonary artery just above the valve in the low voltage area where you got early signals, but the patient came back with VPC. So this time, mapping in the left cusp, you should map with the coronaries injected, and then the catheter is kept at the coronary ostia to tag it, and then you can measure from how far away from the coronary ostia you get the earliest signal. And most importantly, at the earliest signal, you should have an early near field signal as well as a unipolar signal, which is a slur in the this unipolar slur in the unipolar signal indicates a prepotential. And here you can see it is much earlier than the catheter in the CS distal or great cardiac vein. So this is the typical unipolar signal and the bipolar signal matching, which should give you the classical point of ablation. This is another case where you get a R wave in V1, a negative complex in lead 1 and AVL, indicating probably from the LV outflow tract. In the lab, however, R wave is not that tall in V1, but still the QS complex and in lead 1 and AVL. And this was mapped very early in the CS distal catheter in the great cardiac vein, maybe into one of the perforators, and it was ablated from the left coronary cusp, showing how mapping and ablation can be obtained from adjacent structures. This is another clue of looking at the ECG. You have a reverse progression pattern, like the V2 showing a negative complex and V1 and V3 more positive with the Q wave in 1. So this was mapped to the great cardiac vein region, great cardiac GCV, AIV region, and ablation was successful there. So there are various methods which you can follow, but all in all, you have to target all the possible sites, RVOT, the GCV branches, and the LV endocardium and aortic valve cusp. So just a few one more. This is a mitral valve, mitral annular VT, clearly evident from the RBBB morphology, VPCs and inferior axis. Here you are targeting a larger area for mapping, so precision is very important. You get to the signal, and this EGM showing a very early signal with a good bipolar signal and a corresponding unipolar dip in the unipolar signal. And even this, maybe this is catheter induced, I don't know, with the same morphology. And this indicates the proper site for ablation, and we got rid of the VT. Putting it together, this is another case. As I mentioned, RV outflow tract posterior and rightward structures are below, and LV anterior structures are more superior. So this one is a positive complex in lead 1 and somewhat a positive negative complex in lead AVL, 2-3 AVF positive. You would assume that this is very near to the His bundle. But still you have to map the right coronary cusp, because right coronary cusp is close to the area of the RVOT just above the His bundle. But the earliest signal was obtained in the distal His right side, where you get a good unipolar signal which is suitable for ablation. Actually, during ablation, he developed right bundle branch block. Luckily, he had a pacemaker for another indication, and he had a recurrence after 25 minutes. So again, mapping was continued, and the successful ablation site was on the atrial side of the His. You can see here at the successful ablation site, A is much bigger than B. Unipolar signal is showing A and B, but during the VPC, there is a sharp descent in the unipolar signal. So you have to look at the anatomy, you have to look at the adjacent structures, and you have to look at unipolar electrograms in particular to get a good ablation. So just to some few tips and tricks, I do not usually start with femoral artery access in all cases, but when there is any suspicion of LVOT, like an RS complex in V1 with early transition, or an RS or QS complex in lead 1, or if it's a male patient with an RS complex in V1, because LVOT VTs are more common in them, we'll start with arterial access also. Use the coronary sinus decapolar catheter deep in the great cardiac vein in all cases. You look for the classical EGM pattern matching in both bipolar and unipolar. If you're not getting it, you switch to LVOT from RVOT or vice versa. And after ablation, you wait for like almost 30 minutes, not in all cases, but in most cases, so that you ensure that it doesn't come back. Thank you.
Thank you. Really nice talk, Anis. Do you mind pulling back your slide? on the V2 negative. And while we're getting that slide, I just want to make sure for fellows, junior EPs, septum, to view septum of outflow tract, your view you should use is RAO. RAO view because septum of outflow tract is posterior. So posterior RVOT is the septum. So in LAO, whether you go leftward or rightward, it's free walk. So only view you want to look to say, are you on the septum? Meaning opposite side is left side circulation, is the RAO view. This I want to just point out. So here, this is a type of ECG where you get two conflicting information. So one is you look at the R wave progression of the PVC from V1, V2, V3. So V1 positive, V2 negative, V3 positive. So pattern break, that means V2 where we keep the lead, left side of the chest, that's where you're going to find the breakout from the focus. On the other hand, look at AVR and AVL. AVR is deeper than AVL. Our usual teaching is AVR deeper than AVL, it's on the right side. So why is that? This is a very common dichotomy that you'll see and you should be prepared to interpret. The reason is AVR is looking straight down the barrel of the left ventricle, and left ventricular myocardium dominates ventricular myocardium. So even when we're on the left side, because you have much more myocardium to activate from a superior and superficial focus, AVR will still be negative, and you're better off looking at the pattern break across the chest leads.
Any questions? So anytime you use imaging in a RVOT PVC?
No, unless there is any evidence of structural heart disease otherwise, or like ARVD or NSVT or anything other than the typically benign presentation, I don't use imaging other than echo.
The only thing I would say is if you have access and you're not very experienced, very good idea to use intracardiac ultrasound. Is especially, for instance, Anis mentioned you can tag the left main. Just that act of tagging, patient cough, something, you can dissect. You know, every year I hear some case like this. So if you have the intracardiac echo, you visualize you're in the depth of the sinus of Valsalva. Not the cusp, but the depth of the sinus of Valsalva. That's not going to be engaging the main.
Yeah, ICE is quite useful, but we don't have it with us, that's why. Yeah.
Any ECG criteria that it is OT, VT is coming, or VPC is coming out from the pulmonary artery?
Usually
ECG criteria.
Pulmonary artery other than the RVOT.
Just see it, so OT, VPCs, and you map on the right side. If doesn't found, then go to the LVOT side, because
yeah, you have to map the pulmonary artery area also, and usually if it is coming from the PA, you will get a prepotential usually, not a very sharp signal from usually prepotential, which we have seen. But ECG wise, I think if you get a very sharp, very deep QS complex in AVL and AVR, and a tall R wave complexes in 2,3 AVF, and of course you have to map the LVOT also, but there is a chance that these are coming from the pulmonary artery. Then,
yeah, exactly. So remember, even though we say LV summit, actual summit of the heart is right ventricle. It's higher, much higher. So then if you have pulmonary artery, that's even higher. So very tall, 2,3 AVF. But another subtle clue is there for suprapulmonary. One, it can be polymorphic. You can change because it's just like exit changing. Another clue is you won't get fixed by Gemini. Usually outflow tract triggered PVCs, you will get fixed bigeminal pattern if you get by Gemini. But when it's supravalvar, you have one more area of decrement before you can affect, the sinus beat can affect the tissue to trigger the PVC. So because that changes, you will see variable coupling interval by Gemini. That's sometimes a clue that you're beyond the myocardium. You're in some area where it's difficult for the sinus beat to trigger the next PVC.
Two things. When you're taking children with RVOT, be very careful. The place where Anis pointed out, you can easily cause a collateral damage with irrigated tip or a 8 millimeter. Never ever crank up the wattage, never give lesions if it doesn't get suppressed in about 10 seconds or so in that area, which is high risk for collateral injury to LED. We have known patients where they have closed off the LED in children. The second thing is when you make a reverse loop and come down, you can sometimes directly sit on the left main. So it's always a good point to take a shoot, keep a 5 French, take a shoot. The third thing we use is use a radiographic marker like a V2 electrode, put one more extra electrode if it's in the RVOT, LVOT. So that serves as a marker where the left main is, because that will always remain there at the same point. You can go back and forth if you're not using a 3D, and you don't have to keep on engaging the left main to keep injections. Very nice talk. Thank you.
Thank you. I now invite Dr. John Roshan, Professor CMC Vellore, for his talk. Dr. John.
Thank you. So as we all know, this the structure of quinidine, and it's the drug that has just come in to being available. And I'm going to speak about quinidine and its role in ventricular arrhythmias. I'll briefly talk about the mechanism of action, the conditions where it can help, and a couple of case scenarios where we've used the drug. So quinidine, as we all know, is a dextroisomer of quinine and is got from the bark of the cinchona tree. This was actually described way back in 1848 by Van Heijmingen, and in fact Pasteur in 1853, which is even before our first war of independence, was the one who coined the term quinidine for this drug. So the mechanism of action, as we know, it's a class 1 drug, it's class 1A. So essentially it reduces the inflow of sodium, thereby effectively changing the slope of phase 0 of the action potential. And when the slope of phase 0 changes, it would effectively result in reducing your conduction velocity. Now, in addition to doing that, as we know, quinidine also, as you can see from here, increases the refractory period as well. So essentially, by reducing conduction velocity, it causes what we know as the use dependence, which we see with class 1 drugs, with the higher frequency of stimulation causing greater blockade, and that helps quinidine act when you have premature depolarizations. Like I said, it also prolongs the refractory period, and it does so by blocking the IKS, the IKR, and the ITO channels. This results in prolongation of the action potential. And in fact, in the past, when they spoke about quinidine syncope, which was related to a long QT due to overdosing patients with this drug, resulting in prolongation of QT and resulting in, obviously, syncope. So what are the conditions where quinidine can be used? Several conditions, one of which is Brugada. So in Brugada, as we know, you actually have in the outflow tract of the right ventricle, the epicardium and the endocardium, the action potentials are slightly different. And in patients who have Brugada, you have reduction in the inward flow of sodium and an increase in the transient outward currents of potassium, which happens in phase 1. So when these two things happen together, it results in you losing the dome of the action potential in phase 2. So that results in a great gradient, and this dispersion between the endocardium and epicardium results in currents flowing between them, which is what triggers arrhythmias in Brugada syndrome. So quinidine actually blocks the transient outward current of potassium, which happens in the phase 1 of the action potential, and by doing so, it reduces the transmural dispersion between the epicardium and the endocardium, helping in patients with Brugada. Short QT syndrome is another condition where quinidine has been given in as a class 1 recommendation, where it can be used to reduce the chance of arrhythmias. In short QT syndrome, you actually have IKR channels which are increasingly active, and here quinidine acts by blocking the IKR and the IKS channels, prolonging the action potential duration and normalizing the QT in these patients. Quinidine can also be used in the early repolarization syndrome, where you can have arrhythmias in the malignant version of it, involving the anterior and inferior walls of the right ventricle, and in this condition it can help in the secondary prevention of VF. Going on to idiopathic VF, which Dr. Nogami spoke about in great detail, it's believed that the arrhythmia is due to either a re-entry or a triggered mechanism, and Dr. Nogami also spoke about the Purkinje fibers, which could be injured in regions which are adjacent to diseased myocardium, which actually triggers this condition. So I'll briefly talk about two patients where we've used this drug and found it useful. Important thing is that quinidine has a lot of side effects, and so it's not a drug that you want to just throw in just like that. That's an important word of caution. Use it very carefully and very selectively. And I think it's good that only EPs should use the drug and not anybody and everybody. So this is a 51-year-old postmenopausal lady who is a diabetic and hypertensive. She presented with chest pain for 12 hours duration. She had no substance abuse and her blood pressure was elevated when she was admitted. Her cardiac enzymes were elevated with a drop of 6,118. So obviously this was an ECG at presentation, which you can see doesn't localize to any specific territory. There's ST elevations in AVR, V1 and depressions in the V4 to V6 and lead 2 and lead 3. So an angiogram was done which showed some disease of the lady. I wouldn't call it a very critical disease. There was no thrombus seen. However, since the angiogram was done, the operator went ahead and stented the lesion. And soon after that was done, the patient actually started to have polymorphic VT, which was initially occasional but kept progressively getting more and more frequent. Patient had to be started on noradrenaline, amiodarone bolus was given. And this is actually a picture of the polymorphic VT. You can see runs of polymorphic VT that kept happening. And there was that triggering beat, which is very short coupled, which is causing the polymorphic VT. And post PCI, the ECG remained unchanged for the patient. And she had a very stormy course. She kept having recurrent runs of polymorphic VT, not getting reversed. We tried lignocaine, it didn't help. Sedation was tried. The VT kept degenerating to VF. She had seizures. She required intubation. Propofol infusion was started. She needed higher levels of inotropic support with noradrenaline, dopamine, and tirofiban was also started just in case that there's something that could have happened to the stent. So this continued with frequent runs of polymorphic VT. And at this juncture, we realized that the polymorphic VT was being triggered by short-coupled PVCs, like I showed you on the ECG. And we stopped the amiodarone, stopped the lignocaine, and started on quinidine. After quinidine was started, progressively in the next 4 to 6 hours, the VT burden reduced, and she stabilized. So this was the ECG the following morning, and she underwent a repeat angiogram because we were concerned about the stent and found the stent remained patent. And on quinidine, in the next 48 hours, her ECG normalized. So on revisiting the history, this lady actually said that she had a low-grade fever 1 week earlier with body aches, and we sent off a viral screen. She didn't have any associated cardiac symptoms, and the fever had resolved prior to admission, just prior to admission. So our working differentials at this juncture were a possible acute myocarditis, and this was a sequelae of that. Could it be a Takatsubo cardiomyopathy, or could it be a part of an acute coronary syndrome? So as I showed you in the initial ECG that presented, she had that clear target trigger PVC that resulted in it, so which was possible Purkinje automaticity. And the VT settled with quinidine. She was shifted to the ward. Her viral serology workup came up showing Epstein-Barr virus serology was positive. She was started on steroids considering a possibility of myocarditis, but we discontinued it because we didn't feel that it really made any difference. So she actually had an echo done subsequently. The echo was done at admission, which showed regional wall motion abnormality. And subsequent echo 10 days later continued to show regional wall motion abnormality. As you can see over here, there was sparing of the GLS, or sparing of the apex on GLS. And she also underwent a cardiac MRI, which showed some amount of LGE, particularly in the basal anteroseptum and the infroseptum, suggesting possible myocarditis sequelae. She also had a PET scan which was negative for myocardial inflammation, but these were all done about 2-3 weeks after discharge. So we were doing this towards working up and trying to be clear as to what the real problem was for this patient, and we finally concluded that she most probably had a myocarditis with Purkinje fiber automaticity, and to support our diagnosis we had the fact that she had elevated cardiac enzymes, she had regional wall motion abnormalities which were not fixed, it kept changing over the course of her admission. Her ECG didn't show any localized coronary artery disease abnormality, and the myocardial involvement was patchy like I said on the echo, and there was no really tight lesion on the angiogram. And this was a condition where she had short coupled PVCs due to her myocarditis which responded well to quinidine. A second patient is a 23-year-old lady. She had again no comorbidities, no addictions, and she presented with recurrent syncopes, multiple syncopal episodes in a given day. In the ED, she was found to have polymorphic VT, which was cardioverted on 3 occasions, and her ECG then showed a QTC of around 490 to 500 milliseconds. She continued to have further episodes of polymorphic VT. So we have polymorphic VT here with a slightly prolonged QT. So we gave her magnesium, started on beta blockers, did temporary pacing to shorten the QT, and her VT storm settled. So sorry about the bad quality of the ECG. This was when she presented initially. And as you can see here again, we have polymorphic VT following a triggered PVC. She had a Holter again, which was done at that time, which showed multiple such episodes of polymorphic VT. And she was managed very well with the pacing that we had done. And over time, her QT appeared to become better. But as we came off the pacing, the QT continued to hover between 480 to 500 milliseconds in that range, the QTC. So in terms of workup, her history was negative of fever. She was not on any QT prolonging drugs, no toxin intake. Family history she gave was significant. Her father had died suddenly at 45 years of age during sleep. We assumed it was congenital long QT syndrome because of a prolonged QT, polymorphic VT, and the family history of sudden cardiac death. So single chamber ICD was implanted and she was discharged on propranolol. She also had genetic testing done, which didn't show anything significant except for a variant of uncertain significance involving the ankyrin 2 gene. She did well subsequently, but after about 2-3 years on her ICD, she came with multiple shocks, and interrogation showed short coupled PVC inducing a torsade-like picture. So here you can see these PVCs that are coming up, and they're short coupled, which is inducing this torsade. So essentially, this was an idiopathic VF. It is different from long QT. In long QT, you need a long QT, which is, when we say long QT, we are looking at more than 500 milliseconds. 550, 600 milliseconds is usually what the QT is when these people go into getting torsade. And it's a prerequisite for the QT to be long, because if you look at it physiologically, your membrane potential gradually rises up during the period of the long QT, the long repolarization, at which time the sodium channels get activated, causing the rapid uprise, and you having the early after depolarizations. Whereas here it is a short coupled PVC that's triggering off the VF. This patient was started on quinidine and again did very well on the drug. It's important for us to differentiate what we would call a classical torsade versus a pseudo torsade. This was a case of a pseudo torsade where you had what looked like a torsade arrhythmia, which was an idiopathic VF, which was triggered most importantly by a short coupled PVC and not by a long coupled PVC. So in a true torsade, which happens with long QT, you would not give quinidine because giving quinidine will be disastrous. Whereas in this kind of situation where you have a polymorphic VT triggered by a short coupled PVC, quinidine is very helpful. What about quinidine's role in monomorphic VT? Now, there really hasn't been much work on this front, and I would not encourage people to use it just like that. There are 1 or 2 papers, one by Will Stevenson's group, where they've used it for refractory ventricular arrhythmias in high-risk patients where they couldn't give amiodarone and they had limited other treatment options. Quinidine should not be given along with amiodarone because it prolongs the QT. They have found synergistic effect in clubbing quinidine along with mexiletine and with verapamil. And importantly, remember the GI side effects happens a lot with quinidine. It blocks the calcium-dependent potassium channels in the gut epithelium, which affects sodium chloride transport in the gut epithelium, which leads to a lot of GI symptoms. And these can get worse when they are clubbed with mexiletine. So as a take home, as of now, we know that quinidine is recommended for use in idiopathic VF, in Brugada syndrome, in short QT syndrome, in early repolarization syndrome, where you have the malignant version. It can also be used in acute myocarditis and acute and subacute ischemia, where you have short-coupled PVCs that are triggering of VTVF. As acknowledgement, I would like to thank my team, without whom this wouldn't have been possible, and the cases I presented were effectively managed by my team. Thank you very much.
So maybe, first of all, very nice talk. Just a few kind of practical points maybe about quinidine. In at least over the years, time to think of quinidine is that whenever you think Purkinje. So if you are in that same subset like you heard from Professor Nogami, those patient populations, an option is to think of quinidine. Its phase 0 effects are much more in Purkinje tissue than in myocardial tissue. It's actually the same thing that causes the schizonticidal effect for quinine and treating malaria, the same mechanism. Remember quinidine sulfate, which is what John mainly was talking. Bioavailability is iffy. It's very variable and depends on gastric transport time. So I have to instruct patients, don't take it along with heavy food. Don't take with grapefruit juice. The satkudi, this not very citrusy type fruits, you should not take 2 hours before or 2 hours after you're taking the dose. Then some side effects you have to also keep in mind. We know the GI effects, but although rare, there's 3 I've seen personally. One is ataxia. If you see new ataxia in someone you started quinidine, it will sound just like some inner ear problem. They'll get ringing, they'll get this thing, but it's probably the quinidine, and it can be even a year after you start. Another one, if you don't hear about, you won't think, is Sjogren syndrome. Quinidine can precipitate Sjogren syndrome, especially if there is some family history. So if you're starting to get that kind, then you have to think. Another is massive hemolysis. Little bit hemolysis is common with quinidine. You will get some reticulocytes, you will get some evidence, but some patients can get massive, almost like black water fever, and those you must discontinue the quinidine and then think about some alternate drugs.
John, you alluded the benefit in those PVCs to the rate-related better action of quinidine, which is known with class 1 drugs. But that I can understand in termination of AFib and atrial flutter when the tachycardia is going on, and that's why it's more effective than preventing a recurrence. But here with just a single PVC, how does the rate-related benefit come in force? I mean, when the tachycardia is on, it's understood, but with just a single PVC, how do the things work that rate-related effect is beneficial?
I'm not really sure whether that is the only reason why it is beneficial, but I think the other places where it has a role is blocking the sodium channels and blocking the transient outward current. So either ways, it essentially reduces the dispersion of refractoriness, which is how it helps. I believe so. I'm not sure if anybody else can add to my answer.
I think it's very informative what you spoke, because we haven't been using this drug widely. It's very informative talk. Daljit, I think we'll take one question and then stop there in interest of time.
Very nice cases. First case, so patient had a repolarization abnormality. We don't know why. It may be myocarditis or Takotsubo. We know poisoning causes this kind of repolarization abnormality or hyperkalemia, whatever it is. So do you feel giving a propofol in this patient when you knock down the patient, it's a good idea? It's just a query, because we say whenever there's a repolarization abnormality, specifically Brugada or channelopathies, you avoid propofol when you knock down the patient. Your take on this?
Yeah, I agree fully with you. That's a very relevant point that you raised. So actually at that point of time, it was like a sort of emergency, and we had the anesthetist over there, and he sort of gave in propofol, and only later we realized that we probably shouldn't have given that. But yes, that's a point very well taken, and I think it's a very appropriate comment from your end. And the other thing I forgot to add was the ankyrin 2 gene that we found positive in the second patient. That has got a relationship with repolarization, and probably that is the reason why that patient's QT has always been between 440 and 500. which is actually not a long QT per se as long QTs would be. It was sort of like a pseudo long QT in that case.
But if we do parent screening, it will help us to come out of the VUS, no? If you do family screening.
Yeah, exactly. So we've actually called, but unfortunately they haven't come back.
In your second case, why not you use mexiletine instead of quinidine? Because quinidine you use because of short coupled PVC induced.
Yes, exactly.
polymorphism.
Yeah, that's why we
That
use.
was your criteria.
Yeah.
But that can also occur in long QT as well. So why not mexiletine rather than quinidine?
No, so this patient had idiopathic VF that was being triggered by short coupled PVCs.
But
And
QT was long. So
yeah, so
polymorphism.
initially we thought it was long QT, which is why we initially just did temporary pacing, and then we, after pacing the patient at a higher rate, we gave beta blockers and magnesium, and we managed it like a long QT. That was our initial impression. But when the patient came back with multiple shocks, and we looked at every single episode that had a shock, she had at least 8-9 episodes, which I displayed 2 of them. Every one of them was a short coupled PVC inducing the tachycardia. So it was clearly short coupled PVC triggered tachycardia and not long QT.
Any role of quinidine in primary VF? Primary VF means those ST elevation MI came in the.
Yeah, no, the literature doesn't give any role of quinidine in primary VF. No, there's no role in literature on that. And the other thing is the QT that triggers that is usually a very long QT. If you're talking about torsade, the QT that precedes the torsade, the classic torsade, is a very long QT. It's not, though we say long QT and we say anything more than 500 is 480 is long QT, it's usually in the ranges of 550 to 600 that they develop the torsade.
Thank you very much. It's a very, very educative talk. Thank you very much, John. We'll close this session and I'll hand over the mic to the organizer. Thank you.
Thank you so much, Honorable Chairpersons, and also to our speakers. Big round of applause. We will be starting with the inauguration ceremony right after this. So requesting all of you to please stay back. Just in 5 minutes, we'll be starting the inauguration. We'll be just taking a few minutes to arrange the stage, and everybody please stay back for the inauguration.
Primary VF जिसमें होता है ST elevation MI, हम बीटा ब्लॉकर देते हैं because quinidine was not available. IV quinidine is the drug, so that you can bring the patient in the cath lab and do it. And studied by Hassan. Primary VF in ST elevation MI, quinidine is not available.
Requesting all of you to please take down your seats. We'll be starting with the inaugural ceremony right now. Also, right after this, there will be the quiz happening in the other hall. So anybody who is still left to register your name, please do it immediately. I request our honorable doctors to please come on the dais for the inaugural ceremony. I request Dr. K.K. Sethi to please join us on the dais. Dr. Akiho Nogami sir to please come and join in the dais. Dr. Samuel Asirwathan sir, please come and join in the dais for the inaugural ceremony. Dr. T.S. Clave sir, please come and join in the dais. Dr. C. Narasimhan sir, please come and join in the dais. Dr. Yash Lokhanwala sir, kindly come and join in the dais. Dr. Jong Il Choi sir, please come and join in the dais. Dr. Ajay Naik, kindly come and join us in the dais. Dr. Rakesh Yadav, sir, please come and join us in the dais. Dr. Amit Bhora, sir, kindly join us in the dais. And Dr. Anup Gupta, sir. Can we have a louder applause for all our honorable doctors who will be joining us and join us for the inaugural session. Dr. Amit Bhora, sir, request you to please come on the dais. We will be starting the beautiful moment of inauguration with the Saraswati Vandana, also requesting all of you to please join, and Dr. Shuchit Mojumdar and Dr. Devabrata Vera, sir, please join for the inauguration and the lighting of the lamp.
पद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने
I now request Professor Nogami sir to please share some valuable words with all of us.
Thank you very much. I'm very honored to be a part of this meeting, and I'm very glad to visit this beautiful country again. And actually, this is my first time to visit Kolkata. So I used to visit many cities in India, and every place is different. I feel that. So thank you very much. We have to keep in the touch with especially the young EP physicians. I believe that education is the most important thing. So in this field, we have to keep in touch. Thank you very much.
Thank you so much, sir, for your wonderful and enriching words. I now request Dr. T.S. Lev, sir, to please share some valuable words with us. Big round of applause, please.
Well, first of all, thanks Devabrata and Suchit. They have done a wonderful job. Nice arrangements, nice scientific sessions, and it's very nice to see IHRS growing. You know, Sam, I was the first president of IHR many years back. So it's good to see the younger people taking on to electrophysiology, and I've seen the presentations and the case discussions are excellent, and they are really of good standard. I think what we need to do next in our country, as far as electrophysiology is concerned, some original research, better data collection. We do good job, but many times we don't publish. So that change is needed in the country. And I also thank people like Sam, and many others, Indian colleagues who are in rest of the world, United States or Europe. They have been of great help, like Jasveer Sara, also my friend, who have helped the Indian electrophysiology to grow. And I'm sure they will continue this noble job to assist us to develop more better electrophysiology services in the country. And again, thank you, Suchit and Dr. Vera, for doing a wonderful job. Thank you very much.
Thank you so much. I now request Dr. Ajay Naik, sir, to please share a few words with us. Big round of applause, please.
Great applaud to Suchit and Deba. They've done a great job. They've worked very hard, and it's been an excellent meeting. We've had some great presentations, very intricate work done from different parts of the country. I think we need to work more cohesively. Our EP work from our country has been great, but we have to work together and publish more. And like Dr. Claire has said, we need to make our presence felt all over APHRS, HRS, and all over the world. We have illustrious predecessors to show us the path and guide us. Thanks to all the international faculty for being here personally and online. And it's been a great meeting. More kudos to Suchit and Deba once again.
Thank you so much, sir, for your kind words. I now request Dr. Samuel Ashirwathan, sir, to please share some words with us. Applause, please.
Thank you. It's actually really nice to take a moment and think over the years where electrophysiology is in India right now. I still remember with Ajay walking in San Francisco with some ECG meeting, Professor Clare, and when Yash and Narasimhan came and visited in Oklahoma when I was doing my fellowship. First time I came to India, did some cases, did a presentation, was 1999, and when you think of the evolution, it's really incredible. It was a field where interventional cardiologists, little bit of EP, there was no much depth, and now we have not only great presentations, but the curiosity in the questions. Daljit gets up and says, don't use propofol, and did you do the family history when you were discussing in this case? You will rarely see anywhere in the world that level of understanding or that curiosity. I think, yes, research is next, engineering is next, but also there's a critical stage that comes in an electrophysiology society that you get the feeling of mastery, you get the feeling we've learned that you have already come pretty close to being very good at what you do. It's an illusion. The field of electrophysiology is primitive. It is in its early stages. And then on top of it, we just feel that we are good at what we are doing. Anywhere in the world, you have to be particularly careful where you have to have so much growth, like in a place like India. So just to keep that same humility and curiosity that got our country's electrophysiology from 99 to now has to be there for the next 25 to 30 years. Thank you.
Thank you so much, sir. Now I request Dr. Rakesh Yadav, sir, to please share a few words with us. Big round of applause.
Respected dignitaries sitting on the dais, speakers, delegates, ladies and gentlemen. On behalf of Indian Heart Rhythm Society, I am a secretary of the society And I must congratulate both the organizing secretary, organizing chairman, and all the organizing team for conducting this wonderful meeting this year. The IHRS now is gaining their access in each and every part of this country. Believe me, we have members from Kanyakumari to Kerala, from Gujarat to remote part of Northeast. We are trying to collaborate more with SAARC countries. Our association with Korea is now a regular phenomena. With Bangladesh is a regular phenomena. Now we are trying to engulf more from Nepal, even from Pakistan, Afghanistan, and Sri Lanka. We are trying to, I think this should be disclosed here, we are trying to make a SAARC IHRS, because now what you see, in the number of procedures, the number of devices are increasing in a very rapid way in all these SAARC countries. Second important thing, when we are seeing that young budding electrophysiologists who are only dedicated to electrophysiologists, this phenomena was not in the last 10 years, it's only last 10 years. People are dedicating to electrophysiology only. There's a lot of debate and discussions, lot of suggestion from senior people, WhatsApp group, and Dr. T.S. Clare is very, very categorically says that these electrophysiologists should be trained electrophysiologists. Now what is happening, anybody who has done a DM cardiology or DNB cardiology can perform electrophysiology. I think this debate will continue, and IHRS is absolutely ready to pave the path, not among the cardiologists, but they are ready to give the advice to Government of India that somewhere there should be some strict guideline for advanced electrophysiology procedure. And I think with the help of all the seniors, all of us, we are able to make certain guidelines. Now we are in the process of making guidelines for India. That is also very, very important. And our new president, Dr. Ajay Naik, I think under his able guidance, we are able to propose our new guidelines which are more important for Indian, not for a Western country. Thank you very much for this.
Thank you so much, sir. I now request Dr. C. Narasimhan, sir, to please share your valuable words with us. Big round of applause.
Respected President Dr. Ajay Naik, Secretary Dr. Yadav, distinguished members on the dais, dear friends, ladies and gentlemen. It's indeed a great pleasure to see several of the people whom we started training with have taken mentorship roles. We used to, like Dr. Samuel Asirvadam was saying, meet in a small room with Yash and few of us, used to discuss tracings. Bard used to run a training program once a year. From there we started. We've come a long way. I would like to echo the same sentiment. Some problems are different in different geographies. The patient's capacity to pay. So you need to have your own guidelines, or you need to have your own pathway to evaluate a patient. Certain disease prevalence also dictates how we practice medicine. So it's very, very important to have data that is generated from within the country or in and around these geographies to find out what is different, what works best with the available constraints. So for this, I think IHRS initiative of starting multi-center registries would be an excellent initiative to take this forward. And IHRS, the journal, has done extremely well. Thanks to Raja and Nambudri and several of the assistant editors who have helped, and several of our international faculty who have helped running the journal. And it's very well referenced upon, and a lot of good review articles. I would suggest some of you start sending articles to Indian Heart Rhythm Society, pacing journal of our own society. And I would like to congratulate most of all. Running a meeting of this size is not easy. I would like to congratulate Dr. Devabrata Bera, Suchit, and Dr. Rakesh Sarkar for, because there is a lot of constraints now in running a meeting, and they were able to do an excellent job. Congratulate them, and congratulate the new office bearers for the coming meeting.
Thank you so much, sir. I now request Dr. Amit Bohra to please share your kind words with us. Big round of applause.
I'm reminded of Kal, Aaj or Kal. The yesterday and today of IHRS was good, but it's very heartening to know that the future, which is now of IHRS, is great. Seeing young investigators, the in-depth knowledge and commitment in electrophysiology in the country, a young dynamic committee, I'm sure that IHRS will reach great heights, and once again, congratulations to the organizing and the scientific committee of IHRS 2024. A great job done, and future is bright. Thank you very much.
Thank you so much, sir. Now I request Dr. Anup Gupta to please share your words with us. Applause.
Well, 20 years down the line, 2003, when we started IHRS, I remember there were hardly 20 electrophysiologists. And now we have got more than 400 electrophysiologists. So when I came back, so physicians, they were not aware what electrophysiology, they used to think like, probably they are going to do some experiment on human beings and all this thing. The biggest achievement in 2 decades in India. Now the patient, even in a remote village, they know what exactly electrophysiology, if they have got any problem with the rhythm, they know whom to contact and whom to go. So, the credit all goes to all the teachers like Yash, Narsimhan, Amit Vora, who started. And amazing meeting again, Suchit and Deba has worked very hard. And again, thanks to all the foreign faculties, and they're helping us for last 20, 25 years with all respect. And again, what Dr. Claire said, I second that same thing, probably we are lacking in publication because volume is tremendous. And now when I see the young electrophysiologists are doing amazing cases and presenting is phenomenal. Again, thank you very much, and congratulations to Suchit and Debabrita Bera.
Thank you so much. We end the inauguration ceremony over here. Thank you so much, doctors. Big round of applause, please, for a beautiful moment and a wonderful inauguration. We'll continue with the next session. And as chairperson, I would like to invite on the dais Dr. Yash Lokhanwala and Dr. Aftab Khan.
Good afternoon, everyone. Till the time the slides are up, I just must mention that we have the maximum hard work was done by Dr. Rakesh Sarkar, who had to kind of find out and fix the scientific agenda, along with special thanks to Deepak Padmanabhan and Sanjeev Mukherjee, without whose help, means me and Suchit has been doing the groundwork. But setting up the scientific agenda and working on it, who is coming, who is not coming, dropping, fixing on another, this is the maximum and tremendous hard work done by Rakesh Sarkar. I would like to congratulate him as my friend and brother, and we'll continue the next scientific session. Thank you so much.
Starting the next session, requesting Dr. Yash Lokhanwala and Dr. Aftab Khan to please come on the I request Dr. Ashish Nagar to please come on the dais to grace the chair as a chairperson, and Dr. Bhim Shakar to please come in the dais and do the honor. Can we have a loud round of applause for our honorable chairpersons?
More than gracing the chair, I think it is this impromptu opportunity is good to sit like a student very close to the masters and hear some of the nice
things that they're going to say. Again, we are always grateful to Dr. Sam and Dr. Nogami for undertaking this long journey and going to educate us on different aspects of EP. We have had something from both of them in the last session, and I think some nice things are still going to continue. So I think Dr. Nogami is going to make the first presentation. Dr. Sam, can you also please join us on the dais so that we can have your comments?
Thank you very much for the kind introduction. I'm going to present the null-QRS tachycardia with a VA block. The case was a 39-year-old female with a tachycardia. The left panel showed the ECG during sinus rhythm, quite normal, I think. And the right panel shows the tachycardia. Tachycardia cycle length is 500 milliseconds, and the QRS morphology was almost equal to those during sinus rhythm. And when you see carefully, you can recognize the dissociated P waves. And the lower panel shows the magnification of the lead 2, and here you can clearly see the P waves here. And this seems to be sinus rhythm, and the sinus cycle length is 840 milliseconds. There was a AV dissociation during tachycardia. And we gave the ATP, adenosine triphosphate, 10 milligram, and that terminated tachycardia. Here, tachycardia terminated at this site. And after the termination of the tachycardia, you can see the sinus P waves, and there was a significant long PR interval at the very first time, and after the few seconds, PR interval became normal. So the question, what is the diagnosis of this null-QRS tachycardia with VA block? There are several possibilities. Number one, AV nullity with upper common pathway. Number two, junctional tachycardia. Number three, concealed nodoventricular or nodovascular pathway mediated ORT. Number four, vascular VT, especially the special type of the vascular VT named upper septal type vascular VT. In this upper septal type vascular VT, QRS morphology is almost the same as during the sinus rhythm. So let me check at the time of the initiation of this tachycardia by program ventricular stimulation. The base drive, S1, is simultaneous pacing with A and V. And the S2 induced the tachycardia, and you can see the retrograde conduction here. And after the initiation of tachycardia, there was a 1-to-1 VA conduction at this time. And the important thing is the HV interval. HV interval during tachycardia was 42 milliseconds, and during the sinus rhythm, HV interval was also 42 milliseconds. That was equal. And if the tachycardia is upper septal vascular VT, HV interval should be shorter. This is an example of the upper septal vascular VT. There was a VA block, and QRS morphology was not equal, but similar to those during sinus rhythm. And this is his potential. HV interval during tachycardia is 25 milliseconds in this case. And during the sinus rhythm, HV interval was normal 55 milliseconds. So if the HV interval was shorter than that during sinus rhythm, that must be the VT. But in this case, HV interval was equal between during sinus and during tachy. Therefore, this tachycardia must not be the VT. And also, his potential, it's a quite little, but morphology of the his is similar, identical during tachycardia and during the sinus rhythm. So maybe that can be method to differentiate the junction of tachycardia. And there is two possibilities. One is AVNRT with upper common pathway, and the concealed notoventricular, notovascular pathway mediated ORT. How can we distinguish them? This is at the time of the Wenckebach wave block during tachycardia. Even at the time of the block, tachycardia cycle lengths remain the same. And we did ventricular stimulation on the refractory His period here, and we measure the AA interval. AA interval after the stimulation is the same. And also we check the HH interval. HH interval after the ventricular ectopy was also the same. But the important thing is the next HH. Next HH, that was shortened. Here, you can see his potential here, and the HH interval shortened after this stimulus. Therefore, that is the advancement of the next His with ventricular ectopy on the refractory His. This here, you can see the HH interval was shortened after the ventricular stimulation on the refractory His. Therefore, this tachycardia is a notoventricular, concealed notoventricular or notovascular mediated ORT. If this tachycardia is a AVNRT, usually refractory His stimulation could not capture the A, or if this tachycardia captured the A with a very short coupling interval, that must be the antidromic capture of the His. That must be not the next His. To confirm before that, I will show you actually the conduction from the ventricle is directly this one, this ventricle conducted to the next His, and also this blocked here. Actually, the stimulation blocked the conduction to the next A, not this A. To confirm the diagnosis of notoventricular, notovascular tachycardia, we did an entrainment during tachycardia. This is an entrainment from the right ventricular apex. And again, this stimulus captures the next His, and this stimulus captures the next His, and the last stimulus captures this His, not this His. And when you see the morphology of the His bundle, the morphology of the His is the same. There is the orthodromic capture of the His potential. If this tachycardia is AVNRT, and entrainment, if the entrainment capture the circuit, the His bundle must be the antidromic capture. This tachycardia is a notoventricular pathway, therefore the entrainment pacing capture the His with the orthodromic fashion. Also, the retrograde atrial potential, the stimulus capture the next atrial potential like this. And also, please, this is a His orthodromic His capture and the VHVA response, VHA response. And there is the notoventricular, notovascular pathway. And please remember, PPI was 645 milliseconds. It was very long. This is a diagram of this tachycardia. This side, star side, is the upper turnaround side. And this is this side. And there was a block beyond this turnaround point. And the circuit itself is ventricle to the AV node, and then down to the His bundle, and that activates the ventricle again So this is a circuit, and this block side is the out of the circuit. And to differentiate notoventricular pathway and notovascular pathway, this entrainment is important. And we did an entrainment with a different cycle lengths. This is a 440 milliseconds, this is a 480 longer cycle lengths, and this is a ventricular pacing during sinus rhythm. And the QRS morphology were always the same. There is no constant, there is no progressive fusion. QRS morphology always the same. And also, please remember, PPI was very long. That means no fusion, long PPI. That means this tachycardia is a nodovascular pathway. If this tachycardia is a nodoventricular pathway, ventricle is a part of the circuit. So there must be the progressive fusion and the constant fusion. And also PPI should be close to the VT cycle length. So in this case is a nodovascular pathway mediated ORT. So this is a summary of the comparison of the AVNRT, nodoventricular, nodovascular ORT. HB interval, sinus rhythm, tachycardia are equal. And the complete VA block is possible in nodoventricular, nodovascular pathways. And during the RV overdrive pacing during tachycardia, his capture is antegrade in nodoventricular, nodovascular, but retrograde in the AVNRT. And also to distinguish nodoventricular, nodovascular ORT, PPI and the QRS fusion during RV overdrive pacing is useful. These kind of things were based on the recent paper by Dr. Nagashima and Dr. Higuchi. Thank you for your attention.
What does the termination with adenosine indicate? Does it help in the differential diagnosis?
Differential diagnosis, what?
Yeah. Does it tell us, give us any information, termination with adenosine?
Yeah. What is your question?
You terminated the tachycardia with adenosine. Did that help us to differentiate between the different diagnoses?
Termination of tachycardia by the...
I think he's mentioning that you said ATP terminated the tachycardia. So maybe that makes junctional less likely,
yes,
and just fascicular re-entry less likely.
Yes.
Keeping AVNRT, nodovascular still in the diagnosis.
Yes, I think so. Thank you very much.
Sam, your comments?
It's really very interesting case. So this, I think the differential diagnosis like this is perfect. The tricky one, because AVNRT is so common, is it AVNRT and you have a bystander nodovascular tract?
Yes.
So because it's the bystander tract is there, your PVC will change the direction of the His, but it's still AVNRT.
Yes.
But it's just you won't see the VA dissociation. If you're seeing VA dissociation and evidence of a nodovascular tract, is probably nodovascular.
Yeah.
The other thing is, keeping a multi-electrode catheter on the His. You used a single His recording to see the change in the polarity. But if we keep a multi-electrode on the His and we see fusion, then there is two ways to get to the His, retrograde and antigrade. And if that's resetting the His, no other diagnosis. Yeah. But I'm curious what you did with the case. Where did you ablate this tachycardia?
Thank you very much. We ablated this tachycardia at the site of the slow pathway potential.
So, sometimes for people, they say your differential diagnosis is AVNRT, nodovascular, and junctional tachycardia. All of them were ablating the slow pathway.
Yeah, yes.
So maybe we should just ablate the slow pathway and see, does it go away?
I think there is a case report of the ventricular side ablation in a case of the concealed notoventricular fiber from the UCSF. But that can be done if the tachycardia is notoventricular. This case, notovascular, so therefore there is some risk of the creation of the right bundle block.
And is it fair also to say for the entrainment, in nodovascular, your post-pacing interval is shorter when we pace at the base compared to apex, but nodovascular, it's shorter at the apex compared to the base.
Yeah, that's true. Thank you.
HS interval. So why not nodoventricular? Number one, why not it's a bystander?
Oh yeah.
Because post-pacing interval minus TCL is more than 145. So AV-RT is the circuit and your nodoventricular or nodovascular bypass tract is attaching with the your slow pathway region, and the next beat is orthodromic, his bundle which is coming, orthodromic, his bundle is activated before because of the pathway, and your antidromic is extinguishing and orthodromic is continuing.
Yeah, that's
so
true.
how will you prove that a nodovascular is the part of the circuit?
Bystander, yeah, yes.
So you have done some like atrial pacing at the rate of tachycardia, or then you could have done that it's really AV nodal DNT tachycardia or nodoventricular nodovascular.
Yeah, that kind of thing can be proved by some EP method during the tachycardia. But unfortunately, in this case, we could not do that kind of precise EP method. And 10 years ago, we experienced many patients with SVT with a VA block. At that time, we thought all of them are AV-RT with a VA block. And after that, we checked some of them using the extra stimulation or entrainment from the right ventricle. And there were 3 types. One is true reader AV-RT with a VA block, and the another one is this kind of nodovascular, nodoventricular ORT. And some of them are AV-RT with a bystander of the Mohan nodoventricular fiber. So you are true. And to differentiate them, it is a little bit difficult. So Thank you for your comment.
Do you have one more case, or Dr. Nogami?
Yeah, just one.
This one.
This is-
Last,
Sure,
one small question, if I can have. So, fortunately for us, most of these concealed pathways attach in the slow pathway of the AV node, and so we are successful in ablating at the same region. But some of them can be in the fast, can attach to the fast pathways. So, how do we differentiate and how do we ablate those?
I don't think there is any evidence that this you can go from ventricle directly to the fast pathway. If you look closely, there are 2 case reports. If you look closely, what they are calling fast pathway was just earliest day during V-pacing. And the reason is tendon of Todaro is separating fast pathway from the annular myocardium. So if you are going to have a bypass tract on the septum that connects to just across the annulus, you can connect to the slow pathway, you can connect to atrial myocardium, you can connect to AV node. But to connect to fast pathway, you have to somehow cross over tendon of Todaro without connecting to anything in front of tendon of Todaro. So it's basically not possible.
No, there is a case report.
Yes, there is the case.
Published where it was attached to the nodoventricular, nodovascular pathway was attached to the fast pathway.
That's the one I'm saying. It is an inaccurate report because what they are calling as fast pathway is different from the anatomic fast pathway. They're just saying this was the earliest stage during ventricular pacing, therefore this is the fast pathway region. That's an inaccuracy.
And in this case, we could map the earliest atrial activation site. And that site is close to the coronary sinus ostium. And there was a slow potential site during the sinus rhythm.
Did you ablate it during sinus rhythm or you ablated during tachycardia?
During sinus.
Yeah, because we ablate during tachycardia, if have like this, that
Yeah,
we will.
there is a dialect, but I don't know if there is a VNLT that can be terminated.
Sure. Thanks, Dr. Nogami.
Thank you very much.
Sam?
You said the ATP has terminated, that at least indicates it's AV node dependent and not the septal VT. That's the first.
So very nice to tell a little bit similar story, but a different mechanism. So it's a lady, actually radiologist, palpitations many years, sudden onset, sudden offset. Sometimes she used to say she will do some maneuver and stop, no pre-excitation, and fairly narrow QRS tachycardia. So kind of setting up for SVT type ablation. Also had single beats, narrow, very narrow, and similar to the tachycardia. So put in catheters, coronary sinus numbering 1, 2 is distal. His recording, multiple electrodes you're seeing on the distal, and about 30, 35 tracing. This is actually the critical point that Dr. Nogami pointed out, very useful for trainees to remember. You look during sinus or atrial pacing, what is your HV interval? And then look during your beats or your tachycardia, what is the HV interval? Very important concept. If the HV shortens even a little bit during the ectopic or during the tachycardia, you have to think below the His. It's below the His. Why? Because if it's below the His, by the time you reach the His, you have already started going towards the V, so your HV will be a pseudo interval and shorter than a conduction reaching the His and then the V. So very useful differentiating point. If HV is exactly the same, that's the spot, so like His bundle tachycardia, or something above, or something retrograde connecting to the AV node and conducting antigrade in the His, like Professor Nogami's case. But if it shortens even a little bit, think below. But you can extend that thinking. This patient, we also did parahesian, there was no accessory pathway. We did a map for earliest ventricular breakthrough, just to get an idea where is it discrete in the ventricle or multiple sites. Now you can take that same concept further. Instead of keeping the catheter on the His, if you keep the catheter on the left bundle, and the left bundle you see, conducted beat is longer left bundle to V compared to the ectopic beat or tachycardia, same idea. That means you have to go below. And then if you keep going lower, 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 somewhere you get a point where your conduction to V matches conducted beat and ectopic beat. What that point is telling you is it's not lower. It's there, or it is possibly in a different location at that level. So very useful comparative map. But this one is a little different. We actually were hunting to find that level. Idea is HV during sinus is longer than HV during tachycardia, go lower. Left bundle, Same thing, go lower. If you go to distal left fascicle, now you're matching, then somewhere in between. But somewhere along the way, we get this. Kind of even in sinus rhythm, you see these intervals. But key is whenever you got an ectopic beat, this signal to the V time was the same. So not something mechanical, not something that you're seeing there. What could this signal be kind of in the middle of nowhere? So we decided instead of doing ventricular map, let's just do the fascicular map and see if we can find this area of activation. And indeed, you find some sites where you can get like the end of this mid-diastolic signal matching ectopic beats and the sinus beats. But what could cause something to be like in the middle of nowhere? And if you see the fluoroscopic view, LAO projection, you're not on the wall, you're not anterior, you're not posterior. RAO projection, you're not in the anterosuperior surface, you're not in the posterior inferior surface. You're kind of dangling in the middle and you're getting this type of signal. So with intracardiac ultrasound, you see that there is a papillary muscle, there is this little protrusion on the free wall and the faint band-like structure going across that site. And if you catch that site, which fluoroscopically looks like you're floating, you can reproduce the morphology of these ectopic beats, narrow complex ectopic beats. And this was an example of automaticity on a false tendon. False tendon, most of the time Purkinje tissue, and because it's not immediately connecting to ventricular myocardium, you have a period of activation of the conduction system without exit to the ventricular myocardium. That's not going to happen on the surface of the heart itself. And this, during ablation, you get sustained tachycardia, similar type morphology before termination. So just a word about these false tendons. It's really a nomenclature. Fellows should be aware the Purkinje network is what kind of raises these little trabeculations. And then you see these bridging segments in everybody's hearts. Sometimes these bridging segments are in the cavity. They are very short. They can be branching. These are the places that Professor Nogami has explained. If you get a catheter, you will simultaneously record two different parts of a circuit involving the conduction system. On the other hand, if they are all superficial, the chance of that happening is less likely. Sometimes though, these are not just short bridges or bypasses, but they go all the way from the septum to something, either septum to papillary muscle, septum to papillary muscle and free wall, very similar to the moderator band, except they tend to be more angled, and unlike the moderator band, the insertion point is usually much more apical than your origin point on the septum. Now these can be the source of VTs. They can also be part of the circuit in structurally abnormal heart VT, just to finish the circuit even though the slow zone may be in part of the diseased tissue. When people have resected the tendons and kind of looked under the microscope, you do see combination of fibrous tissue, myocardial tissue, and Purkinje tissue. And these Purkinje tissues in mammalian hearts are common. In human hearts, they appear to be there in about half to 2/3 of all small bridging fibers, and universally in large bridging fibers like these false tendons. Also interesting is usually we think of sympathetic innervation is an epicardial innervation of the heart. This is true. It is mostly stopped by the visceral pericardium, but there are fewer examples of sympathetic innervation within the heart. Occasionally in the papillary muscle, but very commonly in mammalian hearts, especially large mammalian hearts, cow hearts, lamb hearts, porcine hearts, in the false tendons as well. So just to summarize, very important, we didn't actually plan on doing these two cases, but same concept, comparative mapping of HV sinus versus the ectopy, dead the same, think that spot or higher. Even little bit narrower during the ectopic or the tachycardia, start thinking lower. And carry the same concept to see how much lower until you get a time when the true interval and pseudo interval are matched. That's the level that you're going to find this ectopic beat. Don't forget, not all conduction signals have to immediately exit to the V. You can have insulation in the proximal part. You can also have these bridging structures like the fascicular, like the false tendons in the ventricular cavity. Thank you very much for your attention.
So I have a question. You showed that the false tendon inserts into the free wall myocardium with multiple things. So can one expect any discernible difference in the ECG morphology on a bit-to-bit basis?
Yes, definitely. And it's very interesting to hear Professor Nagami make that comment about moderator band and papillary muscle junction. It's exactly the same observation over the years. It's different arrhythmia. If it's on the false tendon or on the moderator band, you'll either get like a monomorphic type tachycardia with slight variation, or you'll get non-sustained changing morphology VT. Generally, and I don't know the exact reason for this, it must be some source sink phenomena, but when you're in the middle of the structures, you're not getting the trigger for the polymorphic VT. But if you trace this to the papillary muscle, in the right side, some people are calling anterior, I like to call lateral papillary muscle, same thing, but at that junction with the moderator band, and same false tendons where they are junction with the papillary muscle, you'll get syndrome of triggered VF. But in the middle, when we're getting either short sustained changing morphology or we're getting monomorphic VT.
Sam, just wanted to ask, this is from the false tendon. Should it not be wider? More basal would have been narrow. So how do we explain why?
Why it's wider?
Why it's narrow?
Why it's narrow. So the false tendon is going to attach to something. The septal part where it's attached, that's where it is getting its Purkinje tissue. That's where the Purkinje is coming in. So if you have a structurally normal heart, your first place that you're going to get the activation is in your upper septal fascicular region. And from there, you'll get downstream activation of right bundle, left bundle, other fascicles. Now, if your origin is on the lateral part of that, then you will reach the ventricular tissue before you reach the conduction system. Then you can expect it's going to be different. So one way to think is how different are these beats from sinus? The more different they are, even if it's an endocavitary structure, it's more away from the septum. If you are free structure like a false tendon and closer to the septum, the origin, it's just like quickly getting to the conduction system. Sort of like left bundle pacing, if we're very proximal, you're quickly coming to right bundle, left bundle, so similar to the sinus beat.
So, what was the QRS duration in this patient?
So during the Holter monitor, it was about 115, 110 milliseconds. In the EP lab, it was 118, 120 milliseconds.
I have two questions. When I did ablation from the fibromuscular band or moderator band, it is a little difficult to determine the exact site of origin because it's intercavity tissue, so it's difficult to map using the 3D. And
Yes.
after the unsuccessful ablation, sometimes the curious morphology significantly changed.
Yes. So just two quick points about that. Mapping the moderator band, even with ice, it's extremely difficult to actually sequentially map on this. You'll keep slipping. So one thing I like to do is take the catheter to the right ventricular outflow tract and then curl from apex towards base under the moderator band. So curl and use the curving to touch the moderator band. Then we are getting that point. Then to release, move, curl again, get the next point. Release, move, curl again to get the next point. Another one also useful is to use cryo not for ablation but for mapping. So idea is you take the cryo and when you touch with ice, turn down the temperature but only to -30. So you will not ablate the tissue. But at that -30, as you're cooling, you'll get the stability, take a point. Then release, so no ablation is done. There is full recovery. Go to the next one and then try to do. But is it really necessary to find that site? I think it is useful to minimize the ablation. But another clue also is in true moderator band VT, each beat is a fusion beat. There is a lateral exit, there is a septal exit. So you can pace map at both exits and see which is closer. And that gives you an idea like which part of the moderator band to focus. And then there we can do these maneuvers to get a nice map. It's very challenging. Sometimes you have to do all of these tricks just to get the map.
Thank you. Another question is, was there any mechanical effect when we do this kind of mechanical?
Yes.
Was there suppression or induction of the VT?
Yes, I actually remember doing a case. It may have been this case. One of our fellows, she's now practicing in Dallas area, and she saw me mapping, going behind, plucking, coming like this. She said, Sam, I didn't know you play the guitar. So that's kind of same thing that you're doing. But that mechanical effect sometimes is going to stop the PVCs themselves. So it has to be kind of you come to touch rather than going forward and touching, because then the mechanical force can be too much. So the going apical and then coming back to touch.
Sure. Any more case from your side?
No.
That's sure. Any questions from the house before we close the session? Sure. Thank you very much. Yeah.
Thank you very much.
Thank you so much, chairpersons and our speaker. We move on to the next session. As chairperson, I would like to invite on the dais Dr. Ajay Naik, Dr. Anil Saxena, and Dr. Suchit Mojumdar.
To begin with, we'll have Dr. Dave Frankel talking on refractory VT in sarcoidosis therapy, therapy beyond stellate ganglion blockade. Maybe I can have Dr. RD here on the dais with me, if Dr. Saxena is not. Good afternoon, Dr. Dave.
Okay, good afternoon, everyone. Thank you so much for the opportunity to be part of this fantastic conference. So again, I'm David Frankel from the Hospital at the University of Pennsylvania, and I'll be talking about the management of VT and cardiac sarcoidosis. So here are my conflicts of interest. And what I'd like to do is give a broad overview, beginning with immunosuppression and then progressing to antiarrhythmic drugs, catheter ablation, and wrap up with a couple words about sympathetic denervation. So the pathophysiology of cardiac sarcoidosis is, of course, more complex than most non-ischemic cardiomyopathy. So we begin on the left with the inflammatory phase of sarcoidosis as manifested by FDG PET uptake. And during this phase, we see a lot of PVCs, polymorphic arrhythmias, and the predominant mechanisms are going to be abnormal automaticity and triggered activity. Over time, the inflammation leaves behind fibrosis, and then we have the classic VT mechanism of reentry leading to monomorphic VT. And so let's begin by discussing immunosuppression. So this is a small series from Japan where they looked at PVC burden before and after initiating immunosuppression. And on the whole, the burden of PVCs did decrease with initiation of immunosuppression. A very interesting part of this paper was in 3 patients, the signal average ECG, the late potentials, which were present prior to initiation of immunosuppression, actually resolved with effective immunosuppression. Late potentials being the result of slow conduction from fibrosis, but this actually argues that you could also have slow conduction resulting from inflammation. Now, the other side of immunosuppression, I think anyone who's treated cardiac sarcoidosis patients has seen this as well, which is that the burden of VT will often flare right after starting immunosuppression. So in this study of 60 patients, also from Japan, in the first month following initiation of immunosuppression, 10 patients had sustained VT. And so I think it's important to be prepared that after you start prednisone, many patients will flare their ventricular arrhythmias, and that's not a reason to stop immunosuppression, but you just need to be prepared to see that and to treat that ventricular tachycardia if it does flare. Moving on to antiarrhythmic drugs, surprisingly little has been published about the effectiveness of antiarrhythmic drugs in patients with cardiac sarcoidosis. This is a multi-center series of cardiac sarcoidosis patients with VT assembled by Frank Bogan. And they used a stepwise approach in these 42 patients. So the first step was to implant an ICD and initiate immunosuppression. And that led to resolution of VT in half of the patients. The other 21 who were continuing to have VT, the second step was to add antiarrhythmic drugs, most commonly amiodarone or sotalol, occasionally class 1C antiarrhythmic drugs. And that resolved VT in 9 patients. And then the remaining 12 patients went on to VT ablation. So I would say antiarrhythmic drugs, as in other forms of structural heart disease VT, were moderately effective. So how good is catheter ablation? Well, this is data from that same series, 13 years later, now up to 158 patients from the US and Europe. And the burden of ICD shocks was reduced quite significantly in the majority of patients with ablation. So this looks pretty favorable. And the predictors of recurrence after VT ablation were not surprising. So number one, if the ejection fraction was lower, which I think is really a surrogate for more fibrosis, more extensive VT substrate, there was a higher risk of recurrence. And number two, if inflammation was not adequately controlled, again, there was a higher risk of recurrence. Why? Because those patients are having more of the automatic and triggered arrhythmias. Remember, PVCs are what are required to initiate reentry, even in the fibrotic stage. So not surprising that more fibrosis, more inflammation, higher rates of VT recurrence. We also looked at catheter ablation in the IVTCC, the International VT Center Collaborative, which was a large series of patients, and we compared the rate of recurrence following ablation in different etiologies of non-ischemic cardiomyopathy. So the best outcomes were observed in patients with ARVC. Those are very similar to what you would see with ischemic VT ablation, where you get nice confluence, dense patches of scar. And the most challenging outcomes were actually in sarcoidosis. And again, why is that? I think it's multifactorial, but number one, you have patchy substrate, often biventricular, often mid-myocardial, so that's one challenge. And then number two, I think that sarcoidosis is even more so than other non-ischemic etiologies predisposed towards developing new substrate. If the patient develops inflammation again, then that's going to lead to fibrosis in new locations and new VT circuits. Lastly, how good is cardiac denervation? So this was a small series from Johns Hopkins. They had 5 patients who are receiving ICD shocks despite antiarrhythmic drugs, despite one or more catheter ablations, and they underwent bilateral sympathetic denervation. One patient was only able to undergo unilateral sympathetic denervation due to surgical challenges, but at least in this very small series, sympathetic denervation was quite helpful. So to summarize, the pathophysiology of cardiac sarcoidosis seems to be uniquely complex and challenging, with that evolution over time from the early inflammatory phase to then the later fibrotic phase. But the inflammatory cycle can repeat over and over again over the course of the patient's lifetime. VT often will flare after immunosuppression is initiated, and again, that's not a reason to stop immunosuppression. Antiarrhythmic drugs are moderately effective. Catheter ablation is effective, though it's not uncommon that multiple procedures are required, and timing is key. We try not to ablate in that early inflammatory phase because most of those patients are going to get better with immunosuppression in some patients. But certainly in the fibrotic phase, once you see late gadolinium enhancement on MRI and a patient's having monomorphic VT, that's a very good time to ablate. And sympathetic denervation can be useful as a bailout. Thank you.
Thank you, Dr. Dave. That was a good presentation. We see a fair number of granulomatous myocarditis in our part of the world. And frequently what we do when we start immunosuppression is give steroids simultaneously. So is that something you follow to suppress the initial flare-up of the ventricular arrhythmias?
So I'm sorry, you said you give steroids and
steroids and
drugs
immunosuppression.
simultaneously?
Yeah, steroids and immunosuppression. And then time the ablation.
Yeah. So I would say similar approach for us. So the immunosuppressive regimen often will start with prednisone, and then we repeat the PET scan several months later till we have controlled inflammation, and then we'll sort of transition to the steroid sparing regimens over time. And again, yes, we tend to protect the patient with an ICD and try not to ablate in that very early phase unless it is truly necessary, because we know that a lot of that VT will quiet down over time. I can recall one patient, we started on immunosuppression, probably had 100 episodes of pace-terminated VT, and in the first couple of weeks after prednisone was started. And then, I've been following him for 10 years since and really has had nothing. So it's clear that those early arrhythmias were really driven by inflammation.
Any role of anakinra, IL-1 receptor blocker in inflammation inhibition among the immunosuppression or anti-inflammatory drugs? Anakinra.
Yeah, I would actually, I think that first of all, we've learned a lot from you guys in terms of cardiac sarcoidosis and some beautiful presentations over the years and very nice research. But I would like to hear what the experts in the room would say about their preferred immunosuppression strategies. We generally co-manage these patients with either a pulmonologist or a heart failure specialist who tends to make the decisions about the immunosuppression.
There's a question from the floor, Dr. Claire.
So, you gave the first line of therapy was the ICD plus immunosuppression. So what we have seen here that some of these patients, they respond very well to steroids plus, other immunosuppressants, where one could avoid the ICD. I don't know what should be the exact timing of the ICD in these patients. I do agree that if you have to give ICD, then you give before you start the steroid, just to avoid infection and things of other nature.
Yeah, thank you. That's a great comment. And certainly not every patient with cardiac sarcoidosis should get a defibrillator. I agree with that completely. So the risk factors that would push me towards implanting a defibrillator would be, of course, lower ejection fraction, lots of non-sustained arrhythmias, history of concerning syncope. There's some data that program stimulation can be useful to sort out who should get a defibrillator. And again, I think that's probably relatively similar information to what's available by the MRI. If there's a lot of late gadolinium enhancement, that's going to push me to implant the defibrillator. If there's conduction disease and you're worried about the patient needing pacing, then we're going to have a very low threshold to make that pacemaker defibrillator. But yes, plenty of cardiac sarcoidosis patients are okay without a defibrillator.
Yeah, this comment is particularly important because we have burnt our hands occasionally. Patients in sarcoidosis in the inflammatory phase, implanted an ICD and the patient goes into VT storm. So then we have to manage that. That becomes... Dr. Daljit, last comment, they have Dr. Daljit and Dr. Narasimhan, their center has done a lot of work in this. Some comments before we move on to the next topic.
No, same thing. I think I'll echo whatever you're saying, that if there is an inflammation, try to treat the inflammation. And we start, as you said, we start steroids along with the anti-inflammatory. Usually first drug is methotrexate. If it's not working, mycophenolate mofetil can be used. Biological, which we are talking about, either anakinra or rituximab, or we have used other drugs also, but that is with the support of same pulmonologist and rheumatologist, but those are the last resort where we feel that VT is still going on and inflammation is still there. There are some case reports we have done where there is an incessant VT or VT storm despite of everything and there is still an inflammation. But usually by far patient responds to steroid followed by methotrexate or few patients on mycophenolate. Few patients we have given cyclophosphamide also. But all these with the support of we are having rheumatologist and pulmonologist with us. Thank you.
Thank you. Thank you, Dr. Dave. That was fantastic.
Thanks for the honor of participating. Enjoy the rest of the conference.
Dr. Sanjay Dikshit. My pleasure to invite Dr. Sanjay Dikshit. He'll be talking about endpoint of scar VT ablation. a tailor-made approach. Hi, Sanjay.
Hi, how are you?
Good, and
to
Dr.
see,
Saxena,
uh,
please come on the dais.
Are you guys able to see the slides?
Yes, we can hear you, we can see the slides.
Terrific. Well, it's always a pleasure to participate in this forum, and it's great to see old friends. And Suchit, congratulations on organizing this symposium together with your team, and thank you for inviting me. So, I've been asked to speak on endpoints of scar VT ablation. Now, you already heard from Dr. Tung about his methodology. You heard from my colleague, Dr. Frankel, about his approach for a very specific form of ventricular tachycardia presentation. What I'm going to try to do here is just discuss with you some of the ways in which we go about targeting scar-based VT and then the endpoints depending on the approach that we choose. So now for any ablation, but particularly VT ablation, the procedural endpoint should be failure to induce the targeted VT, and ideally all induced VTs, and we certainly try to do that. But then there are other endpoints which are equally important, if not more important. And foremost is that whatever you do, the patient should leave the EP lab stable, awake, and alert without any neurologic complications. If the patient presented in storm, then you want to make sure that you achieve non-inducibility, and then during the rest of the hospitalization, the patient remains VT free. And you can also test this pre-discharge after a few days of VT to make sure that the acute endpoint holds. And then the long-term goal is really to get them off antiarrhythmic drugs. But all of these endpoints, I think, are primarily driven by procedural success, and that's why we focus a lot on this. So when it comes to scar-based VT, the majority of these tachycardias, the mechanism is a re-entry. And the goal of VT ablation is to target the critical components of the re-entrant circuit. And the gold standard for identifying the re-entrant circuit is entrainment mapping, and we are all very familiar with this concept, which was developed by Dr. Bill Stevenson, the way he conceptualized different components of the VT re-entrant circuit. And the way to go about identifying that is to pace during ongoing tachycardia. And then when you stop pacing and the tachycardia resumes, you perform a series of measurements such as post-pacing intervals, STIM to QRS, to understand which part of the re-entrant circuit you are in. And the goal is really to find the isthmus region. So the key, and this is the point that has been made over and over again, to do entrainment, you need reproducible inducible tachycardia, which is sustained and tolerated, as was the case in this particular example with a patient who had a posterolateral infarct and sustained VT. And ideally, if you're able to characterize the substrate, and then within the substrate, you perform entrainment mapping from different locations, then in this particular example, you can see that you entrained by overdrive pacing at a rate slightly faster than the tachycardia cycle length. The tachycardia is advanced, which means the maneuver is good. When the tachycardia, when the pacing maneuver stops and you do the measurements, the post-pacing interval is very close to the tachycardia cycle length. The stimulus to QRS in this case is about 50% of the tachycardia cycle length, which makes it in this isthmus region. So if you've been able to identify the isthmus region, then typically ablating in this location results in slowing and termination of the tachycardia. And this is really a very gratifying way to ablate VT. But the challenge with this approach, and this was recognized early on, there's some of the early series from two centers that were exclusively doing entrainment mapping, Dr. Stevenson's center and Mark Josephson and Beth Israel Deaconess. And in Mark's experience, acute termination of the tachycardia was achieved with 95% of the patients. If you were able to identify the isthmus region with a single lesion, it wasn't quite as good with Dr. Stevenson. But in both these instances, the long-term freedom from ventricular tachycardia with a very limited approach targeting the isthmus region was less than ideal. And so even if you're doing entrainment mapping and you are lucky to find a tachycardia that allows you to do it, you oftentimes have to do more than target just the isthmus. And so that's where the concept of substrate modification has been developed, and that's being utilized more and more, if not exclusively, in the majority of cases. Now, there are different strategies for substrate modification, and depending on the strategy that you choose, there are these different endpoints that you typically try to achieve. So the early experience with substrate modification, and this was developed by my mentor, Dr. Marchelinsky at Penn, and the way he conceptualized this was that you spend the time to do a very detailed map in the chamber of interest. In this case, there's a patient with a healed anterior apical myocardial infarct. And you can see that when you do a point-by-point detailed map, you can identify the dense scar, the border zone, and then the relatively healthy myocardium. Now, from the prior experience that we had in the OR during the early period of surgical VT ablation, the majority of the exit sites for ventricular tachycardias typically happened around the border zone. And so the way you try to do substrate modification in this approach is to define the substrate first, identify the border zone, and then perform very meticulous spacing around the border zone to match the paste complexes to the clinical and or induced VTs. And then you demarcate those locations. Now, the concept is that the re-entrant circuit, the critical component, is typically not very far from the exit site. So presuming that the best paste map sites at the border zone represent exit locations, you drop a series of linear lesions into the dense scar. And using this approach, he showed in the seminal paper that was published in 2000 in Circulation that you could achieve long-term freedom from ventricular tachycardia with a substrate modification strategy shown here in the order of about 75%. And these were both patients with ischemic and non-ischemic cardiomyopathy. But at that time, he didn't really define an endpoint of the linear ablation strategy besides just non-inducibility. No clear endpoint was identified for individual lesion creation. But over the years, all of us who do these procedures certainly use certain endpoints during lesion delivery. And those include steady decrease in the impedance during energy delivery, depending on how long the lesion duration is. Typically, you're trying to target an impedance drop of about 10 to 12 ohms with steady increments in energy. Obviously, you don't want to do this too quickly because you can cause a steam pop. So that's why you have to deliver slow increments of incremental energy, depending on how the impedance is responding. If you are performing a good lesion, then you typically should see some local changes, attenuation of the signal, change in the polarity of the signal. If there's a late potential and you're targeting it, sometimes you'll see the late potential get delayed or also go away. One of the things that we do for the majority of our cases is to use intracardiac ultrasound. And so if you have that luxury of using ice, it can be very helpful. Like in this particular case where you're ablating in this dense aneurysm, and you can visualize the lesion. As it's happening during energy delivery, you'll notice this opacification or echogenicity appear on ice, which is a sign that you're causing damage to the tissue, whether that's edema or permanent damage, time will tell. And then, of course, one of the principles that we utilize is that at the end of creating a lesion set, whether it's a linear lesion set or core isolation, you want to perform high output pacing throughout the lesion set to demonstrate that you've achieved local electrical inexcitability, which is an important surrogate for showing that you have affected the tissue sufficiently. Now, substrate modification, obviously, as we originally conceptualized it, has certainly evolved a lot. And there are many ways in which substrate modification has been enhanced to make it a little bit more precise than just linear ablations at the border zone. And the most frequent approach to improving substrate modification is to target late potentials. Now, late potential is not a new concept. As early as 1986, when surgical VT was being performed in the OR at Penn, Dr. Josephson and Dr. Cassidy, who was a fellow then with us, was able to identify the value of these late potentials. And then over the last several years, many other investigators have delved in this area, have identified the value of late potential mapping. And depending on how you characterize the late potential, sometimes you need an isoelectric segment between that and the QRS. Other times, it could be a combination of different coupling intervals of the late potential. But late potentials are important, and the importance was brought out in this paper by Dr. Henry Shah when he was at Penn. And this was a very well done study in which he looked at a series of patients. Majority of them had ischemic cardiomyopathy, but there were also patients with non-ischemic cardiomyopathy. And the way he went about doing this is you characterize the substrate in great detail, just like I showed you in the example earlier. And then within the substrate, he looked at the distribution of the late potentials. And then in these patients, they also had sustained tolerated VT. So then he performed entrainment maneuvers to really identify the critical components of the reentrant circuit. And then he went back and analyzed late potential distribution vis-a-vis the critical components of the reentrant circuit. And what he found is that the majority of late potentials tend to localize around the entrant or isthmus sites of the reentrant circuit. So that's the value of late potentials. But it's also important to note that there are other areas outside the reentrant circuit where you can also have late potentials. So not every late potential is representative of the reentrant circuit. Now, when it comes to targeting them, obviously there are two different approaches. I've shown this example many times, and this is the approach used by Dr. Natal and Dr. DiBiase. The publication came out in 2012, but the concept is that once you've identified the scar, then basically every late potential in that scar is either representative of the VT circuit or has the potential to become a reentrant channel. And so they perform this very extensive ablation of the entire substrate, which they call scar homogenization. Oftentimes, they go both endocardial and epicardial. And many investigators and operators have moved towards this approach where they basically just do a substrate map. They don't even induce the ventricular tachycardia and simply modify the substrate. And there's certainly been long-term follow-up in these patients, and it seems to work. And so there is value to this approach. But there is also probably equal value in trying to understand the late potential distribution, how that might correlate with the reentrant circuit. And so this is another approach, which is very meticulous characterization of the late potentials in the dense scar, and then identifying the coupling intervals of the late potentials to the preceding QRS. And looking at this coupling interval, you could conceptualize that if there's a channel here, then deeper in the channel, the coupling interval will be longer, and at the edges of the channel, the coupling interval will be shorter. And this original series of patients, these investigators basically targeted only the entrance of the channel within the scar, and just doing this very limited ablation, they were able to abolish the potentials in the depth of the scar. So as a concept, this is very good, but again, it requires very, very detailed mapping and remapping, which is not always possible. Another way to understand how the scar behaves in terms of sustaining VT is this particular example. This was my patient, but I followed the principles that were outlined in Dr. Stevenson's original paper, which was published in JACC in 2003, where you have a posterolateral infarct. This is the clinical tachycardia. And as you pace from these three locations inside the scar, you can see that you're mimicking the tachycardia in each of these cases. But as you go from site 1 to site 3, the time that it takes to generate the QRS gets progressively shorter. And so this is one other way to understand that if there is a reentrant circuit, it's probably traveling in this direction, which then allows you to maybe design a lesion set to transect it. So that's another way to kind of understand how the scar may be sustaining VT. Now, there are different kinds of scars, and often in patients with healed infarct, especially those who are coming for repeat ablations, the scar can sometimes be very dense and inexcitable using traditional high outputs. Most of these stimulators can generate an output of 10 to 20 milliamps. And so in this particular series in patients where the scar was traditionally inexcitable, we then performed very high output pacing at 50 milliamps. And here is an example of a very dense posterior scar in a patient who had undergone multiple unsuccessful ablation attempts. And you virtually have nothing in this scar that can even be conceptualized as a local signal. But when you pace at 50 milliamps within the scar, you can see at these two locations, you have different exit sites which generate a QRS that matches perfectly the ventricular tachycardia. So this is one of the things that we have utilized from time to time to further characterize traditionally an excitable scar and identify and successfully target VT circuits within that. Now, one of the concepts that we developed many years ago is this core isolation. And so this is kind of our approach to doing a more limited ablation of ventricular tachycardia and modifying the underlying substrate. And so this is potentially how it can work. Here are two examples. Here's a patient, both of them, there's a posterolateral infarct. In the first instance, we were able to sustain the VT, and so you had the opportunity to actually perform entrainment mapping. And so within the dense scar, you're able to identify the isthmus entrance and exit in this region of the scar. And here's a second example where the ventricular tachycardia was not tolerated, so we performed the approach of characterizing surrogates by identifying late potentials, spacing the late potentials, and kind of configuring in some ways how the VT might be utilized in the scar. And so then depending on how careful you are with defining the reentrant circuit, if you have used entrainment mapping, you can do a very limited core isolation around where you thought the circuit was to render the center inexcitable. In the second instance, you have to do more extensive ablation to achieve inexcitability. But the idea is that if you do this so-called circumferential lesion set in the scar, and if you do a good job of that, then the center or the core of the scar becomes inexcitable. And this we have found to be helpful, although sometimes it requires very meticulous mapping, sometimes two catheters in the dense scar to demonstrate both entry and exit block, just like what we may have done with pulmonary vein isolation in the past. Now, it's also important to recognize that when you're performing core isolation, or for that matter, any approach, the nature of the disease to some extent drives your ability to achieve the endpoint. So here's a patient with non-ischemic cardiomyopathy who's coming for a second ablation after having failed a prior attempt elsewhere. It was clear for the cardiac MRI that this patient had an epicardial substrate. So we went to the epicardium up front. You can see that this very well demarcated extensive scar along the anterior lateral wall with late potentials and a variety of other findings. But what was very interesting is that in the depth of this dense scar was relatively preserved myocardium, and the reentrant circuit was in some ways traveling through this, at least on the epicardial aspect. And this was a relatively safe zone. You can see the phrenic nerve represented here is far from it. The epicardial coronary vessels are also at a safe distance. And so we targeted this area with the goal of trying to achieve core isolation of this particular zone of relatively healthy tissue, which was part of the reentrant circuit. And despite achieving circumferential lesion set, we still could not get rid of this particular electrogram at the center. And this was critical because that's where we knew the reentrant circuit was. And so in this case, after having failed to achieve core isolation from the epicardium, we actually went to the endocardium. And although the endocardium does not represent any of the voltage abnormalities that you saw in the epicardium, right opposite the location where this late potential was on the endocardium, you can see a similar late potential, but with an earlier coupling interval. So this is almost continuous activity on the endocardial aspect. And then targeting this area, we were able to abolish the epicardial late electrogram. So again, the scar can sometimes be three-dimensional, especially in patients who have non-ischemic cardiomyopathy, and sometimes a combination of endocardial and epicardial ablation is necessary to achieve core isolation. But in our experience, it's very seldom needed for patients in field infarct, where you can achieve most of this, 80 to 90% of the times, from the endocardium. And again, we practice core isolation whenever we can, because in this observational series that we first published, it certainly added value to traditional ablation in improving long-term outcomes. But this is not our exclusive approach. When we can, we do core isolation, but it's not uncommon for us to oftentimes deliver linear lesion set to transect the scar, but get all the critical components of the reentrant circuit. So to summarize, obviously the most common mechanism of VT in patients with scar is reentry. And so the end point of VT ablation in these patients is to modify, if not abolish, critical components of the pre-entrance circuit. And when you're trying to do that, depending on what approach you're using, if you're able to entrain the ventricular tachycardia and characterize these different components, then ideally you want to see slowing and termination of the tachycardia during lesion application at the site of the critical component, which is oftentimes the isthmus. If you cannot induce the VT, then you use surrogates. But the goal at the end of this strategy is to achieve non-inducibility of the tachycardia. And obviously, as I mentioned, defining critical components of the VT re-entrance circuit, in my experience, is what's needed to really modify the scar adequately. Again, when you're trying to do that, it's very important to deliver effective energy. For that, you use many pointers, including impedance drop, electrogram modification, and of course, with ICE, it really provides additive value. I'm going to stop here, and I appreciate everybody's attention. Thank you.
Thank you, Sanjay. Excellent talk. Anil here. So, obviously, as usual, it was an excellent talk. Now, you rightly pointed out in the beginning that it's very important that the patient leaves the lab safe and fully alert, and blood gases should be normal, no acidosis. And sometimes these ablations, they continue for several hours with some or the other inducible VT. Sometimes it happens that you have eliminated the clinical VT, but the patient has other inducible VTs which are faster, sometimes pleomorphic, sometimes. So how long should we pursue in patients who have severe LV dysfunction, extensive scar? It becomes nearly sometimes, something or the other keeps getting induced. So what is your recommendation in that setting?
That's a great question, Anil. These are very challenging cases. Oftentimes these patients have really bad LV function. They start off not infrequently in heart failure because they've been having VT storms. Now, we are very fortunate at Penn that we actually have cardiac anesthesiologists that work on all the cases with us, not just VT ablation. And I can tell you that that didn't happen from the get-go. It was something that we slowly got the resources. But in the last 8 or 10 years, we've had that support. And I can't tell you how much value there is to having an accomplished team, especially cardiac anesthesiologists, because they are very good at recognizing all the things that you pointed out to. So just to kind of give you a sense of how we go about doing this, if a patient has all the potential complication situations that you described, it's not uncommon that sometimes our anesthesiologist upfront will put a SWAN or PA line to kind of assess their baseline status. If we anticipate that the procedure is going to require all these things, and we can even anticipate that there are going to be significant changes in the hemodynamics, sometimes we'll have the surgeons help us get ECMO access to provide hemodynamic stability during the case. Now, that happens very rarely because in the era of substrate mapping, our approach is that you get the patient in the lab. I generally don't do general anesthesia up front, as some of my partners do. Those who practice general anesthesia throughout the case will do a NIPS before the patient is put under. I try to do the case under conscious sedation because I think it's a little bit easier to maintain the hemodynamics. But again, it's a very limited induction to get the tachycardias identified. Once you've done that, then you kind of do a lot of pace mapping as you're building the scar to identify surrogates. And when you're doing it in sinus rhythm with just limited pace mapping, you can actually spend about an hour or two to really get the substrate characterized. And if you've gone through all these steps, you oftentimes don't induce VT more than twice at best. Now, that being said, there are cases where there's incessant VT every time the catheter moves. In those cases, what I've done is, as I'm identifying the substrate, if there is one area where the VT tends to be happening a lot more, I'll just do some limited ablation there to quieten that VT down. That allows me. So going through all these steps, an average case for us takes anywhere from 4 to 8 hours. But if we have, regular measurements of the AB, the acid-base analysis, the gases, together with the hemodynamics and supporting blood pressure, oftentimes a combination of epi as well as, other agents with the anesthesiologist working with us, the majority of these patients we can get out of the lab safely.
No, there is a question from Dr. Claire, sir. Clear.
Sanjay, this is Dr. Clare. Good morning.
Hi, how are you?
All well. So I just want to ask you, when you say non-inducibility, do you mean without isopril? Or if you mean with isopril, how much isopril, what dose, what are your kind of targets in that situation? You know, it all depends upon the aggressive protocol you use as far as the non-inducibility is concerned. One extra stimulus, two extra stimulus, long, short cycles. So what is kind of routine in these patients?
Right. And all good questions, Dr. Clare. So first, because this is CAR-based re-entrant VT, we typically don't utilize isopril for these cases. In the majority of these cases, you are able to get the VT to start. Now, when we do program stimulation at the beginning, we start in the RV, and my approach is to just use a 500 millisecond drive cycle length and do singles, doubles, whatever it takes to get the VT going, typically up to triples. If I can't get it from the RV, then I go to the LV. As I'm building the substrate in the LV, I try to do program stimulation from the LV, again using the same approach. So with this approach, in the majority of cases, we are able to start the VT. At the end of the case, we perform, again, program stimulation going up to triples, and ideally from two sites, either two sites in the RV, or my approach is to do one site in the RV and one site in the LV. We don't use isopril for re-entrant ventricular tachycardias. We don't do short, long, but definitely triples down to a coupling interval of 200 milliseconds at least, or failure to capture.
How many times you go epicardially? How many times you go epicardially in post-MI scar VT?
Less than 10%.
And what about the newer modality of energy like PFA for VT ablation?
Yeah, I mean, there's a lot of interest in it. And obviously, there are some very early studies that are investigating it. But right now, we really don't use that the only time I think it's been used maybe is once at our center, which was maybe a couple of weeks ago for a failed VT case. But no, majority of the cases are still done by radio frequency ablation.
So Sanjay, when it comes to the question of mechanical circulatory support to these patients, do you decide upfront, or when you see patient is not doing well or lactates are going up? That's number one. Number two is whether you use ECMO or use Impella or both.
Yes, very good question, Dr. Clare. So we've learned with our experience in these cases that if you are trying to do a bailout ECMO, then the patients are generally doing very poorly and their outcomes are terrible. So we try to do the best that we can to identify the patients who are going to be requiring hemodynamic support up front. And if a patient needs hemodynamic support, our go-to strategy is ECMO. We have a surgical team that's really good about doing this, and if the patient is managed by ECMO, they end up going to the surgical ICU. The surgeons are very meticulous about post-ECMO care, which is probably as important. Sometimes patients can lose a limb if the post-ECMO care is not good. But if you really need hemodynamic support, ECMO is the way to go. We did use Impella in the past, and it made us feel good, but if we induced VT, the ability of Impella to support hemodynamics was really not very good. And oftentimes, if you're using CAR-T to map, as the Impella battery kicks up and you're getting close to the Impella, it can cause a lot of motion artifact. So if the patients need hemodynamic support, we try to get that up front, and ECMO is the preferred strategy for us.
Thank you, Sanjay, for a very insightful presentation and discussion.
So quick question I just wanted to ask.
Yeah, okay.
If a patient is on antiarrhythmic drugs and you're taking him for an ablation, so do you stop the antiarrhythmic drugs or continue the antiarrhythmic drugs?
Yeah, no, if somebody's in VT storm, then obviously they continue with the drugs. But if a patient is being brought electively, we typically try to stop amio 2 weeks before, and non-amio agents for 5 half-life, which is about 2 to 3 days.
Thank you.
Thank you. I think we come to the end of this session. Thank you so much, Sanjay.
Terrific.
Always
Thank you
great
very much.
to hear from you.
Pleasure to see you all.
Next talk, Dr. Anish Tolar, managing frequent ICD shock in ARVC, role of ablation.
Hi, good afternoon. Can you
Hi Anish, how are
hear
you?
me okay? Hi Ajay, nice to see you. Let me just get my talk ready here. Can you see my slides?
Not yet. Yeah, now they've come up.
Okay, great. So you can see my slides, correct? Ajay, are you able to hear me?
Yes, we can see the slides. We can hear you.
Okay. Okay. So this is full screen?
Yes.
Okay. So thank you to the organizers. Thank you to IHRS for inviting me to speak today about the topic of VT ablation in patients with ARVC. Congratulations to the organizers. And it's an honor for me to speak. As you know, I do come also to do some charitable work in India. And so it's really a delight for me to present this to you today. The topic that I was given was the discussion on the role of VT ablation in patients with recurrent ICD shocks and ARVC. Throughout the talk, I'll be referring to ARVC as arrhythmogenic cardiomyopathy, and I'll show you why, but essentially the field has really moved towards eliminating the idea of just RV cardiomyopathy and really moving towards the concept that the arrhythmogenic cardiomyopathy may involve not only the RV, but also the LV. So as most of you know, the determinants for ARVC really come back, arrhythmogenic cardiomyopathy come back to the pattern of genes and inheritance involving the desmosomal proteins. The desmosome involves the connection between myocardial cells as shown here, and these proteins, which have really been well understood now, the most common of which is plakophilin PKP2, has been shown to be at issue when patients exercise and are much more active. The mutations affect the ability of the cells to remain joined together, causing and leading to fibrosis as well as fatty deposition interspersed amongst the myocardial cells. This example shows a post-mortem ARVC or ABC or AC patient where you can appreciate in the right ventricle as shown here, the anterior free wall is replaced largely with fatty tissue and with thinning of the RV musculature. And you can see on the microscopic slide here, muscular fibers here replaced with fibers and fatty tissue. For those that are interested in taking patients with arrhythmogenic cardiomyopathy to the lab, it's important to understand the locations of this fibrosis and fatty infiltration. The most common location that's involved with arrhythmogenic cardiomyopathy patients involving the RV, as you can see on this slide on the right, involves the subvalvular, the subtricuspid valvular area, followed by the outflow tract as shown here, and to some degree often the apex. But the subvalvular and the outflow tract regions are the most commonly involved. This top panel shows a patient who has early cardiomyopathy. The bottom panel here shows late cardiomyopathy. And what you can also appreciate is that the voltage maps that are demonstrated here, this map showing a endocardial voltage map shows relative sparing of the endocardium And you can contrast that with what is going on in the epicardium, where you have a large degree of involvement of fibrosis and fatty infiltration. Contrast that in patients who have more advanced cardiomyopathy. You can see that even on the endocardial maps, there is endocardial involvement, here shown in the outflow tract, that is a progression of the disease process. And so, besides understanding location, the common locations for arrhythmogenic cardiomyopathy fibrosis, it's important to understand that the disease progression occurs from the outside in, so that the epicardium is first involved, followed by the endocardium, based on studies that have been published. I'd also like to just take a moment to remind our audience that patients have had LV involvement with arrhythmogenic cardiomyopathy, and this has been seen particularly in more advanced RV cases, so that if you have a patient with late stage arrhythmogenic cardiomyopathy, you are also more likely to have LV involvement. And there are a category of patients who have LV dominant arrhythmogenic cardiomyopathy, and these are often misclassified as patients with perhaps a non-ischemic cardiomyopathy. But if you take a history and perhaps highlight the family history, and if you have the ability to perform genetic testing, you may come across patients who have desmosome mutations. And we have in our practice identified some patients with this entity. And I would refer you to this article published by Dr. McKenna and his group that really highlights the importance of not forgetting about left-dominant arrhythmogenic cardiomyopathy. I'd like to discuss a case of a patient that we took care of 2 years ago who was very challenging. He is now 73, but he was 71 years old at the time with quite advanced arrhythmogenic cardiomyopathy. This patient had evidence for liver cirrhosis from right-sided heart failure. He had been managed on amiodarone for many years, and more recently had come in with recurrent VT. He had multiple hospitalizations for VT, and finally presented with VT storm on amiodarone, mexiletine, and even was placed on ranolazine in the hopes of trying to control the VT. He did have a defibrillator implanted and was receiving therapies from the device. This is both endocardial as well as epicardial maps, voltage maps, and you can see on the left, the endocardial voltage map demonstrates fibrosis and low voltage in the area just below the tricuspid valve, with some involvement of the RV outflow tract and some sparing of the anterior wall here. We also ended up going epicardial in his case, and you can see here a large amount of fibrosis with no voltage seen on the epicardial surface, which is what you would expect in more advanced cases. We took him to the lab and did induce VT. In fact, we induced 5 different ventricular tachycardias in this patient. And as Sanjay had said earlier, we use cardiac anesthesia for all of our VT ablations. In this case, I believe it was critical to his overall survival because the cardiac anesthesiologist involved was phenomenal in keeping his blood pressure up. He did go in and out of multiple VTs, and so this slide shows one example of a VT where we mapped a mid-diastolic potential on the ablation catheter. We used a multi-electrode catheter to begin with, and you can see here this morphology of VT with mid-diastolic potentials seen. This was an activation map we made in this patient. Where you can appreciate that the patient has a high amount of scarring in this area. The pink dots represent fractionated electrograms, and the blue dot is where I will demonstrate some entrainment that we also did. But we found that this patient had multiple VTs, very similar pattern of activation, all involving the subtricuspid valvular area. In this case, although there was some scarring above, as you had seen earlier, where we had another isthmus. So this was the entrainment we performed in this patient, and you can see here that the VT cycle length is about 410 to 410 milliseconds. The mid-diastolic potential here is seen. In this case, this patient had a somewhat little bit of a right bundle looking VT with a superior axis. And when we did the entrainment, you can see that the post-pacing interval here is 425 milliseconds. We have concealed entrainment with the QRS really unchanged from entrainment and its native form here. Ablation in this area, and you can see again the electrograms on the ablation catheter during RF slowed the VT and eventually terminated the VT, and we did this multiple times in this patient. After mapping this patient and performing and chasing after his 5 VTs, he now has been quite stable and has gotten back to a great quality of life, and we've continued to follow him in the clinic and now out more than 2 years with no recurrence in VT. The approaches to VT ablation in patients with arrhythmogenic cardiomyopathy have been discussed in the literature, and the most effective way that our colleagues have demonstrated the approach to ablation really involves a combination of both endocardial as well as epicardial ablation. That really is the most effective. However, we do have to consider the risk of epicardial access, remembering that these patients' right ventricles are markedly enlarged and sometimes replaced with fatty tissues. So I do think there is more risk with this. Endocardial ablation could also be considered first, and if the patient still has recurrent VT, you can consider epicardial ablation. And so these are really your two options. I'll also share this paper with you from the Bordeaux group, where they studied patients with non-ischemic, ischemic, and arrhythmogenic cardiomyopathy patients. And in this paper, they placed catheters on the epicardial surface, multi-electrode catheters as shown on the slide, and performed ablation endocardially. And what they really demonstrated, which is nicely demonstrated in this paper, here you can see the endocardial voltage and the epicardial multi-electrode catheter voltage with signals. And during RF ablation on the endocardium, you can see loss of the epicardial late potentials that we often look for. And so this gives some perhaps evidence to the concept that sometimes we can ablate endocardially to eliminate epicardial signal, perhaps making that a reasonable first approach. Baruzio and colleagues did perform a registry study of a combined endocardial and epicardial approach to ARVC or ABC ablation. And you can see here that patients who had right ventricular arrhythmogenic cardiomyopathy did quite well, almost out to 3 years, with a fairly high success rate in terms of recurrent VT. The patients who had left dominant arrhythmogenic cardiomyopathy fared far worse. But I want to also point out in this 41 patients, 2 patients were reported to have pericardial tamponade, and there was 1 death in the EP lab due to tamponade related to epicardial access.
Dr. Anish,
and so I think that gives a little bit.
We are running out of time, so can you please conclude? You have more
Sure.
slides?
Just a couple more.
Yeah, sure.
So VT ablation from the Penn group data demonstrates a significant reduction in VT. As you can see on this slide, basically post-ablation, no VT, pre-ablation, significant amount of VT, median episode 13. And the Penn group has also demonstrated in arrhythmogenic cardiomyopathy patients that you can see a significant reduction in the use of antiarrhythmic drugs. So amiodarone, really far less post-ablation. So to summarize, VT ablation can be used successfully to treat patients with recurrent VT and arrhythmogenic cardiomyopathy. Fibrosis starts from the epicardium and progresses inwards towards the endocardium. And while epiendo ablation has been shown to be most effective, it certainly may be reasonable to start with an endocardial ablation first.
Very good lecture. If you have scar from endocardium mapping, then you will not go epicardially, or you will routinely go epicardial?
I think that if you have scar endocardially, it's certainly reasonable to start with that first if you want to be conservative. And then if you have recurrent VT, you can certainly consider. Some people may disagree, and I think that tends to be still an area of controversy.
Because the RV is not that thick. They are mostly 4 millimeter, and from endocardially you can reach the up to outer wall even. So does it require epicardial in all cases? I don't know why. The study has shown yes, but I don't know.
Well, I think that. Go ahead.
Again, the use of PFA as a possible source of energy for ablating in the right ventricle. Any experience with that in any paper has been reported?
For arrhythmogenic cardiomyopathy, I am not aware of any papers that have reported this. There is experience, as I think Sanjay had mentioned, but there have been case reports now published. Rod Tung had a case report in an ischemic patient with the Farapulse catheter used at the apex of the LV in a post-MI patient.
So thank you so much for your presentation, and I think we can close this session now. Thank you. There is no further question.
Thank you.
So there's one more presentation that was missed out earlier, which is a lecture by Dr. Roderick Tung, and this is a recorded talk on SCAR-VT, my approach to ablation, alarm versus activation map.
Thank you for the opportunity to talk about ILAM 2.0, identifications of lines of block, and finding the VT circuit during a sinus rhythm. These are my disclosures. So we now understand that critical sites for VT co-localize to deceleration zones, but we further have more understanding of the mechanism of deceleration zones, which are they're actually lines of block. So rather than just slow conduction, these are pebbles in the stream with a fixed anatomic barrier, as evidenced by a greater than 20 millisecond isoelectric segment. Now, why 20 milliseconds? Because 10 milliseconds and 5 milliseconds can be highly subjective. So we wanted to make sure that there's no pass-through, there's two discrete electrogram components, which tells you there's a clear wavefront discontinuity that cannot get through that local site, which is a line of block. And like lines of block are great potential boundaries for VT isthmuses. So it could be as simple as a fixed model where you have lines of block during VT and the same lines of block during sinus rhythm. Here would be an example of an anterior apical infarction with VT, beautiful coming down the nose of the apex with a figure of 8 pattern of reentry. We look at this very extensive anterior apical infarct, and we take a look at what sinus rhythm looks like. And here you can see the sparkle map of the propagation of the ILAM, and you see a U-shaped fixed boundary during VT, which is exactly mirrored as a U-shaped boundary with high rotation, what the Japanese called rotational activation patterns during sinus rhythm. We find that these U-shaped boundaries are highly arrhythmogenic because they're doing a 180-degree turn even during a baseline rhythm. So why would reentry favor any other area that is already almost reentering during a baseline rhythm? But we'll fix our eyes on the bottom part of the U because you have 2 lanes in the lateral boundaries, but you have a depth boundary as well. And this is the complexity of the 3-dimensional nature of VT. Here you can see that as it comes down the isthmus in the lanes, it actually then reemerges below the surface, and that is evidenced by an activation gap. And these gaps that are not seen on the surface are likely due to intramural activation. There is no other possibility if VT is ongoing and you're not recording it from the surface with adequate contact. It must be a logical inference that this is happening below the layer of recording. So we're typically used to seeing 2D VT with the Stevenson model, but we need to start thinking about VT as a 3-dimensional structure. And there you might not see the isthmus. You'll only see the entrance and you'll see the reemergence and the exit. So a line of block is actually not only a barrier that it has to go around, but in a 3-dimensional cross-sectional model, it can serve as a depth boundary in a hyperboloid. So it comes on the surface, you've got surface fibrosis, it goes below the surface, and then reemerges. So these will often dictate the extent of intramural activation. And a given line of block is more likely to create depth boundaries with the isthmus and cross-section than it is to be on one monolayer and one surface. And we've been looking at finding what the best vantage points for 3-dimensional VT is. Do you ablate where it enters the intramural space? Do you ablate where it's within the intramural space and you have activation gaps? Or do you ablate where it reemerges or it breaks through back to the surface from the intramural space? And we're starting to find signals that the intramural exit, when it resurfaces to normal tissue, might be the best vantage point. So the most common pattern you're going to see whenever you have the luxury of mapping VT is this break and wrap pattern. You get breakout, it looks focal in nature, and then it wraps back around to the entrance site, and you don't see the isthmus. So these are often misinterpreted as focal VTs, but instead, all it is a hyperboloid VT circuit with the waist of the hourglass below the surface. You've got a wrapping pattern, it reemerges, and then you've got your activation gap, and that's determined by your depth boundary, which is a surface line of block. So what about the other 50% of isthmus boundaries if you only see D cell zones as lines of block 50% of the time? Well, it could be it's happening completely normal tissue. And that is unlikely because we don't have any preclinical models to induce monomorphic VT in the absence of scar. Number two, it could be that they're already abnormal and you need some functional perturbation like S2 and S3. Or it could be that you do have a line of block, but it's concealed by a random, arbitrary, it's unintended, suboptimized wavefront. So we all arbitrarily say, I'm going to do it during sinus rhythm. I'm going to do it during RV pacing. This is an LV substrate, and none of these wavefronts are that close to the LV substrate. So here you have wavefront collision to a line of block. It results in simultaneous arrival, lava fractionation. So this wavefront convergence or collision is not ideal, and it's suboptimal to identify a line of block. But if you happen to get a wavefront that's closer to the line of block, then you'll see split electrograms. And this is nothing more than the concept of differential pacing. So why are we not using differential pacing in the ventricle? And we probably should. So here you can see pacing is fractionated, continuous electrogram, no line of block. No pacing, 100 milligram split. So it is dependent upon the wavefront, whether you even see a line of block or not. And here you can see that you've got linear activation with late electrograms, but if you pace the latest site, then you get this wide splitting of 160 milliseconds, and you even get triple components here as well. So clearly, you wouldn't say there's an overt line of block in this late zone, but then you can unmask these concealed lines of block with differential pacing. So here would be an example where you have three distinct VTs that were all mapped. We take a look at this anterior infarction. It was during bi-V pacing, which is not ideal, but even with bi-V pacing, when there's wavefront convergence, there's still enough conduction delay where you see a late zone of activation. And you see these wavefront discontinuities, which are indeed lines of block because they're separated by greater than 20 milliseconds. And when we take a look at wavefront collision or convergence, you often will see a curvilinear activation if you use a linear catheter. This is why we still enjoy using linear catheters, because mechanistically it allows the eye to see wavefront convergence and it allows us to sense linear block patterns. So here you've got wavefront convergence, and you cannot assess if the site of final arrival or collision actually has a line of block. It's clear the electrograms are abnormal, but there's nothing that's clearly separated by 20 milliseconds from local components. So when we do differential pacing in real time, you get a linear catheter, you can pace at the site of convergence. And let's say here, we're going to pace here at 1920. And you can see that there's activation up the linear catheter, but there isn't activation down the lower poles of the catheter. And as a matter of fact, the longest electrograms are the areas that are most close to the line of block. If we pace at 910 on the lower portion, we can assess if it's bidirectional. And you can see there's activation down directly below, and you've got a long delay in the most immediate electrode above the line of block. And that really proves that there are concealed lines of block whenever you have wavefront convergence. And as a matter of fact, this actually can explain multiple exit sites as well, because you're just capturing on either side of a line of block. So in this example here, you've got activation here, it exits, you get a different pace map. In this portion, it actually re-enters because you've got a long latency as if it's the entrance of the VT. And when we've mapped pace maps and done an activation map of the pace map, it actually looks very similar to VT. In this example here, you're pacing the lower poles, you exit out, you get a different QRS morphology, and this component here actually reemerges as the entrance site, which is early diastolic. So this is really beautiful, and this is all fixed lines of block that are masked by the wavefront. And more importantly, you can see that you get a change in the VT morphology from right bundle to left bundle. So the line of block is the new unifying mechanism that underlies everything that we've been looking for. Isolated late potentials, fractionated electrograms, split electrograms, lava, pace maps with long latency, with multiple exit sites. It's all due to relative capture or to relative collision next to a wavefront, that discontinuity that is a line of block. So this finally explains why we have all these different names for abnormal electrograms, but what we should be looking for is just a line of block in sinus rhythm, which is further evidence that these VT circuits are fixed. So then we can change our whole approach to find a line of block and burn around the boundaries. These are the boundaries in this VT circuit, in this VT patient, and you've got 3 specific VTs, and they all are revolving and rotating around these lines of block as if there is a predestined fixed maze that is already there, and it's going to use this obstacle course. And for us, if we just burn around the lines of block, we might be able to eliminate these VTs. One final example is a 61-year-old woman with this very significant intraseptal mid-myocardial stripe that's actually transmural in some components and extends to the basal anterior septal aspects and the anterior wall of the LV, which almost shares across from the RVOT. This woman had recurrent slow VTs. And what we did was we actually mapped this patient and had 2 distinct VTs, right bundle, inferior axis, left bundle, superior axis. These could not be more opposite VTs for the same given patient. What we see here is that epicardial mapping shows a break and wrap pattern, and then there's a disappearing act, which tells you there must be activation that continues below the surface. Then we look at VT number 2, and you see you have a break and wrap pattern, but it's going in the exact opposite 180-degree flip. So this is a really beautiful example of a shared VT isthmus, and the red line is the LAD. So this is this anterior septal stripe and the scar in a woman that actually has been recently diagnosed with sarcoid. And this is an intramural line of block that then dictates VT that has one side of the hourglass on the LV and the other side of the hourglass on the RV. And these VT exits can be very misleading, but they're actually quite shared by one line of block. And these are mid-myocardial layer in this specific incidence. This line of block, when you're across here in a baseline rhythm, does not appear to be widely split. You don't have a wide split, but when you focus on the electrograms on this Tridica catheter, you see you have one near field component at the beginning of QRS, and you have the other component. So even though one electrogram doesn't have split, your linear catheter shows you that you have 2 populations that are on both sides of this line. And in matter of fact, you do see that there's wavefront deceleration, and that's important. But if you were to actually then have a left-sided wavefront, and here you can see a different morphology, you do get split electrograms. And this shows you that you can unmask a true line of block because this is a better wavefront to assess this line of block. Here you've got population number 1 and population number 2, which is beautiful for the VT circuit, which we've already seen. And when you see this break and wrap pattern, we look at the electrograms and you see that this is the area of mid-diastolic activation that is missing. You've got entrance and early isthmus in yellow. You've got exit there in purple, and you're missing the next components, which are green, light blue, and dark blue, because they reside below the epicardial surface. We actually did do endocardial mapping in this case, and we did not find those components either, which really is the proof of a mid-myocardial isthmus. How do you know that the wrap pattern is actually the entrance? Well, here is entrainment at the yellow region here, which is really codified as the proximal isthmus. And here you can see from this component here during VT, where you have separation of presystolic and early diastolic, you actually have perfect concealed entrainment at this site. And when you reverse the VT, we can demonstrate the same activation gap because this is all the mid-myocardial layers. And then there becomes the exit, and the other side is the entrance. One pulse field application using the novel field medical technology actually was able to terminate VT number 2, which was the left bundaloid morphology. And then we went on to continue to do multiple pulses in this direction here. And we did it at the exit site, which is the reemergence site for VT2. And then we pulsed on the other side of the line of block. And this was our final lesion set. So we're doing ablation on both sides of the line of block, which renders the VTs non-inducible. And when we find and look for these fixed isthmus boundaries with differential pacing, we could increase the number of fixed boundaries we find to 74% as proven to be fixed lines of block. And of course, potentially the other 26, yes, maybe functional, maybe less than 20 milliseconds, or may be residing within the mid-myocardial layer. And that is very relevant because we're not expected to find 100% of fixed boundaries from the surface that we mapped. So the new game is find the line of block and ablate on both sides of the line of block. How wide? Maybe about 2 centimeters, because we've done the analysis and these VTs typically reemerge within 2 centimeters of the line. And in a 2D boundary, it's nothing more than an incisional flutter. In a 3D boundary, it goes below the surface and reemerges, and you've got exit on one side or the other. Thank you very much for your attention.
Thank you so much. We'll be starting the next session. As chairperson, I would like to invite on the dais Dr. Prakash Chandra Mondol. Would like to invite Dr. R.D. Yadve on the dais, Dr. Kumar Narayanan on the dais, Dr. Milan Kumar Gadei, and Dr. Rajesh Badani.
I think this session will be on translational session, genetics and arrhythmia. And first talk will be on interpretation of clinical genetic testing in arrhythmia patients. I think this will be on online talk by Dr. Andrew Karn. Is he online? Oh, Dikshit will talk first. Okay. That means there is second in order, that is arrhythmogenic mitral valve prolapse, an unusual cause of sudden cardiac death. It will be by Dr. Sanjay Dikshit. Dr. Dikshit, welcome for your second talk. I think you can start now.
Okay, great. Are you guys able to see my slides?
Yes.
Great, thank you. So hello again. So this is the topic that Suchit asked me to speak on. And so, you'll hear more about the different kinds of atypical reasons for sudden cardiac death. And one of the entities that has caught our attention more recently is this arrhythmogenic mitral valve prolapse. And as the topic says, and it's correct, this is an unusual cause of sudden cardiac death. So just to put it in perspective, you're all very familiar with this concept. Typically during systole, the mitral valve is supposed to, protrude towards the left atrium. And then the concept of mitral valve prolapse itself, it's a very well-known entity since the 1960s when it was first identified by Dr. Barlow and colleagues, where more than 2 millimeter projection beyond this longitudinal annular axis, which is dropped from the aortic root down to the posterior AV groove. In this orientation, if the leaflets protrude more than 2 millimeters, that's considered mitral valve prolapse. And oftentimes, patients who demonstrate mitral valve prolapse have other features such as morphofunctional abnormalities of the mitral valve, the concept of mitral annular disjunction, we'll talk about that, as well as sometimes abnormal systolic movement of this aspect of the mitral valve, which is often labeled as systolic curling. Now, it's important to recognize that the presence of mitral valve prolapse per se in the general population is somewhere in the order of 2 to 3%. If you use more stringent criteria, like in the European guidelines, where you actually look at the point of cooptation protruding and not just mitral leaflets, then the prevalence of MVP is even lower. And it's also equally important to point out that within these patients, the incidence of arrhythmogenic variants or the incidence of life-threatening ventricular arrhythmias and sudden cardiac death is even lower. So somewhere in the order of 0.2 to 0.4% per year. So really this is an uncommon cause for sudden cardiac death. Nevertheless, it's something that is worth paying attention to in terms of, how do you go about recognizing this? So even when mitral valve prolapse was first described in the 1960s, there was an arrhythmogenic variant that was identified. And then more recently, this concept of malignant arrhythmic MVP has kind of caught our attention. So when you think about a patient with mitral valve prolapse who could potentially be at a risk for arrhythmogenic outcomes, it's usually a female patient with a very manifest bileaflet myxomatous degeneration who also manifests some other features that can be associated with arrhythmogenicity, such as repolarization abnormalities in the inferior and lateral leads on the 12-lead ECG. And if you provide monitors to these patients, then you will be not surprised to notice variation of PVCs, non-sustained VT. And if you get a 12 lead of the PVCs or the non-sustained VT, they have a right bundle branch block morphology, suggesting that it's coming from the left ventricle. And if you go further into the analysis of the ECG, those PVCs often have the morphological features that suggest that it's coming from the papillary muscle. So those are some of the things that are associated with the prototypical arrhythmogenic mitral valve prolapse. Now, it's been recognized that if there's a high degree of regurgitation in prolapsing mitral valves, that too has been associated with sudden cardiac death. So when you think about what causes ventricular arrhythmias, and especially the life-threatening ones in patients with mitral valve prolapse, it's sort of multifactorial. So there are clearly factors related to the valve itself, such as the elongated or hypermobile leaflets, together with mitral annular dilatation or disjunction, and we'll talk about this entity in a second. And certainly if there's chordal rupture, that's the factors of the valve that can predispose these patients to arrhythmic events. There are also factors that are related to the left ventricle, and some of them are just mechanical. If there is a prolapsing ventricle, prolapsing leaflet, there's papillary muscle traction. If there's papillary muscle traction, there can be mechanical effects on the ventricular substrate that it's attached to. If the cord is ruptured, you can sometimes get friction lesions. There are also certain changes that happen in the ventricle in patients with mitral valve prolapse, myxoid changes, myocardial ischemia, localized fibrosis. Those can be the setup for re-entrant arrhythmias. And then sometimes these patients have other repolarization abnormalities, including QT prolongation. And then in that mix is this other sort of, global abnormality in the patient. Sometimes these patients have underlying cardiomyopathy, which is an independent risk factor for sudden cardiac death. But when it's coupled with mitral valve prolapse, it perhaps gets enhanced. Autonomic dysfunction is something that can sometimes be seen in these patients, as can be conduction system abnormality. So there are a variety of factors that can predispose these patients to developing ventricular arrhythmias. So this concept of mitral annular disjunction is something that's also important to recognize, and it's typically described as an abnormal atrial displacement of the hinge point of the valve away from the ventricular myocardium. And it's pretty apparent when it happens on this parasternal view. You can see that this is the hinge point of the mitral valve, and you can see the degree of separation that's demonstrated in this fixed image from the ventricular myocardium. MRI is also very good at identifying this. So here are two examples. Panel A is a person without mitral annular disjunction. We can see the mitral valve and the ventricular myocardium are continuous. And this is a patient with mitral annular disjunction. We can see a clear separation between the hinge point of the mitral valve and the ventricular myocardium. Now, why is this entity important? So it was recognized as one of the conditions in patients with or without mitral valve prolapse where you can have the occurrence of life-threatening ventricular arrhythmias. And the largest series on this entity was put together through this experience, I believe, from Iceland, where they identified 116 patients with mitral annular disjunction. And the goal of this study was to identify factors that predispose these patients to developing life-threatening ventricular arrhythmia. So it's not a surprise that the majority of patients who had mitral annular disjunction also had mitral valve prolapse. So there was a minority where the disjunction was without prolapse. And when these investigators looked at the different factors that were predisposing these patients to ventricular tachycardia or cardiac arrest, what they found is that patients with severe arrhythmic events within this cohort were typically younger, had lower ejection fractions, and more frequent papillary muscle fibrosis identified by MRI. Interestingly, presence or absence of mitral valve prolapse was not associated with severe arrhythmic events in this population. So, when you think about these patients and you're confronted with this situation, what are the parameters that you can use or guide risk stratification? So, we talked a little bit about the ECG. The typical things that you look for in this patient population are repolarization abnormalities such as T-wave inversion, QT dispersion, and prolongation, oftentimes in the inferior and lateral leads. If these patients are monitored, which I think is not a bad strategy to begin to identify risk factors, you may often find multiform PVCs, non-sustained VT. And interestingly, the non-sustained VT and PVCs, while they definitely manifest a right bundle branch block morphology and features we'll talk in just a little bit about suggesting why they are coming from the papillary muscles, about 70% of these patients can have more than one morphology, including ventricular tachycardia manifesting features consistent with outflow tract region. One of the thoughts is that when you have mitral valve prolapse, there is this traction on the mitral annular apparatus, which can then cause PVCs even from the outflow tract region. Echocardiography can be helpful for recognizing some of the motion abnormalities that I pointed to, mitral annular disjunction, of course. And then, of course, another entity that's been found to be somewhat predictive of arrhythmic events is mechanical dispersion, which echocardiography can provide you information on. Cardiac MRI is very useful, especially if you identify fibrosis in and around the papillary muscles. That is sometimes a predictor of arrhythmic events. EP study really has not been found to have any role for risk stratification of these patients. So if you bring them in the EP lab, that's really without too much justification. If you induce an arrhythmia, you may compel yourself to put an ICD, but the value of this approach has not been shown in studies. Now, how do you reduce the risk of sudden cardiac death in patients with mitral valve prolapse or mitral annular disjunction? So, lifestyle modifications. Certainly, if you have competitive athletes that have mitral valve prolapse with manifest regurgitation and ventricular arrhythmias, it's worth cautioning them to modify their physical activity level. Beta blockers have been used. There's really no randomized study, just sort of observational experiences. So at the very least, they don't cause any harm, and they may cause some good. They reduce the PVC burden. ICDs are typically utilized primarily for secondary prevention in patients who have had arrhythmic events and have been resuscitated from them. In that population, ICDs may have some value. But at this point, we don't have any data to support primary prevention in this population. There certainly has been this experience with fixing the valve, and in patients with manifest regurgitation, mitral valve repair can reduce ventricular arrhythmias. And then there's growing interest in targeting the PVCs. So catheter ablation of ventricular arrhythmias is something that's becoming increasingly popular in trying to reduce the risk of sudden cardiac death. So catheter ablation, of these ventricular arrhythmias, again, is guided primarily by our experience that we've developed with targeting papillary muscle ventricular arrhythmias. And for some of you who may have been doing this for a few years, like myself, papillary muscle ventricular arrhythmias typically were one of the more challenging PVC ablations in the era before ICE, and I'll show you why. But usually patients who manifest PVCs coming from the left ventricular papillary muscles share certain features. So usually these PVCs have a right bundle branch block morphology, and because they come from the mid cavity, they demonstrate a precordial transition pattern. The features of papillary muscle PVCs from the anterolateral LV papillary muscle, typically an inferior axis, but discordant forces in leads 2 and 3. And oftentimes leads 1 and AVL will be negative for this location. In comparison, for the posteromedial papillary muscle PVCs, they usually manifest superior axis because it's coming from the posterior medial aspect of the inferior aspect of the left ventricle and positive forces in leads 1 and AVL. So getting back to our experience with catheter ablation. So this is one of the papers from 2010 where Dr. Neil Kay and his colleagues looked at long-term outcome of papillary muscle ablation guided primarily by electroanatomic mapping. And in that experience, the single procedure efficacy in this relatively small series was somewhere in the order of 40%. And this here is a compilation of the PEN experience with papillary muscle PVC ablation. You can see that our outcome were somewhat comparable to what Dr. K reported up until 2010. And these were, again, like I said, one of the more challenging PVCs to ablate. However, with the advent of ICE, we saw an uptick in our success. And this is why we feel ICE has certainly helped us, because with ICE, you can really localize your catheter to different aspects of the papillary muscle. And using that approach, we recently published our experience with papillary muscle PVC ablation with overall success rates in the more contemporary period, somewhere in the ballpark of 85 to 90%. So nowadays, with the use of ICE imaging, we have done pretty well in targeting these arrhythmias. And that's something that we advocate, that if you have a patient typically PVCs are felt to be arrhythmias that trigger the more life-threatening situations. And so there is value in targeting that. And so to summarize, arrhythmogenic mitral valve prolapse is, once again, a very uncommon cause of sudden cardiac death. There are certain risk factors for arrhythmogenic mitral valve prolapse that one has to be mindful of, such as morphofunctional valve changes, left ventricular abnormalities, together with certain patient demographics, such as age and sex, and certainly there's underlying cardiomyopathy that enhances the risk. However, at this point in time, other than these factors, we really don't have any invasive ways to truly identify the risk factors. And then treatment of this condition includes, trial of beta blockers. If there is very manifest regurgitation, then mitral valve surgery. And for patients who manifest papillary muscle ventricular arrhythmias, the current experience with targeting these in the era of ICE-guided ablation is, in our experience, really good, somewhere in the ballpark of 85 to 90%. And then ICD therapy, again, is considered more for secondary prevention. I'm going to stop here and
excellent talk, sir. Excellent exposition of the mitral valve, arrhythmogenic mitral valve prolapse. Really enjoyed it. Why not primary prophylaxis if you have ECG abnormalities of T inversion in inferior leads, along with, say, PVC of RBBB and your left axis deviation and your RNSVT in, and you get MRI done, so this scar in the papillary muscle. Why not to put ICD as a primary prophylaxis?
Right. No, I think that's not an unreasonable approach. It's just the value of ICD in that population. You just don't have the cumulative experience to say yes or no. I think if you get very stringent with what do we know about ICD outcomes. So typically, if they say that, your EF is preserved, then even if you go back to some of the very early data with ICD in the AVID population, where patients with healed infarcts were getting these, an EF of 35% or higher is typically predictive of not much value to the ICD preventing bad outcomes. So you could make the contrarian argument that yes, you may have all these other features, but if their EF is preserved, these patients should do well with ventricular arrhythmia events. It's just that the timeline of predicting ventricular arrhythmia is unclear. But could you justify an ICD? Absolutely.
Another thing is that papillary muscle VPCs can lead to VF rather than monomorphic sustained VT. So I think it's if these criteria are there, ECG, Holter, as well as the MRI, we can put ICD. Any question? Yes,
No.
from the audience there.
Let me just make one point there, though,
Yes.
and I think your point is very well taken. I also want to just mention this, and because there is lack of evidence, in the most updated guidelines on management of sudden cardiac death, even in the European guidelines, which were just updated a couple of years ago, this entity has really not been identified as a separate category for understanding and then treating in terms of prophylactic ICD implants. So we just don't have the data. But can you do it? Yes.
Another question, do you think without surgery, say MITA clip can reduce the arrhythmic death risk?
Well, it certainly can alter one aspect of the contributing risk.
One
right?
is
So we
MR is
talked about
decreased, but whether that will lead to decrease in the ventricular arrhythmia? The post-surgically, yes, but what about the MITA clip?
I think there is no evidence till now.
Well, there's evidence, but I think to his point that, there are different aspects of why ventricular arrhythmias happen. So if there's friction, if there's traction, and if the mitral clip reduces that, then you're at least taking one aspect of the risk factor contribution out of the equation. So it's possible it may help.
Sir, is this mitral annular disjunction is progressive or a static phenomena? If you see it, suppose is it at the 10 years of age or 15 years of age or 20 years of age, will it progress or it remains same?
An excellent question. That's an excellent question. I think if it's mitral annular disjunction by itself, that's an anatomical defect. If the mitral valve prolapse is part of the mitral annular disjunction, there may be some progression because of how the prolapse is causing that atrial hinge point to shift further. But if there's mitral annular disjunction alone, it should not progress.
Then early repair should halt it? Early repair of this prolapse, suppose surgical repair or by clip, it should reduce the progression then?
Yeah, depending on how you're doing it. So if there is regurgitation, then there are separate criteria for targeting it. But if you go back and look at that cohort of 116 patients, there the ventricular arrhythmia burden was not dependent on presence or absence of mitral valve prolapse. So,
another question from the audience, Dr.
Sanjay, Ashish here.
Ashish Nabar.
Now, is there any recommendation how you evaluate the risk year on year? Whether you are supposed to do the 7-day loop recorders or something like that, external loop recorders, I mean, on some kind of some kind of a year-on-year basis or whatever, because these are low-risk guys with some PVCs, and most of them will be like that. So how do you year-on-year evaluate in addition to the echo features?
Yeah, no, I think that's a good question, Ashish. My approach for these patients is again to just validate their arrhythmia burden together with imaging studies. I actually use cardiac MRI annually because that will provide you both functional information on the valve apparatus together with evidence of progression in fibrosis. It's also a better way to quantify mitral annular disjunction more objectively. Annual MRIs together with functional assessment of the valve, as well as once or twice a year Holter monitors, so these 14-day monitors.
Papillary muscle VT ablation by your RF success rate is quite low, as you shown me by the Neil K group as well as your pain group also. So then the concept came that it should be ablated by the cryo, so that it does not move. Cryo once get freezed, you can give lesion and adequate lesion, so movement will not be there as happens with the as happens with the RF catheter.
Yeah, so the reason I showed you those two slides is that our early experience when we didn't have ICE imaging At that point, the success rate of RF ablation was not very good. But once we started using eyes, you can really understand and create the anatomy of the papillary muscle and position your ablation catheter on different aspects. Now, when you do that with RF ablation in our most recent, single center experience, the success rate for RF ablation, not cryo, is about 90%. And the reason for that is because once you see where your catheter is on the papillary muscle, you can really dial up energy, right? So previously, the way we would do RF ablation is like traditionally, you go with 20 watts, 30 watts, you dial up power. But when you're ablating papillary muscle PVCs, your catheter is touching the muscle from beat to beat. It's not like it's there all the time. So now when we have eyes showing us where the catheter tip is, oftentimes I'll start power with a cool tip catheter at 45 or 50 watts and keep it there for like 3 minutes because I know I'm not damaging the muscle. I'm literally getting like 1 to 2 grams of contact force. But if I have high power there, just like you use high power for AF ablation, even if the catheter touches there every 20 seconds, that's enough to get rid of the PVC. So I would say that since we've started using this strategy, we have not used cryoablation. And mind you, cryoablation catheter is not an easy catheter to manipulate. I mean, you may get there, you may keep it stuck there, but to get to different aspects of the papillary muscle is not as easily done with that catheter. So no, we just use RF ablation.
Thank you, sir. Excellent, excellent demonstration of managing this complex arrhythmia. Thank you, sir.
So now I can.
Congratulations, and hope you have a great meeting. Yeah.
Thank you.
We should go to the next presentation by Dr. Arshad Jahangir.
Yeah, of course, but before that, I just want to request Dr. Ajay Naik to get on the stage and make the glory of our stage as a chairperson. I requesting Dr. Ajay Naik sir to get on the stage and take the chairperson seat, and that will make the glory more of this stage. So moving to the next presentation.
Next talk will be on understanding management of long QT syndrome and catecholaminergic polymorphic ventricular tachycardia, a mechanism-based approach, and presenter is Dr. Arshad Jahangir. I think he is online.
The organizers for their kind invitation to for the topic assigned to me is understanding management of long QT syndrome and CPVT, a mechanism-based approach. No disclosures. Cardiac arrhythmogenesis results from an abnormal substrate, and for these two conditions we are discussing today, it's an abnormal substrate in the repolarizing or depolarizing current that results in prolonged repolarization. For the long QT syndrome and calcium handling with primarily abnormality of ryanodine receptor or the calcium release channel for CPVT. The substrate is stable at baseline, but in the presence of triggers or modulators such as adrenergic stress, it becomes unstable and could result in early after depolarization or delayed after depolarization that can cause triggered activity, or due to the transmural dispersion of refractoriness actually results in reentry, causing ventricular tachycardia or ventricular fibrillation, causing syncope or sudden cardiac death. If the arrhythmia self-terminates, it results in syncope. If it persists, could lead to sudden cardiac arrest or sudden cardiac death. The long QT syndrome is a heterogeneous group of disorders characterized by prolonged ventricular repolarization in structurally normal heart with high risk of malignant ventricular arrhythmias resulting in syncope and sudden death. You can see PVCs arising, probably surrogate of the early after depolarization and the polymorphic VT. It's the most common inherited arrhythmia syndrome, 1 in 2,000 live birth, with 17 genes as identified as causative. Majority are autosomal dominant, rare autosomal recessive forms associated with deafness. More than 90% of all genotype long QT syndromes are the first 3 described one in the 2 potassium channel and the sodium channel. Long QT1 is due to loss of function in the slowly activating component of the delayed rectifier, the IKS channel. This is the most frequently identified long QT syndrome. then the loss of function in IKR causes long QT2, or gain of function in the sodium channel causes the long QT3 in 5 to 10% of genotype cases. The others cumulatively are less than 5%. The main pathophysiology behind prolongation of QT is either decrease in outward current in the most common form of the long QT with mutation in IKS or IKR, or gain of function more commonly in sodium channel and rarely in calcium channel, prolonging the action potential and the QT interval. The acquired form of long QT could result from potassium channel blockers, results in electrolyte disturbances or autoantibodies against these channels, presence of cytokines, myocardial injury, or can cause acquired form of long QT. The basic mechanism and target for intervention are summarized on this slide. There is an underlying channel mutation or presence of this acquired form, reducing repolarizing current or increasing depolarizing current, depending on the type of mutation. Action potential duration is prolonged, and in the presence of triggers could result in early after depolarization that can generate a PVC, and because of the transmural dispersion of repolarization could result in reentry or triggered activity promoting torsades point, as illustrated here with catecholamine stress, prolongation of repolarization, EAD, and triggered activity, which can result in syncope or sudden cardiac arrest. So what are the electrophysiological alterations that predispose to torsades point? It's prolonged repolarization, dispersion of repolarization early after depolarization, and reentry. And these could be triggered by adrenergic stress, startle response, or other triggers that were listed in the previous slide. On EKG, these parameters could be assessed by the QT interval. The transmural dispersion could be assessed by the interval between the peak of the T wave and the end of the T wave. And early after depolarization surrogate could be the ratio of the second component to the first component of the T waves. And based on that, some of the mechanism how these medicines work have been identified. The antiarrhythmic approach is to target the vulnerable parameter, which is the action potential duration prolongation. So shortening that is the approach, or reducing the transmural dispersion of refractoriness, suppressing early after depolarization, or avoiding or countering the effect of triggers. And if the arrhythmia occurs, early termination is helpful, especially in medication refractory cases. So how this could be accomplished is by shortening the action potential by increasing heart rate in non-IKS dependent mutation. Pacing is one way to shorten it. Mexiletine with a class 1B sodium channel blocker can also shorten action potential. Potassium channel openers can shorten action potential. But the mainstay of treatment are the antiadrenergic approaches with beta blockers and left cardiac sympathetic denervation. Magnesium, especially low potassium, inhibits IKR current, so that could also contribute to prolongation and proarrhythmias. So maintaining regular electrolytes is important. ICD in medication refractory cases is life-saving, and it can terminate arrhythmias in this otherwise healthy hearts. Gene-specific and mutation-specific therapies are being tested, and genetic engineering probably will play a big role in future as these techniques are being investigated. So the current guideline is summarized on this slide that lists all the different presentation of the long QT with cardiac arrest, with syncope without treatment, or asymptomatic patient with or without known pathogenic mutation or QT prolongation, or an asymptomatic patient with known pathogenic mutation. For all of these, general recommendations are to avoid low potassium, magnesium, avoid QT prolonging medication, and genotype specific triggers for each of the common forms. There is no time to discuss those in detail. Beta blocker are the mainstay, whether class 1 or class 2A, everyone gets a beta blocker. Nerolol is the preferred beta blocker, but propranolol also is effective compared to other beta blockers. Sodium channel mutations may respond to mexiletine, and this responsiveness is also dependent on a specific mutation. And a lot of work has been done, and further more individualized therapies could be streamlined as more data is being collected. In patients with cardiac arrest, ICD implantation is a class 1 indication. Those patients who have arrhythmogenic syncope on treatment or who cannot tolerate treatment, sympathetic denervation, left sympathetic denervation, and ICD implantation have a class 2A indication. In high-risk patient, ICD implantation and sympathetic denervation have an indication. Recurrent syncope, QTC more than 500, or particular genotypes have higher risk, are the high-risk features that requires advanced therapy. So how does the beta blocker work? Let's just review how the cardiac repolarization and the 2 potassium channel participate in repolarization. At slower heart rate, both IKR and IKS that has a slower deactivation contribute to the repolarization. But at faster heart rate, because of incomplete deactivation of the IKS channel, more potassium current flows out. Even if the IKR is blocked, as we see with some of the potassium channel blocker, the IKS can contribute to repolarization and shortening of action potential. So at faster heart rate, more IKS contribution to repolarization and the rate-dependent shortening of cardiac action potential is due to this channel. If there is loss of function of this, then there is maladaptive repolarization response at faster heart rate, with paradoxical prolongation of action potential duration with exercise or catecholamines. Increased transmural dispersion can result in EAD and torsades point type of situation. And what we see with IKS mutation is that the main events are during exercise or catecholamine type of conditions with higher catecholamine state. IKR also can result from startle response, auditory response that can result in sudden acceleration of heart rate and change in autonomic that can result in arrhythmia syndrome. And if you look at the effect of isoproterenol on action potential, it shortens action potential. Mainly the effect is on IKS shown in red here. There is no significant effect on IK1 and IKR. So there was a sympathetically driven shortening of action potential is also mediated through IKS. So loss of function of IKS could result in this prolongation of QTC and the proarrhythmic stress that can result in reactivation of invert current and causing EADs and triggered arrhythmias. And that explains the effectiveness of beta blocker or left cardiac sympathetic denervation, which is highly effective in patients with long QT type 1 with mainly the sympathetically driven type of potassium channel defect, a little less effective in IKR and SCN5A type of mutation, but still has a role to play in these patients. However, the residual events are higher in these other 2 mutations compared to long QT1. The good thing is that the syncopal episode do precede a cardiac arrest in patient receiving beta blockers, and advanced therapies could be implemented to prevent sudden cardiac arrest. How does beta blockade work? These are some elegant work done a while ago, but very relevant on QT interval and transmural dispersion, sympathetic stimulation in long QT type 1 patients. The QTC prolongs with epinephrine, but the major effect is on the transmural dispersion. You can see how it prolongs, and the oral propranolol in these patients had a little effect on resting QTC, but reduced the transmural dispersion, but more importantly, reduced the effect of epinephrine, prolonging the QT further and the transmural dispersion. Similar effect is also described for long QT type 2 patients where epinephrine has effect on transmural dispersion and QT prolongation. With propranolol use, baseline QT is not much affected, but the transmural dispersion is reduced, as you can see here, and that is how these drugs help reduce arrhythmogenesis. Now, a recent study Another elegant study in long QT type 2 patients shows that abrupt prolongation of dispersion and EADs could be reduced by the beta blocker use. The solid line shows that at faster heart rate, the beta blocker do reduce the QT prolongation. But more importantly, the transmural dispersion, as you can see, at faster or abrupt change in heart rate that occurs with the startle response is reduced by the beta blocker, as you can see, broken line and the solid line over here. And the EAD, the surrogate for that, the second component of the T waves versus the first component, you can see that ratio is also reversed by beta blocker, suggesting the mechanism how these beta blocker can help reduce arrhythmogenesis in these patients. What about the sodium channel blocker? Sodium channel defect, the loss of inactivation of the sodium channel causes the late sodium current, causing QT action potential duration and QT prolongation. And that can result in reactivation or persistent of late sodium current. And mexiletine, as you can see here, has more effect on the late sodium current, inhibiting that compared to the peak current. Both with a tonic and use-dependent blocker, it's an effective medicine that helps reduce the action potential duration. However, this effect depends on specific mutation. This is the original study by Peter Schwartz that showed the effect was most prominent in long QT3 patient, but also some effect in other long QT2. A more recent study also shows this effect in reducing arrhythmogenic event, also in type 2 long QT patient. So in the few minutes left, let me just quickly go over CPVT. It's a heritable disorder, catecholamine-induced ventricular arrhythmias in the absence of structural heart disease or ischemia. Normal resting ECG characterized by recurrent syncope induced by physical or emotional stress, mainly related to DAD or triggered activity. Less common, familial in 1/3 of the cases, and autosomal dominant, mainly due to ryanodine receptor gain of function type of mutation. Also, autosomal recessive forms are fine. Most are de novo mutations. This is the original study by Philip Kummel, showed that there's a heart rate increase in PVCs, and the complexity of this arrhythmias increases as the heart rate increases with exercise, with bidirectional VT and polymorphic VT. And as the exercise is reduced, heart rate reduced, the rhythm it goes back to normal. Isoproterenol reproduces these effects. The main pathology is the calcium-induced calcium release through sarcoplasmic reticulum is normally happens during systole. During diastole, the channel is closed. If the channel is mutated, either the channel itself is regulatory proteins or the storage calcium protein, it results in a leaky current. And during diastole, the calcium leaks, resulting in delayed after depolarization, which can result in a triggered activity, PVCs and VT, especially during exercise or catecholamine stress. As the heart rate increases, you see more and more of these DAD and extra beats. So what is the target for this? So the main trigger is the beta adrenergic receptor. So blocking the beta receptor with natalol or propranolol is effective in a number of patients. Calcium channel blockers could have a role, especially verapamil that has some ryanodine receptor effect also. But the other main target is the ryanodine receptor inhibition by flecainide, which is a potent inhibitor. Sodium channel blockers. Phenytoin is also described as inhibiting both flecainide and the effect on this arrhythmogenesis, ryanodine receptor stabilization. But the other impact is reducing the cardiac epinephrine release by lifestyle modification of reducing exercise and swimming that triggers these arrhythmias, or left cardiac sympathetic denervation. ICD has a role in terminating, but could be proarrhythmic and should be used with caution and with proper programming. PVC and VT ablation are the other targets. So the main targets for arrhythmogenesis become the adrenergic stress that need to be reduced, calcium overload, calcium release channel activity, DAD arrhythmogenic foci, and VT termination. And here is the guideline that is recommend beta blocker as class 1 or 2A indication, ICD implantation in those with cardiac arrest. Flecainide has a role in patients with symptomatic recurrences and sympathetic denervation. And I think I'm out of my time. I'll stop there. Thank you so much.
Glorifying our stage, and to all the presenter for presenting their best studies. Thank you so much. So we're moving to the next session, automatic function and arrhythmia. So our next session is automatic function and arrhythmia. So for this, I requesting Dr. Soumik Basu. Requesting Dr. Soumik Basu, Dr. Saroj Mandal, Dr. Saroj Mandal, Dr. Vasavaraj Sutar to be on stage as chairpersons. And also Dr. Veem Sankar and
Hello, Dr. Bhim Shankar? You have to go? Okay, okay. Then Dr. Kapil Kumawat and Dr. Raja Selvaraj. Chairperson.
So we'll start the session on autonomic function and arrhythmia. So we're already behind schedule. So let's start with the first talk by Satish Raj on interpretation of clinical autonomic function testing.
Thank you very much. Let me get my screen up here. Are you all able to see the screen properly, or have I messed
Yes,
up?
yeah, we can see the slides and we can hear you.
Wonderful. So this is a little different, and I want to congratulate you all. I've attended the last couple of talks, and they were great. Much more focused on acute electrophysiologic changes in death. And what I'm going to be talking about actually has less to do with death and more to do with the mundane problems of syncope and orthostatic tachycardia. And I was actually asked to sort of explain the physiology of interpreting autonomic testing, and I think that's a little in the weeds. And so what I tried to do is provide a broader overview of how detailed autonomic testing can actually be helpful in terms of the management of some of these common problems that come to clinic. So just by way of background, we in the autonomic world, we're living at the junction between the nervous system and cardiovascular control, right? So the patients that we see, for the most part, don't have a structural cardiac problem. They probably don't have a cardiac problem at all, but more and more, I think we're appreciating that regulation is a problem, and the nervous system is everywhere, including in the heart. And I think you're going to hear more about that in the other talks in this session. The disorders I'm dealing with are fundamentally gravitational, right? And we don't, really pay attention to standing most of the time because it works. We're able to do it, and no one thinks about it. But it's actually a fairly physiologically intense change in terms of the effects of gravity. Lots of fluid shifts, and quite frankly, if the nervous system weren't working robustly, we would all drop our pressures tremendously and have a syncopal episode. But that usually doesn't happen. In healthy people, there's minimal change in blood pressure, maybe a small change of a few millimeters of mercury. There's usually a small increase in heart rate, and no one really pays attention, and life is good. The problem is when this doesn't happen, and I think we're seeing this a fair bit, and you can see it more and more, and it's associated often with tachycardia, which is honestly the only reason why this often comes to cardiac electrophysiologists, because this isn't primarily an arrhythmia problem. Lightheadedness, often fatigue, there can be issues with blood pooling, and hypotension, right? So there's a broader cardiovascular remit than heart rate or arrhythmia alone. But the easiest thing to measure, and often the key hallmark that physiologic hallmark people will jump on, is heart rate or blood pressure. So I'll touch on two disorders, postural orthostatic tachycardia syndrome and vasovagal syncope, both quite common in many clinics. If there are questions about orthostatic hypotension, I'm certainly happy to address that, but I haven't, for time, I've left that out. So postural orthostatic tachycardia syndrome, or POTS, is a chronic form of orthostatic intolerance. I guess the important thing to really understand here is, regardless of why, and we don't fully understand all the mechanisms at play, very much so, these patients have a very poor quality of life. There have been multiple studies that have documented this in different jurisdictions, but we all appreciate that patients with end-stage heart failure, people with bad chronic lung disease, have a very poor quality of life, and these patients fit right in that group, along with end-stage renal disease, patients on hemodialysis. And it's not that uncommon. I mean, certainly it's not, 20, 30, 40% of the population, but it's probably in the range of 1 to 3% of the population. This is an estimate. These are all estimates, but these are estimates from pre-COVID, and it seems to have increased during COVID. And the demographic are typically young women of childbearing age, right? Overwhelmingly female, 90+% female, with a big onset starting around puberty, but the onset can happen into the 20s and 30s, not quite commonly. And the challenge is it's not due to a thing. It's actually an end phenotype with multiple possible causes. But we weren't asked to talk about that specifically. We were asked to talk about how the actual autonomic lab and autonomic testing might help. And the hallmark of it is a tilt table test. There's an example shown here. This is actually a patient not with POTS, but with orthostatic hypotension. You can see here that, with continuous blood pressure monitoring on the bottom channel, you can see the moment the table was tilted up, the blood pressure fell like a rock going off a cliff, and fell very low from 123 to 72 systolic pressure. And in patients with severe neurogenic orthostatic hypotension, the heart rate may not change at all, as you see here, right? So the point of this isn't to focus on the orthostatic hypotension, because that's not what I'm going to talk about, but just to point out that the key to a good tilt table test isn't just a table that tilts. The key to a good tilt table test is good physiologic monitoring. And at minimum, I think in terms of standard of care, really you want heart rate and you want continuous blood pressure, non-basic continuous blood pressure. An intermittent blood pressure cuff that you measure every 3 minutes is going to miss a lot of the key bits of information that you can get. Just when thinking about the POTS diagnostic criteria, we see tilt table traces from a POTS patient on the left and a healthy control subject on the right, age matched, heart rate channel on top, continuous blood pressure in the middle, and the tilt angle, just so you can see when the table was up at the bottom. The key things to note are that if you look at the control subject, the heart rate goes up with standing, right? This is physiologic. Orthostatic tachycardia is normal, it's healthy. The second thing is that POTS fundamentally isn't a hypotension disorder, right? If you look at the blood pressures, I think you could correctly look at the POTS blood pressure and say it looks different. Qualitatively, it's spikier, and that actually, I think, is actually quite important. But you can't look at the average blood pressure and say it's low. If anything, it's actually a tiny bit higher than the control blood pressure. And finally, if you look at the heart rate in the POTS patient, it goes up a lot, and it keeps going up. And in this patient, it was designed as a 30-minute tilt protocol. The patient told us to stop early, and the patient's heart rate was almost 180 beats per minute when she told us to stop. So POTS involves the increase in heart rate. It's excessive, defined as at least 30 beats per minute in adult patients without orthostatic hypotension. And importantly, it's not just physiology. These patients have to be symptomatic, with symptoms that are worse when they're upright and better when they're lying down. Those first three things all of us get in the setting of an acute viral infection. You can test it yourself the next time you get a bad cold or the flu. But the difference is that it goes away in most of us within a few days. In the POTS patients, it doesn't. I'm not going to go into detail on this, but just to point out, there are different approaches to treatment. So some approaches involve trying to take the edge off the heart rate. You have a lot of heart rate, we can lower it. You don't want to lower it too much, because that's often not the underlying problem, as we'll get into. But it can sometimes help with, using low doses of propranolol or ababardine. A mainstay of treatment are strategies to expand the blood volume. So increase in dietary salt and water, maybe using fludrocortisone or Florinef, maybe using desmopressin or DDAVP. The Florinef promotes sodium retention, the DDAVP can promote free water retention. And then vasoconstrictors and venoconstrictors like midodrine. But how do you decide when to use which? And this is, where autonomic testing may be, able to provide some added value, where you can actually get more detail on the mechanisms within an individual. We pay a lot of talk to personalized medicine and precision healthcare. And usually what people mean is we want to actually get genetic information. But the truth is, that hasn't worked out that well for all except the rare diseases, but there may be physiologic information that we can actually use to personalize care. So here we see a patient with excessive tachycardia. The channels are labeled: heart rate, blood pressure, stroke volume, cardiac output, SVR. These are all, so these advanced hemodynamics can all be estimated from waveforms and are available in almost real time with many of these systems. The tilt angle is on the bottom, and you can see when the table went up, the heart rate went up excessively. Here it was sitting at about 135 beats per minute from 75 beats per minute, almost immediately on standing. The blood pressure, started wobbling, but certainly didn't drop a lot. And then when we look at the advanced hemodynamics, what we see here is that the stroke volume fell tremendously. The vascular resistance, on the other hand, actually didn't go down at all. The vascular resistance went up a bit, but perhaps not enough, and then the heart rate had to compensate to maintain the blood pressure, right? So the fundamental problem here is one of, and if that's the case, one can make an argument that, treatments targeting the stroke volume, such as, volume expansion to try to increase cardiac preload, salt, water, compression of the lower body, may be the most effective approaches. Adding Florinef may be an effective approach. But that's not always the case. This is a patient, similar presentation, POTS, heart rate went up on standing. Heart rate was a little higher, I think, to begin with, and went up on standing. Again, blood pressure didn't drop. What we see here is the stroke volume did drop a little bit and recover, and overall, the stroke volume fell. The truth is, it falls in everyone when we stand up. It'll fall in you if we look at it, and if we were measuring it. That's the gravitational effect. But here, the problem is that the vascular resistance dropped a fair bit, unlike in the prior patient. And so the approaches here probably, this patient would probably benefit more from an approach targeting squish, something targeting the vascular resistance. And a drug like midodrine, which is a short-acting pressor agent, an alpha agonist, would do that. Right, so we have different treatments, and the different treatments target different mechanisms, and our autonomic testing can actually help us to figure out which mechanism is at play in the individual patient. But that's a POTS approach, and there's different things we can get into there. But one of the more common problems that I suspect you see is vasovagal syncope. Up here, I have a version of the old Sharpie-Schaefer model as to why people faint with vasovagal syncope. Often it occurs on standing. There's volume depletion. There's an increase in sympathetic tone. There's central baroreceptor activation. Magic happens in the brain, and ultimately, you get some combination of an increase in vagal tone that can lower heart rate and sympathetic withdrawal at the end. And I have in green and red different treatments that we use with various degrees of evidence. And the ones in green are actually very commonly used. The ones in red, less so now, for this. But again, how do you decide? Well, just a little bit of data. So my colleague, Bob Sheldon, has spent the last 20 plus years running a number of international clinical trials, multi-center trials for vasovagal syncope. It's in a family of trials called the Prevention of Syncope Trials, or POST. POST-2 was looking at fludrocortisone. You can see here that fludrocortisone certainly had a strong trend towards benefit in brown compared to the green in placebo. The hazard, the p-value was, hazard ratio suggested a 30% risk reduction, but the p-value was on the incorrect side of 0.05. This is probably a trial design issue. If you're a purist, it's negative. If you're not a purist, you'd point out that there were a lot of events early on, and we actually had a 2-week dosing phase to try and reach steady state. And if you actually blank or censor the 2 weeks, this was significant. And in fact, if you actually said, okay, who actually got to target dose? So this is an on-treatment analysis now. There was potential benefit, right? So pure trialist, it doesn't work. In the real world, you can certainly use this. How about mitidrin? Again, similar drugs that we used for POTS. This was the basis. I apologize, it says post 2. This is the post 4 trial. This was published in the Annals of Internal Medicine a few years ago. And this drug actually did significantly reduce the recurrence of syncope. It decreased the burden. If you had a little bit of syncope, you might have no syncope in the next year. It was a 1-year follow-up. If you had a lot of syncope, it decreased the burden. And pacing, has made a comeback. It was sort of gone away for a while, but with closed-loop stimulation pacing in particular, there are a couple of studies now. The Spain study is shown here, and then the BioSync 2 study that have both shown some benefit from pacing invasive vagal syncope. But how does autonomic testing help with that? Well, for one thing, in the pacing studies, actually, they only looked at patients with specific responses on tilt table test. So it became a critical issue. And when we do tilts on patients and they have a positive test, they can actually have very different positive tests. So the one that often shows up in textbooks looks something like what you see here. You have the ECG on top, and you can see there was a little bit of slowing and then a nice long asystolic pause, 17 seconds here. This always makes the textbooks because asystole looks nice and it's easy to capture. And obviously, if you don't have any beats, you don't have any blood pressure, and so you get hypotension as well. But what's driving it is really the lack of heart rate. We have treatments for that, pacemakers, and more recently, cardioneuroablation is rearing its head. I think Dr. Sunny Poe is going to talk more about where we are with that momentarily. But the more common response we see on tilt is actually one of vasodepression, right? So where if you look at the ECG and the heart rate, honestly, the heart rate falls a little at the end, but certainly isn't driving the hypotension. This hypotension you see on the second channel, the sudden drop in pressure, precedes any drop in heart rate. And so, strategies primarily targeting the heart rate would seem not to work. But again, we have different issues that we can look at in terms of stroke volume and vascular resistance, and we can use the guidance if we want to look at that, to argue which of these drugs that have been shown to work in a broader group might work in your specific patient. And those that have paid attention to the space will know that beta blockers were tested in the first post-prevention of syncope trial, and they didn't work. It was the most negative trial I've ever seen. The survival curves overlapped completely. And so they're considered class 3, both by the European Society of Cardiology as well as by the ACC, American Heart Association Heart Rhythm Society syncope statement from 2017. But is that always true? So if we look at this, again, in a big population, we just throw beta blockers at syncope patients, it absolutely is true. But one of the things that we see in our autonomic lab, not uncommonly in the POTS patients, is that while most POTS patients don't faint, some do, and often the mechanism is what you see here. They get really, really tachycardic. And at some point, probably not because of the heart rate, probably because of a critical drop in stroke volume, but at some point, that causes hemodynamic collapse, and the blood pressure falls, and they have a vasovagal reaction. And in these patients, actually preventing that really high increase in heart rate with beta blockers or with ababerdine does seem to be quite helpful. So it's another approach that may be evolving, but in a select group based on their personalized physiology that you can get out of autonomic testing. So I will stop, because I'm not sure how much time I have left, but I will say that orthostatic intolerance is common, but there are actually different underlying disorders. And even within each disorder, there are different underlying physiologies. And that's actually where an autonomic testing guided approach can actually allow us to individualize care. I've focused here just on head-up tilt testing for the sake of time, but if you actually are branching out into more detailed autonomic testing, and I know Dr. Chakraborty, who's going to be speaking later in the session, is on the verge of doing that, Other tests, including the Valsalva maneuver with continuous beat-to-beat monitoring, can actually sometimes give you clues as to why people are fainting, even when the hemodynamics are okay now. It can actually serve as a great autonomic stress test, if you will. With that, I will stop. Thank you.
Excellent talk, Dr. Satish. And this is often the most problematic thing we face in our outpatient department, and is still one of the most neglected field. We are still searching for the answers. Do you believe COVID has brought out more POTS and vasovagal has affected autonomic nervous system, or it is just that COVID gave opportunity for us to see all these things, all these patients?
I don't know if COVID has increased vasovagal syncope. Vasovagal syncope has always been, pretty common. But fainting once or twice in your life isn't actually pathology. That's probably physiology. Fainting, once a month is pathology, right? So it's a matter of degree. But as for POTS, it certainly has increased the prevalence. Well, at least the obvious prevalence of POTS, right? And I think it's two things have happened. One is even before COVID, the most common identified trigger among POTS patients was a viral infection. And what we had was a massive, a concatenation of viral infections that all occurred at the same time. And for the first time in my life, I knew what the name of my virus was. I live in Canada. I'm good for a viral infection once every winter, and then pre-COVID, I never knew what to call it. And so I think it galvanized attention in the public in a way that we haven't seen. So one, there was more virus, and two, there was more recognition because people started talking about POTS in the lay press, the New Yorker magazine, the Wall Street Journal. It wasn't just medical journals and articles that I write that no one reads. It was now things that everyone read, not with a lot of detail, and so more people started paying attention. So I think it's a combination of increased, actual illness and increased recognition of the illness that was already there.
Thank you. Any questions from the audience?
One question is, how do you do this continuous non-invasive BP monitoring? What kind of a device do you have to do that? I had heard of FinaPress, but I think it's not widely available. How do you do it?
Yeah, we typically do use a FinaPress Nova, right? There are a couple of different big companies that have monitors. FinaPress is probably the biggest one, and then there's a company called CN Systems out of Austria that has something called a task force monitor, and then there are a couple of smaller things. But basically, they both use some version of photoplethysmography, right? So it's basically a finger cuff that wraps around the finger, it fills the air up, and then it's sort of like a SAT monitor, except the volume is clamped, and so every time a pulsation comes through, you can get a waveform that looks like a peripheral arterial waveform. It has some artifact issues, but when I went to Vanderbilt for my fellowship about 20 years ago, a little over 20 years ago, they were still putting in arterial lines for their tilt tests. I will tell you that people don't come back for a second tilt test if you put an arterial line in. So it's much better tolerated, and it's sort of the standard of care now. So its availability is obviously there's a cost to it. A new machine is in the range of $50,000 US. So not a trivial cost. At the same time, we spend a lot more money than that in, one cath lab is, 20 of those or more, right? I mean, for a cheap one. So it's actually fairly readily available if we want it.
Okay, so we'll wrap up this talk. Thank you, Dr. Satish, once again, and over to the next speaker.
So the next talk we have Stéphane Massé talking on imaging cardiac electrophysiology and metabolism in the wet lab. So Stéphane is an engineer from Toronto who has more than 3 decades of experience with multiple mapping methods. Stéphane, over to you.
Yes, good morning. Thank you. Good evening, indeed. Thank you so much for inviting me. I'm very honored to be here to present on imaging cardiac electrophysiology and metabolism in the wet lab. I'm going to share my slide. Just one moment. Okay. Sorry about this. Do you see my screen?
Yeah, we've got the slides.
Okay, so I want to introduce this concept about imaging cardiac electrophysiology and metabolism in a wet lab. So I have no disclosure to report, and it's my presentation outline. We're going to go quickly over an introduction about imaging in the wet lab. What is it and why do we need it? We'll go over some concept in cardiac imaging, and then we'll go over some application. It will present two different examples where cardiac imaging could be of use. We'll go over the various parameters that we can extract, both in time and spatial domain. Briefly, we'll touch on ADDH mapping or imaging, and then we'll just quickly review some future steps in cardiac imaging, and then we'll conclude. I need to make it clear to the audience, this is more a talk on methodology. So I'm not here to present any result on a specific study. Like Dr. Salvaraj mentioned, I've been involved in this field for a while. This will be more like an overview of the methodology. So it will be more a methodology type of talk than really dealing with results. So why imaging in the wet lab? So before I get into this, I want to just go back, because this is a translational session, from from cell to bedside. So if you don't mind, we'll start from the bedside. So in the cath lab, we do proceed with mapping processes where we map different parameters, but usually they're mostly consisting of either time or voltage. And this is the tool we have. So the only thing, though, is we know that this is not all the parameters that we would like to interrogate. There are other parameters that would be of interest. And to put this in perspective, we're going now back to the cell level. We know that there are, information that are very, useful. And one of them is the action potential, which is produced by various current going to the cell membrane. Now, how do we do this? So we have learned how to do this in the basic science lab. So in cell culture or tissue preparation. It is a very challenging process in terms of instrumentation because we're impaling a cell, a single cell. So this has to be done, either under microscope with care, no movements allowed. We can only record from one cell or maybe few cells. It's very difficult to do more than this. So that's why it's limited in use, and we cannot translate this obviously in the cath lab. There have been methods to approximate this in a cath lab. One of them is the monophasic action potential. So that is a good tool, but has its own problem as well. It's a single pole catheter, and it uses injury to produce the signal. So luckily, several years ago, researchers in neurophysiology discovered or created method to derive the action potential using fluorescence. So they had developed potentiometric dyes. So these are dyes that will produce fluorescence that are based on the transmembrane voltage. So what does this mean is that essentially a chemical that gets inside the membrane, and the fluorescence property will change depending on the transmembrane voltage. And this cartoon here shows how this works. So essentially, the characteristic of these dyes is such that the fluorescence spectra will shift depending on the transmembrane voltage. And as this shift is more or less linear, we can actually, with high fidelity, reproduce the action potential by measuring a change of fluorescence light. So this is very interesting because, as you recall, recording an action potential traditionally involves, a traumatic exercise where you actually get inside a cell. Now here we're not even touching the cell, so we're just using a chemical to elicit this phenomenon. So we excite the fluorescence using high power light, because of course the fluorescence is not a strong phenomena, so to get some readable data, we need to use a fair amount of light to excite the fluorescence, and then of course the fluorescence that gets emitted will also be relatively weak. So therefore, to capture this information, cameras were developed. I mean, following a photodiode that were originally used for the benefit of doing imaging, these cameras were developed. And these cameras, they're not the very similar type we get in other fields, like in photography or in regular video production. These cameras are designed to be very sensitive. We call here about quantum efficiency. So that is essentially the capacity to convert photons that are captured into electrical signal. And the frame rate, of course, has to be fast because if one wants to reconstruct an action potential, you do need a camera that is fast enough to do so. So these are some of the cameras that are available. And this is probably the high cost aspect of this technology, as these cameras are very specialized. So here we're going to go very briefly over two different applications that uses cardiac imaging. So we'll start from the cell level or the low-end level with engineered biowires. So this work has started with colleagues of us at UHN. These colleagues are into this field of regenerative medicine. So their intent is to create building blocks that one day may be used to regenerate diseased organ or replace organs that have been ablated. For doing these blocks, they have developed what I call them engineered tissue constructs. So these are essentially programmed cells from stem cells that have been programmed into different organs. So they do develop other organs than the heart. Of course, the ones that are interest to us are the ones who mimic the heart. So in other words, they are cardiomyocytes, and or the developer believe they're cardiomyocytes. So they do reach to us to assess them in terms of physiology, electrophysiology. They want to know if these are actually mimicking what the cardiomyocyte would do in real life. So we do this in a dish level. And here's a picture of a current setup. It uses a microscope. We don't need much magnification because we don't really work in this case in a cell level. We work more at the small tissue level. So this is actually a microscope. And it's actually fortuitous because since fluorescence is a very weak process, microscope has a large lens which allow more light to get into our sensor. This is an example. I hope the video is turning okay. Among other projects we have done with this collaborator, we have looked into the aspect of developing an arrhythmia into a biowire. So a biowire is a construct specially designed and actually made so that it could be mass-produced if you may. So it's a towards engineering process. And so we've been testing an arrhythmia model into one of these constructs. And indeed, we have found that we could actually recreate electrophysiological condition that you would see in the whole heart. Of course, this is a different context because it's a very small substrate, but we have seen in there that these were reacting to a pharmacological and electrical intervention. Now, moving a little bit higher towards the bedside, I'll show you now another example. And this is now a cardiac imaging on a isolated heart preparation. Now here we're doing a combined mapping. So we're using both voltage and calcium mapping at the same time. So this could be achievable by the use of some dyes that are compatible. Now, why are we doing calcium? And we have seen that in previous presentation. There are occasions where the ryanodine receptor leaks calcium into the cytosol. And this could be leading to arrhythmic condition. So for 10 years, we have been interested in studying the calcium cycling inside the cardiomyocyte. And we have developed a model where this cycling is altered. So to observe this cycling, we had to develop a method also to map or actually image the calcium waves in these conditions. So here we see a picture of our setup. It's a dual imaging setup. It employs the characteristics of dye that are compatible. So you could use the same light source to excite the both dyes that are loaded into the heart. And then these dye will emit fluorescence. And by use of dichroic mirror, you can actually get the light split up, the emission light split up, and then the two different cameras will get the image. A picture of our setup. So it's an elaborated system when you think about it, because you need, of course, with imaging, you have this information of mapping, but you also need a monitoring system, stimulation system, along with the complete Langendorf preparation. On the right, you see the light that is illuminating the heart, that gives it a glowy type of aspect. And as we have seen on the microscope, here again, to maximize light, very expensive optics have to be used, using very large lens, filters, and dichroic mirror. So once we get all this setup up and running and we run our protocol, we're interested in extracting parameters. So the challenge in there, in cardiac imaging, is now, it's a bit like what we have in a cath lab. You have a lot of information. Here we have basically every pixel is a signal. So the camera that has 200 by 200 pixels will produce 40,000 points. So the data cannot be analyzed manually. It has to be automated. Here's an example of some of the parameters we can actually measure. So we have mentioned about action potential before. So of course, the duration is one parameter we can measure. We can measure rise time. And then we can look into APD alternates. This is over time. So this is one measurement we could do of one signal over time. So these are the type of parameter we can extract with voltage. Now, with calcium, they are similar parameters. Calcium transient duration 50, 80, 90, that's same as APD. So a lot of these things are the same, time to peak. However, there's some that are very particular to calcium. One of them is the time constant, which is essentially fitting an exponential curve into the repole section. One aspect of calcium that's interesting is we could actually have a glimpse of the influence of different channels, such as NCX and CIRCA, depending where we're looking at the repole curve. In previous presentation, we have a discussion about EAD and DAD and calcium leak. Now here is a case of spontaneous calcium elevation. So this is something we also are extracting, detecting automatically. And that's, as we know, it could be arrhythmogenic. So we are detecting these things. Now, we said about APD, so APD alternates, we could also do, instead of duration alternates, we can also look at amplitude alternates. These could have physiological of interest. Here we have a workflow of a typical cardiac imaging system. So it's essentially 4 major steps. One is to the acquisition, the data acquisition itself. Second is data selection, quality control. Third one is parameter extraction. In our case, we use MATLAB code that usually is in a batch type of format, will high throughput process the signal and images, and will generate on number 4 the results, and we have them produced into Excel so we can analyze and produce statistics. So this was for the time domain. Now, the wonderful thing about cardiac imaging is not only we have information in time, but there's also spatial information, and it's also very high resolution. So not only we could produce the traditional map that we are using in the cath lab, such as isochronal map and vector field, we can also study VF with optical imaging. So and this is actually, this is actually how cardiac imaging came to birth. 26 years ago, Dr. Gray had used phase transform optical signal and used that to try to see the level of organization in VF. I know this sounds counterintuitive, but there are different type of VF and they have different type of organization. So we could actually trace out the rotors and or the wavelet, and then as we count them over a field of view, we could actually compare different conditions and make a statement about organization or difference of organization between these conditions. Now we have as well now, because this is in space, we can actually quantify spatial dispersion. So here we show a calcium transient amplitude. So we can actually look at how these alternates, either are they relatively uniform over the field of view, or are they spatially dispersed? Here, another example, and this is now with APD, spatial dispersions. On the top, you have, these are actual APD alternates maps. So
Stephen, sorry, we are running late. If you could conclude.
Yeah, I'm almost done. So just briefly here, the NADH could be also imaged using autofluorescence, so we don't need to use any dyes. So it's pretty nice. And very briefly, future step. So there is a push to go on entirely touchless, and that is to being able to develop method where you can actually stimulate the heart with light and record data with light, because this can open up room for high throughput methodology. So we can do drug testing by doing physiological assessment with optical mapping without needing any interaction with the plate. And one last thing on optogenetics, which is how we can actually modify cardiomyocytes. So then in this particular example, we can encode genes on the membrane so they will fluoresce as well. So we can actually have endogenous fluorescence without any dyes. This is very useful because it allows long-term study. And here's a quick slide where we show the advantage, disadvantage of cardiac imaging. We have gone over this solution, this methodology. We have shown that imaging is a powerful tool for investigating these mechanisms. And there's many applications for this, including drug studies, repolarization, VF. And this methodology could help translating new therapies approaches into clinical practice. So thank you so much for your attention.
Thank you, Stefan, for, it's a very powerful technique in the lab, which has obviously a wide range of applications in translational research. Due to shortage of time, we'll just take one question if there's anyone has a question from the floor. So I think you briefly mentioned this, Stefan. So I think the major limitation is going to be that this can only image something which light can reach. So it can only be one flat surface, right? So,
Correct.
So it's not going to be this.
Yeah. Right. So people have been doing using fiber optics, mapping the endocardium, but otherwise it would be too invasive. We would cut the ventricle and then expose the endocardium, and then it kind of defeats the purpose because then it becomes very, very invasive. So you're right, Dr. Salvaraj. Yeah, it's limited to visual contact.
Whatever can be seen. All right. Thank you very much, Stefan. So we'll move on to the next talk.
So I will. Okay. So we'll have a general body meeting of Indian Heart Rhythm Society, and we'll continue with the talks later.
I think I request all members to sign the paper. If you remember membership number, it is okay, but your name should be clearly readable and your phone number. I request Dr. Ullas and Vanita, both are not here. And as the quorum is also not complete, so we have to adjourn the meeting for 5 minutes and reconvene the meeting after 5 minutes. Meanwhile, I request one of the senior most EC member, Dr. Ashish Nabar, to chair this meeting and preside over the AGM. Ashish, you are Huh. Just we can reconvene after 5 minutes. I think 5 minutes are over. So if the President